Yeah. So interestingly, we got one immediate past president of ABSI, who is Professor Diptendra Sarkar. Everybody knows him very well. He's for the motion. So he's going to say that after positive sentinel lymph node, you must do a completion ALND. So that's his topic. And as I said, he's the immediate past president of ABSI. He's a consultant breast and endocrine surgeon of IPGMER in Kolkata. He's a GC member of ASI, an examiner of for MRCS, MS, and many other areas. I don't want to run through the whole CV. Same with another very eminent faculty, Professor Somasekhar. Interesting, like I said, he's the present president of ABSI. So he's between immediate past president and the present president that we're going to have the fight today. He's going to be talking against the motion. So he would try to insist or persuade us or convince us that you don't need to really do axillary lymph node dissection if the sentinel lymph node is positive. And he's the chairman and HOD Surgical Oncology, Manipal Hospital, Bangalore. He's a very eminent robotic surgeon. I think he has done the maximum robotic surgery in India, and he's author of many book chapters. And I am the referee. I'm a peace-loving guy, but I've been asked to be the referee between the two titans. So that's something I'm trying to do. And this is going to be my role today when they are fighting between themselves, and I'll be the one who's going to manage them so that the fight doesn't go out of hands. Very quickly, we know the incidence of cancer is increasing worldwide. The highest incidence of cancer in females, the highest cancer that we see in females is breast. That's true for India also. Even a few years back, it used to be cervical cancer, but now it's breast cancer. Many present in late stage, especially in India, that we all know. But with increased awareness, especially the programs that you're organizing, Jasicon, and all the organizers that you're doing, I think many people are now coming in reasonably early stage, especially in metro cities, and that's where I think the game is going to change a little bit. Out of all cancers, 20% of cancer is breast cancer. We all know that, and it's more common in Western countries. It's curable if detected early. These are the many armaments of treatment for cancer, like any other cancer. For breast cancer especially, we have 5 main treatments. There has been a paradigm shift from ultra-radical surgery from the time of Halsted to gradually Patty's mastectomy, modified radical mastectomy, breast conservation. And more recently, but not so recently, but for the last 10, 15 years, people are now more into sentinel lymph node biopsy for some obvious reasons. And we actually have the advantage of having the adjuvant therapy. So that's how the game is changing. We have more idea about the nature of the disease. Now, the main reason why people don't want to do a thorough axillary lymph node dissection are the main, these are the things that we are worried about. A permanent pain in the shoulder or the arm, frozen shoulder, people are not able to move their arms properly, numbness of the arm, paresthesia, that's what we are concerned about. Seroma, which is a temporary problem, and lymphedema, that's the most horrid problem that one can have. And you can see in the picture one of our patients who came to us with severe lymphedema. Now, if the sentinel lymph node is positive, what do we do? Should you observe with the risk of local recurrence and chances of decreased overall survival? Or what do we do? Axillary lymph node dissection, considering the increased morbidity that we just discussed, that was just a few, we can have many more, and whether we are going to have increased overall survival. So that's how we are going to have the discussion today, the debate. And the rule of the game is each speaker will have 9 minutes to convince the audience that that's what they would like to do, and they will get a chance of rebuttal for 1 minute at the end of their presentation. So the battle begins now. I would request Professor Diptendra Sarkar to start his presentation, and then Professor Somasekhar will be the next one. Professor Diptendra Sarkar, if you're ready.
Okay. So if Anand, you could allow me to share my screen.
Sir, Arnab sir, if you stop sharing your screen,
Yeah,
Dr. Diptendra will be able to share it.
I'm trying to do that now. Stop share, I've done that, yes. So it should be okay now.
Thank you. Good morning, Mr. Moderator, and my very good friend, Dr. Somasekhar, and all the great surgeons of Jharkhand State Chapter. I hope you will agree to the picture that you see in front of you on the left, that you see a patient with a fungating breast mass and a huge nodule in the breast. And that is what is breast cancer, apparently, to most of us who are by and large serving the whole spectrum of the society. While in the West, they would be bothered about Miss Jolie and the screen detected lesion. So you must understand at the beginning the pattern of the disease and the perception that the society and the healthcare professional has about breast cancer, based on which the trials and the studies are being conducted. So I am being entrusted to protect the fort by telling that if you are doing a sentinel lymph node biopsy and it comes out that there are 2 nodes out of 4 nodes are positive, you must go in and complete by doing an axial lymph node dissection. And I firmly believe that's the standard of care which should be applied for Indian perspective. You have seen in the pandemic how wonderfully this country has a single peak in managing the pandemic, whereas in spite of the best resources, the US had 3 peaks. The Europe is going into the 3rd peak. So believe me, in this era, you have to be precise about your patients, your infrastructure, and go ahead with things in that direction. Of course, this debate starting from the verdict that was given from the Z11 trial, which quotes that among patients with T1 and T2 invasive primary cancer without any palpable axial lymphadenopathy with 1 or 2 sentinel nodes containing metastasis, the 10-year survival, overall survival, if you're doing a sentinel lymph node biopsy or an axillary lymph node dissection, is the same. I stand against this, and the reason is, my lord, Dr. Arnav Gupta, I would lay my case by starting that statistics are like bikini. What they reveal is suggestive, but what they conceal is far more vital. And I am going to show you in next 8 minutes what are the hidings that we have in this trial, which would make this trial non-compliant for most of the developing countries. Reality check 1. What was the mean tumor size in this RCT? 68% of the patients were in T1 tumors and 32% of the patients in T2 tumors. With the even on the T2, the maximum size was 2.5 centimeter. That means they were dealing with cancers which were extremely early. And if you try to put the data in Indian patients in our practice, be it Arunima's or mine or Sushil's or Dr. Sunil Kumar's, 10% of them will be T1 tumors with the mean size at presentation across the country, something around 6 centimeters, makes it difficult to implement. Fact number 2, what is the age distribution of the patient in the trial? All of them were above the age of 50 years, at least 64% of them above that. And in India, the mean age is 46.1. That's an Indian publication coming from Dr. Deo in AIMS, whereas in US, it is 61. That means Indians are going to get a more aggressive and a younger cancer where these data may not be so effective. Number 3, reality check 3. What is the molecular subtype distribution in this trial? Now, fact check 3. The ER positive tumor comprises of 77%. That means they are dealing mostly with luminal cancers. That should be the portfolio, because most of the patient will be in the 60s, and in them, luminal cancers are going to be the common cancers. But Indian cancers, the data is 35 to 50% is either triple negative or basal cancer based on different publications. And therefore, you must admit that we are dealing with a more aggressive cancer in our subcontinent compared to the other part of the globe. Now coming to the nodal involvement. Now the total trial comprised of 891 patients, of which it was divided into 400 patients who underwent sentinel lymph node biopsy roughly. Now look at the burden of the disease. Of the 400 plus patients who went into sentinel lymph node biopsy, 60% of them had 1 positive node. So you are trying to make it a point that 2 nodes is good enough. No, 60% had, or 240 patients had single positive nodes. 40% of them had micrometastasis or isolated cancer cells in the lymph node. Well, that's fine. I mean, if you are having a micrometastasis, which as such has no significance in the disease, yes, you are justified in doing that. But if it comes to macrometastasis, I once again will withdraw from leaving aside the rest of the nodal basin and sticking to the Western data and the Western statistics. Now, reality check 5. What was the treatment offer? Ladies and gentlemen, please carefully read the lines and things in between the lines. Most of us try to jump to something based on the conclusion. Now, look, what this trial did was all the patients were patients of breast conservation surgery. And if you look at the data in the West, most of them will be less than 3 centimeter. The trial mandates the use of whole breast irradiation. And therefore, it definitely takes care of the lower level nodes. So the success of Z11 is not only because of the sentinel lymph node biopsy, but the inadvertent radiation that was given to all the patients who were who had 1 or 2 nodes. So the lower level nodes were tangentially irradiated, irrespective of what procedure was done. So the reality 6 is these are, I would agree, are real exclusion criteria. T3N0 tumors, okay, fair enough, you can exclude it. Positive nodes, you exclude it. All axillary nodes with possible pericapsular disease, you exclude this. Anybody who had undergone a neoadjuvant therapy, you exclude, it's fine. But look carefully, the trial excludes all patients who had undergone mastectomy. That means the trialist group were sure that radiation had helped in this particular subset of patients. And the early disease with radiation was really the changing factor and not really the type of the treatment that was conducted. So ladies and gentlemen, if you look from a drone on the battlefield, both of them look like the same. But this is the game of cricket with T20, and this is the game of baseball. Your perception from an overview or a bird's eye view is they are same, but actually they are a different ball game altogether. Now coming to the reality 7 check. Is this study adequately powered? Now, there had always been an attempt through ages to tell that lesser surgery is better, and you are forced to put the surgeon into the dugout time and again. Now look carefully. What happened to this NSABP B0 trial, which told that yes, if you treat the patient by observation, by surgery, by radiotherapy, whatever you do, the outcome is same. Now, what happened to this trial? When this trial was reopened with a sample size of 1180 with 350 in each arm, and the present consensus was that the outcome of the trial should have been based on 20,000 plus data, and that was an inadequate sample size trial. And therefore, in today's era, this trial would not have been incorporated as a valid trial. Amorous trial, again look at this, what happened? It told that in 10 years, 11 out of 681 patients had axillary recurrence if they had undergone in this arm, and 7 out of 744 underwent a recurrence if they had axillary lymph node dissection, and there was a second primary 11.5%. So what this again proves is that you should not be looking at the sample size of the patient, because the event is less, therefore the sample size must be bigger, and therefore again there is a conviction that Amorous again is an inadequately sample size trial, and therefore should not be a game changer in planning treatment of patients throughout the globe. Now coming to the Z11 trial. Now look carefully. What was the initial statement given by the trialist group? 1,900 participants and 500 deaths. And they noted 1 recurrence out of 420 patients. Once again, you see the recurrence, it was actually conducted in 400 patients with sentinel lymph node biopsy, and again 400 who underwent axillary lymph node dissection. So why the trial was terminated at 891 instead of a pre-specified 900? Why there was this hurry amongst the trialist group to come to a conclusion so fast? And therefore, I feel it is almost like the hurry was quite comparable with the vaccine trials, WHO standing, and therefore you had a hurry to completely stop axial lymph node dissection as early as possible and shift to sentinel lymph node biopsy, even in circumstances where you're putting the chances of recurrence to a large subset of patients, particularly throughout the globe, where the disease is more aggressive and there is a possibility of multiple nodal metastasis. But this trial is going to answer the question in 2023. And we take pride that this trial was started by our good friend, Dr. Amit Goel, who happens to be an Indian working presently at Derby. And this trial is called the POSNOC trial. And I have had multiple communications with Amit. And once you actually, instead of making the trial look very linear with 400 on this arm and 400 on that arm, you start stratifying it. Age less than 50 or more than 50, BCS versus mastectomy, ER positive status versus ER negative status, number of nodes, 1 or 2, whether intraoperative assessment was done with OSNA, yes or no. And once you start stratifying it, suddenly the whole thing changes. So if I look at Somsekhar, for once, I always know that he is a very good person. But once you start mixing with it, you start observing the shades in it. So the multivariate analysis, the stratifications will actually make the difference. So to conclude, the mean size of presentation is 1 to 1.2 centimeter in India. It ranges between 4 to 6 centimeters in India and 1 to 1.2 centimeter in the West. Most patients do not qualify for SLNB because of presentation and quality non-assured infrastructure. To get and to implement BCT in all patients is a daydreaming. Younger patient, aggressive biological types is definitely an issue, and non-inclusion of Indian data in the trial is a big problem. I come to the last slide. Now look at this. These are 5 different blind men trying to palpate the elephant and try to get a picture of it. And this is what is happening in breast cancer. San Antonio versus Somsekhar Center versus my center. And this is the description. It's a fan, it's a wall, it's a rope, it's a tree, it's a snake, it's a sphere. And what happens to the elephant is something like this. So we need to have our own data evolve out with our consensus, and we should come out with an Atmanirbhar Bharat rather than blindly following the data of the West. Thank you very much.
Fantastic, Professor Sarkar. Really enjoyed. I think it's time that we have Professor Somsekhar to defend his case. Professor Somsekhar, please.
Just a minute.
The time is 9 minutes, so you have to be quick.
Yeah. Som, have I stopped sharing?
Yes, I got the control. Thank you very much. Diptain is somebody who is very close, who is always right. For once, I feel very sad. My past president immediately was, totally wrong in looking at the data. Now I'm going to unbust this myth that ALND, because what happens, surgeons are worried about their job. What happens if my knife is gone? Intervention radiologist will come and take off chemo, medical onco has taken my primary breast. They keep giving all the chemo, no tumor. Then intervention radiologist will come and burn the tumor. Axilla sentinel node, chemo is sterilizing. There's nothing for me. My job is just to do core biopsy and give them, even that's taken away. So for once, we think the knife of surgeon, which is my experience level 3, is better than the pen, which is the evidence. So SLNB positive, does it mean we have to do ALND always and give all the complication? Because it doesn't matter, all the complication. I will do a good level 1, level 2, level 3 up to infraclavicular. Does the evidence say that? Absolutely not. There are 2 options. If you have sentinel node positive, does all need ALND? No. You stratify them into positive, negative, microscopic, macroscopic, low burden, not low burden. Then you decide no treatment at all after SLNB, or don't do ALND, give RT. Because either way, all the patients which are enlisted by Diptain needs RT. Breast conservation, you have an RT. LABC, you have an RT. Node positive, according to NCCN, 1 node positive is an RT again. So there is no extra cost, nothing. Do you want to put our ego and say, I will use the knife, I'll remove all the nodes without any benefit on adjuvant treatment, overall survival? local recurrence, but I will manage to give all the complication to the patient. So the boxers in ring is my very dear friend, who is there, who thinks that ALND is compulsory and it is equal. There is no equal balance at all. And I'm going to, but ALND was thought to be NSABP 0 for several years before I was born. Oh, it stages the disease, it prognosticates, reduces local recurrence, improves the survival, plans abdomen. Is it true? God has gone. All the Golits have gone home. Number one approach. It has no impact now on the local recurrence ALND as long as you stage by SLNB and give RT if it is high burden or no RT if it is low burden. It is not therapeutic. Myth is out. ALND now in this era is not therapeutic. Only staging. It's whatever it may be. Second, information gained over and above sentinel node has no impact now on the adjuvant treatment. It has no impact on overall survival. You do axillary clearance or not, overall survival remains the same. Information gained by ALND telling, okay, instead of 4-6 nodes positive, no impact on adjuvant. Medical uncle stop listening to number of nodes, TNM. Everything is now only genomic. Luminal A, B, C, TNBC, what it is. Complication of ALND, profound. Breast cancer, routinely they're cured 20-40 years. Complication massive. Morbidity and then side effects is unimaginable. We look at all the guidelines now, ESMO, NCCN, ASCO, I will show you, and the evidence and quality of life issues. This is what was thought. Breast conservation, mastectomy, SLNB negative, nothing to be done. SLNB positive, micromats, nothing to be done. SLNB positive, low burden, up to 2 to 3 node positive, no ALND, no RT to the axilla, high nodal burden, you give RT and no ALND, it is there. Original concept was every quadrant has a lump and separate node. Now we know that no matter which breast, which quadrant, only one sentinel node for that. It looks very good. This is just a ego of a surgeon, but has all the complication, number one. And now this is a thing, ALND you do, and either way they need RT to the chest wall because either you're dealing with an LABC as shown by Dipten or node positive. Look at the lymphedema incidence. ALND alone, ALND with RT, and look at the bottom line, SLNB with or without RT. Now this is NSABP 32, arm edema, lymphedema, shoulder mobility, numbness, tingling, unimaginable. 70% of them have no nodes, even in LABC, but 50% develop all unbelievable complication, not justifiable. What has changed now in last 2 decades? Adjuvant treatment no longer is dependent on tumor size or LABC alone node. No. Everything has shifted from therapeutic to prognostic. We shifted from mastectomy to minimal access to no ink, no almost contraindication for breast conservation, axillary to SLNB. Now SLNB positive is changed totally. This is very important to understand pre-systemic chemo, post-systemic chemo. Regional recurrence in pre-systemic era, remember not local, regional was 4 to 6%. Now all the trials in last 1 decade, positive node, not positive, LABC, how often have you seen any recurrence in the axilla, whether you treated or not? Now in this era of modern chemo with targeted therapies, based on the genomic profile of this, less than 1% now. The word of wisdom, so rightfully in editorial of NEMJ came, tumor subtype now decides. Node positive, I'll give Taxol, node negative, I'll not give, node positive, I give chemo, no longer. You have 1 centimeter, tumor profile decides. So ALND is not giving any more information. So tumor subtype decides. 65% of the patients across all breast, including stage 1, are treated with chemo. They eradicate the nodal disease irrespective of positive. Absence of the extra knowledge over and above SLNB has no impact. Type of systemic therapy is also not dependent on axillary node now. Taxol to be given, not given, anti-HER2 therapy, everything is on the ERPR, HER2 new key 67 and genomic profile. Even T1, most of them needs and they have improved local control. What has NSABP taught us? 61% of the time sentinel node is the only node positive. It may be LABC, it doesn't matter. Don't get confused with T status, young age, and then hormone receptor. They all have no impact. They are all only guiding the axillary status, which is assessed either by SLNB. Even in Indian study from our group, we proved in Indian patients 62% SLNB is the only node. Now look at NSABP, morbidity of ALND, unimaginable. But look at sentinel lymph node versus no axillary, DFS, OS, local recurrence, all same. Now 3 trials, Asacos Z11, my colleague told only in BCT, no. BCT trial, Asacos, even in mastectomy, IBCSG is also in mastectomy. All the trial concluded. You observe axilla even when node burden is positive, they have no impact. I'll show you. Trial in mastectomy, Amaros, IBCSG. Macrometastasis, Indian setup, Amaros. High risk patient, URTC 229.22, MA20. All of them showed that observation has same. The proof of pudding is 5-year recurrence. See that. In node positive axilla, all of them are same, p-value is same. So there is no extra regional recurrence. IBCSG showed that whether you do ALND or not, recurrence is same. Now look at Asakos Z11. Everybody says short trial 6. Now we have got a 9.5 year. Nodal recurrence done, not done, both are same. Look at the curves, they are overlapping each other. Now we have a 10-year update. 10-year update. Look at this. ALND, no change in the overall survival, no change in the recurrence pattern. Now Amaros told that Indian set of patient, high nodal burden, don't do ALND and give the complication, just give RT. Both have same disease-free survival, same overall survival, but look at the lymphedema, very low. Look at this curve, high nodal burden, ALND, no ALND, same loco-regional recurrence. SLNB, no ALND or ALND, 0.43% recurrences. So Amaros told that chemo is there for all based on the genomic profile of the tumor, then you give RT. Now we have MA20 trial, high nodal burden trial, which again showed that instead of ALND, you give RT, it has got the same survival. And remember, in ALND, unlike breast, all the axillary recurrence happens in first 1.5 to 2 years. So any trial you want to study axilla, 2 to 3 years is enough. And this is the trial which shows that. So Amaros, Azegok shows this. POSNOC trial, beautiful. No RT also. I have attended this presentation with Amit many times. We presented in Sentinel together. POSNOC goes one step above. High nodal burden, no ALND, and no actually axillary clearance, no RT also. And recent update of POSNOC trial didn't show overall survival. I attended this. So I want to conclude telling, look at the recommendation. ASCO guideline now says, no ALND mandatory. They have written high nodal burden like India, also no ALND. Low burden, no RT also to be required. Sentinel consensus has told in light of recent trial, panel consider, even in macrometastasis of SLNB, you don't have to do ALND. NCCN recommendation has included. Look at the NCCN recent recommendation standing. SLNB positive, no further ALND. NCCN has included, ASCO is included in this. So in conclusion, ALND gives morbidity, not therapeutic, even in Indian patient high nodal burden. Amaros trial, Asakov Z11, IBCSG, EMA trial, EORTC trial, all of them has shown irrespective of low or high, you don't have to do. All you do is give burden. And we are under a fool's paradise thinking that I guide the medical onco. No. So risk stratification, micrometastasis, no ALND, IBCG trial is there. Breast conservative surgery are doing Z11, IBCA 23, no need to do, no RT also. MA20 URTC for Indian patient, don't do ALND, give comprehensive RT. Amaros trial says that giving an extended RT replaces ALND, same local control, same overall, and no lymphedema, no complication. So now you look at it. SLNB negative, no ALND. Positive micromats, have written the evidence there, no trial. You are doing BCS, 2 trials, Z11, IBCSG, no ALND, and then no RT to axilla. Macrometastasis, high nodal burden, you are doing BCT, MA20, URTC, no RT. You're doing mastectomy, not required. Only group you have to do is low risk mastectomy, no EBRT planned. You may consider ALND, otherwise no other. So in summary, risk stratification, all the evidences now say that there is no benefit of treating axilla over and above knowing it is positive. So it's very important to finish off the line. We started off in NSOP 04 before I was born, with Halstead. We feel very sad. Surgeon's role is coming down, less and less. And then it's a time to change our mindset. We are no longer controlling the chemo. We are no longer controlling adjuvant. We are only giving complication without changing any recurrence, because less than 0.45% is the recurrence now and less than 1% recurrence we have. So this is what is the difference between ALND, 1, 2, 3, 4, 5, 6. All subgroups, BCT, low burden, no this one. So we give only complication, we don't give. So this is an era of not maximum tolerable treatment, minimum effective treatment. Same cure rate, same cost. More is not always better. We give complication. Less is always not inferior. era of de-escalation. Medical oncologists understood, radiation understood. Unfortunately, surgeons, we think knife is everything and we try to ignore the evidence. So I answered all these points with an evidence, guidelines, trials, impact, one by one, and debriefed my colleague. Knowing this, my close friend Diptan says, debate is over. We both are friends. And I just join you, Somsekhar. Let's just practice what is evidence-based. Thank you.
Thank you so much, Professor Somsekhar. Really enjoyed another brilliant talk. So now it's time for rebuttal. Let's see what Diptendra has to say. Professor Sarkar?
Yeah, just a minute.
Yeah, sure.
Well, as I said, I would have loved to agree with Somsekhar, with whom I have agreed on almost everything. But I disagree once again, or I rather beg to disagree with him. He could actually point out so many wonderful trials, but unfortunately, most of them, almost none of them has an Indian evidence to that. And we as a country have matured enough where we are able to produce vaccines in the same pace as the West. It's unfortunate that we could not cite a single Indian evidence to tell. Now, let me once again recheck what did the authors of Z11 put at the end of the evidence. They declared the limitations of this study. Number one, they state that not all biological subtypes are represented in large numbers. So out of 400 plus patients, if 68% are luminal A, it leaves only 32% of the other types, and therefore it's not representative. Number one. Number two, differences in outcome may be seen for patients with different individual circumstances, and you cannot have a generic form of treatment everywhere. Number three, it's an era where we need to understand that surgery is also tailor-made to a particular patient. You cannot have a generic form of treatment. Number three, not all biological subtypes can be analyzed for variation in locoregional treatment. Again, they declare that they have not analyzed the different subtypes in that particular trial. Number four, they have agreed that because of the low event rate, they had actually come to a conclusion prematurely. Instead of 1900 participants, they came out and stopped it at 891 because they were having an early, extremely early group of patients where they could not come to a conclusion to that. Finally, they also agree to the variation in irradiation protocol that they had in different centers while these patients were taken up. So therefore, what it seems that a 61-year female with a screen detected clinically impalpable undergo the breast conservation, 1 sentinel lymph node biopsy showing micrometastasis, I may settle with SLNB. At the end of the day, if we are so confident that axillary treatment has got no role whatsoever, why the hell are we embanking on sentinel lymph node biopsy? If you just see clinico-radiologically there or do an MRI, you find nothing in the axilla. Why don't you stop sentinel lymph node biopsy as well and blindly decide what has to be done with the modern chemotherapy? I would also come to a conclusion like that if in small towns of India, we could have a genomic profile being done and come to a conclusion with a standard IHC marker. This is the biological subtype. Unfortunately, as of now, there is very few level 1 evidence to suggest that biological markers are going to replace completely the axillary markers. So yes, the axillary standard markers are valid, and therefore evaluation of the axilla and complete removal of the axilla in appropriate case is absolutely valid in Indian practice. Thank you very much, Mr. Biden, and I am sure as this guy, Donald Trump, I am a bit obsolete, but I stick to his statement, America is for Americans and India is for Indians. Thank you very much.
Thank you, Professor Sarkar. That was wonderful. Now, last rebuttal from...
Thank you very much. Actually, Dipten answered all the answers on my behalf in his second rebuttal. Remember, I would love to do a surgery ALND. Ultimately, forget everything. The proof of putting in axillary dissection is only two things. Already node positive or negative information has come from SLNB. He told that SLNB, why to do? SLNB is very important to decide on three things. You have to triage the patient into node positive axilla, node negative. Low burden, high burden. Node negative, no ALND, no RT. Low axillary nodal burden, microscopic disease, no treatment. Low axillary burden, no RT, no LND. High nodal burden as per MA and then also MROS and URTC, you need RT. So SLNB is very important to know. Staging, not therapeutic. Second, the proof of putting of axillary treatment, whatever be it is, surgically removing it, RT giving, surgically removing and giving RT, or SLNB no treatment is only two things. Overall survival. All the 7 trials that I've looked has never shown any impact on overall. Remember, overall survival is coming from the neoadjuvant and adjuvant treatment in a good control, which means overall survival is not at all a debate in any trial. All proved overall survival is same. Now, what that leaves us? Not local recurrence, axillary regional recurrence. Now, if you read any trial in any country, including India, the axillary recurrence now is less than 1%, which means a treatment should have an impact on regional recurrence, because overall survival is not at all a debate. No longer it is on that. It is taken care by medical onco and hormone and not by us. So they are going to give overall survival. We give a local regional control. Local recurrence in across the world is now less than 1%. So less than 1% impact is all we note now. Now coming to Indian cases. Remember, gone are the days India is LABC. Recent 4 publication from India from a government institution, regional cancer center catering common public, 40 to 50% breast conservation. Even in government setup now, LABC has dropped down to less than 30%. So it doesn't matter. India is not, we can't keep India poor, get me grant. No. India now, most of the center, audit yourself, Diptendra Sarkarji presented in his government setup recently in AIMS. 55% breast conservation in a rural woman. Where are we speaking? We have to move on. We can't pat ourselves, myself, please, I beg. Indian data, more than 45-50% breast conservation. Mean size of the tumor has dropped down to 3 centimeter. High axillary burden. I'm not telling no treatment to axilla. SLNB negative, no treatment. Micrometastasis, no treatment. Low burden, no RT, no ALND. High burden, instead of ALND, follow MA protocol, URTC protocol, Amaras, and give RT. Both have same cure rate, same local regional control, but no side effect compared to this. That's all I want to say. I would love to do that, but ALND is an absolute procedure now, unfortunately. Very sad. And I'm sure next year Dipten would be debating on my behalf, knowing the evidence. Thank you very much.
Thank you very much, Professor Somashekhar. And obviously, we are running late. I have to say a few concluding things before we wind up. Just one sec. I think you all had valid points, and I think we are just debating over issues which are, to a certain extent, yes, Western-based. So very quickly, Z11 study, we know the criticism, but I think, like we said, if you're looking at Indian context, maybe Professor Somashekhar, the kind of patient you see in your center is mostly early disease. You probably see more of T1, T2 tumors. Mostly they undergo breast conservation. Maybe 1 or 2 sentinel lymph nodes are positive. So at the moment, we all agree that Z11 study is limited to those sort of patients where you don't actually do axillary lymph node dissection. But what is beyond that? Micrometastasis, we all agree that you don't do anything else. We take it as negative sentinel node lymph node biopsy. Obviously, because Z11 study was not very conclusive, they are now progressing with many more studies, and we have to wait for the results. The earliest result we are going to get maybe in 3 years' time. Amaros, it was not just observation, but it's observation, axillary lymph node dissection after positive sentinel lymph node, and also regional nodal irradiation. Yes, the outcome is similar. Morbidity is less in the second group where you don't actually do axillary lymph node dissection. Yes, we agree to that. And these are the different studies that are ongoing at the moment. So we really have to wait before we actually can conclude. So whoever is right, whether it's Trump or whether it's Biden, we really don't know. We have to wait for their terms to finish. Now, just to look at my little data, because I've been practicing in India for 20 years after I came back. And actually, I published our data after 10 years of practice. So that was in 2010. I've got another 10 years of data. And like I said, we need more Indian evidence, and we have to look at our Indian profile of patients. Maybe we are seeing more of early diseases, yes, but we still see a lot of locally advanced disease, and I can show you some pictures. This is a patient who actually had an early disease, had alternative treatment as most of the women would do in India, and then eventually had systemic therapy, local radiation in a place like Bombay, went on to have fungation, and then had lung mets also. So not all of them behave the same way. So you have to look at the tumor biology. That's why genomics are coming to play. You have to look at the IHC and everything. So this patient actually underwent an operation, but obviously we lost the patient. So that's one stage. This was stage 4. This is stage 3, where we actually went on to do. There's no point doing a sentinel lymph node biopsy here because it was a palpable node. And what we did was a complete axillary lymph node dissection, preserving all the structures that Somashekhar had described nicely yesterday in his presentation. That's how we can avoid the morbidity. And there's a kind of axillary dissection that we do, sticking to the principle of not going above the axillary vein and not damaging the the medial pectoral, the pec minor and all. And this is an early breast cancer where we did a breast conservation surgery. So all of them actually went on to have axillary lymph node dissection. And these are just a few snapshots of patients who had BCT. If you look at the our data, sensory loss, that's people are worried about, was only 10%, because even in LABC, people may not believe us. We had presented our data long time back, and they probably would think that extracapsular spray, you don't need to preserve the intercostal brachial nerve, but we had preserved in most of the cases unless they were grossly intimately adherent. So we had sensory loss in only 10% of patients. Lymphedema, you wouldn't believe, it's only 0.4%. You might ask, how is that possible? Because we never allowed our radiation colleague to irradiate the axilla after doing thorough level 3 clearance. And you might ask why we did thorough level 3 dissection, because we want to clear up the lymph nodes and not subject them to radiation, because the combination is bad. You can't do level 1, come out and give them radiation because the combination is bad. Seroma incidence was even less, 2.8% compared to any data. Infection rate, very minimal. Restricted movements, not at all. We start mobilizing the shoulders. So it's just to tell the Indian audience, the postgraduates, that in an Indian scenario, we must not always believe the Western data where they're more accustomed to seeing early breast cancer. Axillary recurrence, you wouldn't believe, again, not a single one. We did thorough axillary lymph node dissection, and we didn't subject them to radiation at all to the axilla. Obviously, they went on to have radiation to the chest wall, depending upon the stage, T3, T4, nodal positivity. They had the radiation to the chest wall. Now, Somashekhar, you rightly said that we don't see that much of axillary lymph node recurrence. But if you look at this picture, we had seen at least maybe 15 or 20 in my 20 years practice. And this is a patient, this particular patient was a wife of a doctor. And obviously, things normally go wrong for any relative of a doctor. And this patient actually had severe axillary recurrence. She had T2 disease. 1 or 2 lymph nodes were taken out from the axilla in a hospital outside. And this is a patient who was, actually having severe recurrence, and we had difficulty saving her. Actually, we lost her after 1 year. Now you have to trust your surgeon, and the pathologist has to do an equally good job. If you don't look at the axillary nodal status, this patient actually was operated on in a small nursing home outside our hospital. We went to a small lab, and unfortunately, that was a long time back. They reported only 2 lymph nodes. And when she went on to a different hospital for radiation, they radiated the axilla because they thought that we have not cleared the axilla. And that's the problem. If you do half axilla, if you irradiate the axilla after thorough dissection, that's a problem. You are going to have a lymphedema. But our recurrence lymphedema incidence is very, very less. So minimal complications can achieve even with thorough axillary dissection, even if you don't do sentinel lymph node biopsy. And obviously, you can't do sentinel lymph node biopsy in LABC. And that's what we normally see in our country. And the winner for today, any guesses? Last night we had the result, yes. So somebody has already mentioned who's Biden, who's Trump in our debate. But I think the winner today is, if any guess from anybody, is actually the team. The team is the winner. You can't have you can't win a match with a good bowler or a batsman. You need a full team. And what does the team comprise of? The radiologist, who has to find the disease even in early stage. If it's a screen detected cancer, they have a big role there. You have to stage the disease properly with a radiologist. Pathologist has got immense role nowadays. We all know the value of a pathologist. And I've told you, if the pathology report is not, what sort of problem you can end up with. Surgeon has to be good in his technique. Axillary lymph node dissection has to be done properly, meticulously, and not just, you just do a dissection being totally untrained, and you end up with severe lymphedema. And not only that, many other complications. Radiotherapy team has to be with you. medical oncologist, support group, patient and family have to be taken into consideration. And you have to have your own evidence-based medicine practice in your place. So you can't just extrapolate the data from anywhere else. You have to look at your own data, your own infrastructure. And if you have everything in place, you'll have a smiling Mona Lisa at the end of the day. And that's one of my paintings from my college days. Thank you very much. I don't think we should argue on this anymore. We really have to look at all the data that's going to come through following the early NSBP and AMAROS and Z11 studies. We have to wait for the further studies, including the postdoc, which I'm sure is going to be useful. Any question from anybody? And then otherwise we'll conclude. I know we are running very late. And congratulations to both the speakers. You did a wonderful job. I congratulate both of you, and thanks to the organizers once again for having us. It's been a pleasure coming back to your conference. Thank you.
Thank you very much, Dr. Arnab, Dr. Diptendra, and Dr. Somsekhar. I think it was an excellent debate. Whatever the outcome, but at least we know the latest advances, because Dr. Somsekhar has already told us about the latest advances. We need to know what the West is doing, not emulating the West, but at least knowing the recent advances. And obviously, with all your experience, Dr. Arnab and Dr. Diptendra, you have shown us the Indian scenario. I think it was a wonderful debate. If we have questions in the chat box later, I'm going to personally ask you all, because this is something which is very close to me as well. I am also very interested in breast surgery, so I also do a lot of it. But it was an excellent debate. I think the start is a very good start today with this kind of a debate. Thank you very much, all of you. Satveer, can you please take over?
Thank you very much, sir. Being practicing as a breast surgeon, I would like to share my experience. Sir, what I feel that in every center, in every place, the scenario changes. When I was working in Andhra Pradesh, there were almost 70% LABC patients. When I moved to Maulana Azad Medical College, where the people were aware of the treatment, we had around 50-50. 50% were LABC, 50% presented for breast conservation. After that, when I moved to Tata Memorial Hospital, there also the scenario was there. The average presentation was 3.5%, and there were some class which always presented an LABC. But after I came to Jharkhand in last 6 months of this lockdown, I almost received more than 20 patients, and almost 15 patients were at the metastatic stage. So I think it depends on which state you are, which place, and what are the medical services, and how aware and how educated people are. This makes a lot of difference from the Indian scenario. That will be all from my side. Thank you very much, sir.
Thank you.
Absolutely, Satveer.
Three cheers to Dr. Somsekhar, my president. And next time when we debate, I will be on your side and you will take mine. I am sure. Thank you very much. Thank you very much.
So at the end of the day, both of you agree as well as disagree with each other at the same time.
Yeah,
but thank you for giving us this
actually.
wonderful debate.
Both are right, because in medicine there is no absolute yes or no.
Exactly.
You must know that there is a scope for both the treatment, but we must be aware of both. There is no absolute yes or no on both the sides. We both very well know that there is a place for both, but it's very important not to say no to each other, because there are a subset of patients on both sides.
Absolutely. Exactly. That is what I said, that having this kind of a debate is what enlightens people. They know both aspects and then they can choose. Thank you very much.
Thank you very much, sir. A respect of token for Dr. Arnab for chairing this session.
Thank you very much. It was my honor.
A respect of token to Dr. Diptendra Sarkar for his beautiful views. And a respect of token to Dr. Somsekhar sir for his beautiful views. Thank you very much, sir. Thank you, sir. So we move on to our next session, which is the best poster presentation session. And we welcome our esteemed chairpersons, Dr. Arnab Gupta, Dr. Sheetal Malwa, and Dr. M. Kanagaval, sir. Dr. Arnab Gupta is the president of IASO examiner to MRCS and DNB Onco. Sir is a medical director, surgical oncologist at Kolkata. Our next esteemed guest is Dr. Sheetal Malwa, professor, Department of General Surgery at RIMS. Sir is MS, DA, FICS, FIGS. Sir is ex-secretary SI Jharkhand, organizing chapter of Jasicon 19, and PG examiner and various publications in national and international journals. Our next esteemed chairperson is Dr. M. Kanagaval, sir. Sir is a senior consultant and PG faculty at ST Isabel's Hospital, Chennai. He is a chairman of Association of Surgeons of India, Chennai branch, founder director of GastroPro Advanced Laparoscopy Center. Sir is a joint director in recent advances in minimal access surgery, editorial board to IJS, and sectional editor to JMAS. And sir has been awarded with Sundaram Award, TNASI, Japanese Surgical Society Traveling Fellowship, JGHAPDW Traveling Fellowship, Professor S. Venugopal Orator, IMA USP Orator, patent holder on membrane transducer chip for oncodiagnosis. We welcome all our esteemed chairpersons, and not to waste much of our time, our first presenter will be Dr. Syed, and he will be presenting a case report of primary breast tuberculosis in a tertiary center of Jharkhand. The rules are the same, 5 minutes for each presentation and 1 minute for the discussion. Dr. Syed, please, I welcome the chairpersons and want the first presenter to start his screen share.
Right. Who's going to keep the time? Yourself, or do you want?
Yes, sir, I'll keep the time, sir.
All right. Okay. Thank you.
The screen goes blank after 5 minutes, right?
Yes, ma'am.
Right. Okay. So the first presenter, once you're ready, give us a green signal.
Morning, sir. Good morning, all of sir.
Morning.
Myself, Dr. Syed Mohammad Sharik. I'm third year junior resident in general surgery, RIMS Ranchi. And I am presenting a case report of primary breast tuberculosis, rare case report in tertiary care here in RIMS Ranchi. And my guide is Professor Dr. Mrityunjay Saraugi, sir, who is also a unit head here. So, as we all know, tuberculosis of breast is a rare occurring disease. It has very low incidence. It mostly affects the reproductive age group of women between 21 to 30 years and seldom present in age group after that and below that. It can either be of primary etiology or secondary etiology. It often misdiagnosed as abscess, carcinoma of breast, because its presentation is variable. Coming to my patient detail, my patient was 35-year-old female. She had a complaint of lump in her right breast since 3 months, which was associated with pain. She came in our OPD and we examined her. On examination, her both breast was not symmetrical because the right breast has a lump of size approx 5:5 centimeter, which was also mildly tender. It was present in upper outer quadrant. On examination, lump was because she it was mildly tender. Lump was fixed to breast tissue, and there was no retraction of nipple. Axilla was normal. Nipple areola complex was also normal, and there was venous engorgement on the diseased breast side, especially on the lump side and bump side. We did the examination. Initial examination, hemoglobin was normal. Total count was raised, especially toward the lymphocytes were raised. Hello. Monto test was done. It was positive. Yes, sir. Monto test was done. It was positive. We did the X-ray of chest, CTs of chest, mammography. Mammography showed the calcification in the right breast. We also did the CT chest. After that, we in the first sitting we did the FNSC, and in FNSC the report came as TB breast. The report consisted of granuloma with necrosis. After that, we sent the biopsy, core needle biopsy. In biopsy was also confirmatory about the granuloma and casus material. ZN staining was also positive. Acid fast bacilli was seen in ZN staining. Sabinat was positive. After proper counseling, we put her on anti-tubercular therapy for 9 months with 2 months of intensive phase and 7 months of continuation phase. This is the picture of my patient and slide of FNSC. We could not get the slide of biopsy because somehow the pathology team I contacted, but they could not provide us the slide of pathology. In discussion, lactating women and immunocompromised women are at higher risk as there is supply to breast and dilated duct and make them more vulnerable. The most clinical presentation is painful lump. Alone, there may be abscess or fistula or may not be. In approximately 20% of cases, like fever, malaise, night sweat, and weight loss are also there. Monto test does not provide definitive diagnosis, but help in confirming exposure of the patient to the tubercular bacilli. In ultrasonography, a hypoechoic echogenic mass is found in 60% of patients, and sometimes help in identifying a fistula or sinus tract, which can be seen in case of tuberculous mastitis. Gold standard is Zn staining, and 73% in cases FNAC may presence of epithelioid cell granuloma necrosis that helps us in making definitive diagnosis. So my conclusion is it is a rare disease. Primary line of treatment is ATT, and we should have a very high suspicion when we dealt with the lump of breast, because it present like in very form, it mimics like abscess, it mimics like cancer, anything. So diagnosis is very challenging. It requires a high degree of suspicion since it has a variable pattern. And to differentiate TB from secondary tuberculosis and primary CT scan is must. Uh, Histopathology, we all know, plays the pivotal roles. These are my references. Thank you very much. This was my presentation.
Thank you very much. Just
Yes,
a couple of questions from my side.
Yes, sir.
What is the incidence in India? Have you done any literature search? What is the
Yeah. In incidence, it's like 3 to 4%, sir.
I didn't see you quoting any literature, so just wanted to ask you regarding that. Now, what is the other differential diagnosis? Common differential diagnosis. The core biopsy might suggest some granulation tissue. You can't be sure what exactly is going on. What is the common differential diagnosis, especially in lactating women?
That's the common differential diagnosis. It could be, sir, granulomatous mastitis.
Right. Okay. Anything else?
Carcinoma.
Yeah. Anything else? Carcinoma is one. Yes.
Carcinoma, traumatic fat necrosis can be there, sir.
Yeah.
Fibroadenoma.
Right. Fine.
Yes,
So
sir.
that's from my side. Anybody else? Any question?
So I had a very well presented article paper.
Yes, thank
I would like to know what are the principal modes of tuberculosis bacillus access to the breast.
Sir, you mean the spread, sir?
Correct.
Yes, sir. Spread is mostly by lymphatic routes, and hematogenous route is the least likely that occurs in disseminated form. And there can be direct spread also.
And what are the known types of presentation of the tuberculosis of the breast?
Sir, type of presentation is we classify in 5 types, but mostly we see it in 3 types. Like most common is nodular type. There can also be disseminated type in which whole breast is involved, and that can present. One type is abscess type, and sir, least 2 varieties are sclerosing type and mastitis ductus obliterans type.
How does the therapy differ from a pulmonary tuberculosis?
Sir, pulmonary tuberculosis, we mostly go for 6 months of therapy, 2 months of continuation phase, and 4 months of because this is an extra pulmonary tuberculosis, so we go for 9 months of ATT.
What is the role of surgery in tuberculosis of the breast?
Sir, role of surgery, if the disease is persistent, like Bailey and Love suggest, if they has persistent residual infection, and by the end of ATT, if it is not resolving, the lump is there, so we must consider for simple mastectomy.
Thank you.
Welcome, sir.
Thank you, Dr. Syed. Thank you, our chairpersons, for thank you, Syed, for such a wonderful presentation. We move on to a next presentation, which is by Dr. Chandan Kumar, unusual perforation of colon by fish bone.
So
Dr. Chandan, please start sharing your screen.
Yes, sir. Good morning to all the delegates. Hello, sir. Are you getting me?
Yes, sir. Yes, you can present. It's visible.
Yes, sir. Good morning to all the delegates, sir. My topic for presentation is unusual perforation of colon by the fish bone. Myself is Dr. Chandan Kumar, DNB second year from General Surgery, Tata Motors Hospital, and my guide is Dr. Arunima Burma. She is the HOD Surgery, Tata Motors Hospital. Perforation of GI tract is not uncommon due to the foreign body. Most of the time, perforation occurs in the esophagus, stomach, duodenum, or the ileum. It is very rare to perforate the large intestine. Clinical presentation may vary and mimic that diverse medical and the surgical condition. Go et al. One reported that the swelled fish bone is the common cause of the GI perforation due to the pointed sharp tip and the long bodies, and the most common site involved with the fish bone is the terminal ileum. Here I am presenting a unusual case of perforation of the transverse colon by the fish bone. Only a few case reports are available. A 27-year-old gentleman came with the complaint of the severe pain abdomen, high-grade fever, and the nausea since 5 days. On examination, patient was hemodynamically stable, febrile, and had tachycardia. He had generalized tenderness and the guarding of the abdomen. He had no comorbidities and any previous surgical history. Initial investigation were normal except the raised inflammatory markers and the CRP. Radiologically, X-ray abdomen shows no gas under diaphragm or the air fluid level. CCT abdomen showing the focal thickening of the proximal transverse column with adjacent rim enhancing fluid collection and the linear hyperdensities. Finding may represent the focal perforation of the proximal transverse colon by the foreign body and the consequent adjacent loculated abscess. After CT, upon questioning with the patient, reported that he had the fish meal about the 6 to 7 days back. This is the X-ray of the patient, which is not showing any air fluid level or gas under the diaphragm. This is a CCT of the patient, which is showing the foreign body, and there is localized inflammatory reaction. This is the pathological specimen of the resected segment of the transverse colon. Patient operated with the midline incision. A microperforation with the localized abscess due to the penetration of the fish bone through the wall of colon was found. Resection and anastomosis of the segment of the transverse colon was done manually. Patient received antibiotic post-operatively and did well and discharged on the 6th day post-operatively. And discussion, accidental swelling of the foreign body is common in the clinical practice. Most of the time, foreign body passes in the stool without causing any problem. There are reported cases of GI perforation caused by the fish bone, chicken bone, but most commonly site involved are the stomach, duodenum, or the ileum. Perforation may seldom occurs at the regions like the hernial sac, Meckel's diverticulum, and the appendix. Perforation of transverse colon due to fish bone is a very rare condition due to its wide lumen. According to the study of Madrona et al., most common cause of the intestinal perforation with the foreign body are the chicken bone. Chow et al. Reported that the swelled fish bone are the most common cause of intestinal perforation with the foreign body in the Hong Kong. Go et al. Also reported that the swelled fish bone is the most common cause of GI perforation of their pointed sharp tip and the long body, and the most common site involved with terminal ileum is 38.6%. Coulier also reported perforation is most commonly involved in the angular region like the distal ileum, where lumen is narrow. Conclusion, this case emphasized the importance of the considering colonic perforation caused by the foreign body, the differential diagnosis of the acute abdomen, although it is very rare. And I would like to thankful to all my seniors and all those who supported in this operation. And these are the references. Thank you, sir.
Thank you very much. Just wanted to ask you, it's very interesting. I've never heard of colonic perforation by fish bone or any foreign body as such. So
Yes,
did you actually find in the literature any other reported case of perforation of the large bowel?
Sir, when I was going through this presentation, I have gone through 1 or 2 cases. I find it there, sir.
Right.
And
So,
most of the cases are from the chicken bone, sir.
right. So none from fish bone. So it's a unique case. I'm sure apart from this contest, you must publish it. Secondly, did you actually do an ileostomy? You resected that bowel. Did you?
No, primary closure was done, sir. Transverse colon segment is resected.
Right.
Yes, sir.
Right, because if you have an infected area, if you do an anastomosis at that portion, there's a small chance of the anastomosis breaking down. But obviously, in good hands, the incidence is very low, and I'm sure you've done a wonderful job. That's from my side. I'm sure the other panelists, masters, will have some questions. Juries.
Dr. Chandan, a very well managed patient.
Thank you, sir.
What is the role of endotherapy? Because transverse colon is pretty much accessible with colonoscopy. Can a surgery be avoided with the colonoscopic removal?
Sir, I'm not sure about this. No, it is because it is abscess formation outside the wall of the colon, sir.
Right. But then
So
many
it is
diverticular
difficult to manage.
abscesses and other abscesses, as long as the foreign body comes out, a contained abscesses are still managed conservatively.
Yes, sir, because patient has a fever since 5 days, sir, and he's not improving after the antibiotic treatment, sir.
What made you to think about the fishbone? Was it a CT scan which picked up that, or a patient themselves told you?
No, sir. After CTS can be found the fishbone, then I have inquired about the history of the patient.
Okay, with the
And then he stated that about the 5 to 6 days back, he took the fish small, heavy fish meal, sir.
with this experience, if a patient comes to you telling, doctor, I accidentally swallowed a fishbone, what will be your approach?
हॉल बी का मैं कोऑर्डिनेट करता हूँ सर हॉल बी
Sir, it's not always that there will be a perforation, sir. Perforation is
जी सर जी
on perforation of the colon is a very rare.
ओके सर
Most common site of the perforation is either the duodenum or the ileum, sir.
Thank you. Very well done.
So we will follow up with the X-ray, sir.
Absolutely. Bye-bye. Good.
Dr. Chandan for the presentation and thank you judges for such good questions. We move on to our next presenter.
Thank you, sir.
Which is Dr. Kunal Kishore Singh on supranumerary nipples in a young male. Dr. Kunal, please start sharing your screen.
Good morning, sir. Myself, Dr. Kunal Kishore Singh. I am a third year PG from RIMS Ranchi. My guide is Dr. R.G. Bakla, sir. Today I am going to present a poster on the topic supernumerary nipples in a young male. Normally, the milk line degenerates shortly after development, leaving behind a portion that persists in the pectoral region where the normal breast develops. Accessory breast tissue and nipples develop due to failure of regression along the normal mammary ridges. The incidence of polythelia varies between 0.2 to 0.5% in the general population. The most common site of accessory nipple is just below the normal breast, and the most common site of accessory breast tissue is in the lower axilla. Polythelia is most commonly seen in males and is more common among the black people. Supernumerary nipples and breast are physiologically non-functional but may undergo benign and malignant transformation like normal breast tissue. They respond to hormonal changes in the same way like normal breast tissue. Here we report a case of 24-year-old male who presented to us with cosmetic complaints due to extra nipples. He informed that the extra nipples were present since birth and he had no any related symptoms. There was no family history of accessory nipples or breast cancer. He did not have any history of urinary tract malformations. On physical examination, the patient had two supernumerary nipples present, one on each side. On the right side, the supernumerary nipple was present 10 cm below the right main nipple, and on the left side, the accessory nipple was present 8 cm below the left main nipple in the mid-clavicular line. The accessory nipples were of size about 15 mm into 20 mm and were present along the milk line and were surrounded by small areola and no breast tissue. There were no signs of underlying swelling or any pain on palpation. The patient was thoroughly investigated and an ultrasound whole abdomen and pelvis was done to rule out any renal or genital abnormalities. The patient was taken up for OT and the patient underwent simple excision of accessory nipples with primary closure of wound and the patient recovered uneventfully. This is the picture showing the presence of extra nipples. The histopathological picture of the excised nipple showing sebaceous gland with surrounding smooth muscles. Discussion. The most common form of supernumerary breast tissue is polythelia. Polythelia is defined as the presence of accessory nipple with or without areola or accessory breast tissue. The supernumerary nipples may occur in any size and configuration along the milk line, and in half of the cases, they are bilateral. Polythelia has been reported at various ectopic sites like over forearm, shoulder, back, thigh, vulva, foot, etc. Most of the cases of supernumerary nipples occur sporadically, but familial cases with autosomal dominant mode of inheritance are also known to occur. The importance of polythelia lies in the fact that they are associated with genitourinary malformation and malignancies and are also associated with malformations of other systems like cardiovascular system, vertebral system, and cranial central nervous system. The genitourinary malformations and malignancies are present in about 23 to 27% cases of polythelia. The common malformations of the genitourinary tract being supernumerary kidneys, renal aplasia, hydronephrosis, polycystic kidney disease, duplicated renal arteries, etc. Polythelia is also associated with 19% of the patient with renal adenocarcinoma and 16.5% of the cases of end-stage renal disease. It is also associated with carcinoma of breast and testicular carcinoma. In a study by Gaudet et al., it was estimated that the risk of testicular carcinoma in men with polythelia is 5 times higher than in men without an accessory nipple. Supernumerary nipples are also found as a part of various syndromes like Turner syndrome, Fanconi anemia, fetal alcohol syndrome, etc. So, conclusion, the accessory nipple and breast respond to hormonal changes in the same way like the normal breast tissue and are prone to benign and malignant pathologies like normal breast tissue and should be taken seriously. All cases of polythelia should be investigated and evaluated to root out any genitourinary or other malformations. Surgical treatment should be considered in cases of suspicion of malignancy and for cosmetic concerns. These are my references, and thanks everyone.
Thank you very much. Yes, it's rather uncommon, especially in male patients. My little question is, was he very keen to have this operated because it was not of any major size, so he could have lived with it. But is it really because for diagnostic reason or for cosmetic reason that he went for surgery?
No, sir, he was going to get married and he noticed that it was not looking very good in the mirror. That's why he wanted to get them removed.
Right. Now he has got scars in those regions, so that will also not look really nice. But then, yeah, that's an option for sure. Okay, thank you. Any other question from
Dr. Kunal, a very well brought out rare case report. What are the principal syndromes which are implicated for this development?
Sir, supernumerary nipples may be associated with Turner syndrome, sir, Char syndrome, fetal alcohol syndrome, Simpson-Galleby-Behel syndrome, sir, and sir, cranioplateal dysplasia.
Okay, so the most important the things which you should remember is the ectodermal dysplastic syndromes like Havel syndrome and Ruvalcaba-Meyer syndrome, all those things. But fine. Having said that, do you have any information about what are the potential pathology which can arise from this supernumerary nipples?
Sir, the supernumerary nipples may develop Paget's disease of nipple because in many cases it has been seen that the supernumerary nipples has a large number of clear cells of Tokar, which indicate that Paget disease can happen in the nipple. And also, sir, it can undergo carcinomatous changes also, sir.
What is the principal age these type of hormonal changes can influence the supernumerary nipples? Say in your patient, it was more for cosmetic reasons. But
Yes.
do they have any specific age where they can land into trouble, or you just allow them to be on follow-up alone?
No, sir. The patient usually develops the symptoms. In case of female patients, the symptoms usually occur during puberty, menstruation, lactation, and pregnancy. And in male patients, sir, we usually the symptoms usually occur around the age of 40 to 50 years because the renal complications usually are more common in younger ages in cases of supernumerary nipples, sir.
What is the incidence of urinary tract malignancies in presence of supernumerary nipple?
Sir, it varies between 13 to 18%, sir, malignancies.
What is the common histology of urothelial malignancies you see in supernumerary nipples?
Sir, it is adenocarcinoma, sir.
Thank you.
Thank you, sir.
Thank you, Dr. Kunal. Thank you, judges, for such a exemplate session. Our next presenter is Dr. Krishan Kumar, and he will be talking about vascular complications due to cervical rib, a rare case report. Dr. Krishan, please start sharing your screen.
Yes, sir.
Please make it full screen. Yes.
Yes, sir. Good morning, judges. Myself is Dr. Krishan Kumar, JRA3 from RIMS Ranchi. My guide is Dr. Sheetal Manwa, sir. My topic is vascular complication due to the cervical rib, rare case reports. A definition that the thoracic outlet obstruction is a disease caused by compression of subclavian vessels and or brachial plexus as it travels through the thoracic outlet. Cervical rib originated from the 7 cervical vertebra and they extend across the thoracic outlet and fuse to first rib. Thoracic outlet syndrome is classified into 3 distinct types. Neurogenic thoracic outlet syndrome, venous thoracic outlet syndrome, and arterial thoracic outlet syndrome. Arterial thoracic outlet result of obstruction of subclavian artery, usually caused by cervical or anomalous splenius muscle fibromuscular band, and pectoralis minor tendon. With the majority of surgical cases, 74 to 100 attributed to abnormal ribs. In my case report, a 20-year-old female presented with pain and burning sensation over right hand and finger since 4 months. Color changes in distal swelling for right hand since last 1 month. On the examination, revealed non-palpable radial pulse. Other pulses are normal. The right forearm and hand are pale and cold. All 5 distal fallings of right hand are gangrenous changes seen. And other physical and systemic examination within the normal. Here, X-rays show the right cervical rib. On a Doppler study, the significant poor blood flow in the right distal segment of the brachial, radial, and ulnar arteries. Here, a CT angiography here show a large cervical rib on the right side, impinging over right cervical subclavian artery, and a numerous collateral and visualized supply by lateral thoracic branches supply into the arm and forearm. The treatment is part of the operation. The cervical rib excision are distal to impinging distal to subclavian thorabrachial artery obstruction. That there are thrombus also there. So thrombectomy also and then amputation of distal fat. Post-operative, so the uneventful and radial pulse are palpable after the patient discharged on POD 15. Discussion. Here the cervical rib is congenital anomaly. Incidence about 0 to 0.5% to 3%. Commonly it is bilateral, often it unilateral also. In chronic arterial compression by cervical rib leads to claudication, thrombus formation, and possible embolization. Atrial thoracic outlet syndrome remains asymptomatic until embolization occurs. When the arterial thoracic outlet syndrome is suspected, competent imaging modality are used to detect the stenosis, thrombus formation, and vascular compression, and further to identify the structural factor predisposing to arterial obstruction. In this case, the symptom sign of the hand and finger coldness, pallor, absence of distal limb pulse, and delay in the capillary filling. Treatment goal are the reconstruction of reconstruction of the distal arterial blood flow and complete relief of the vascular symptom. Surgical management, abnormal rib removal, scalenus pectoralis muscles release, and anomalous first rib resection if indicated. If subclavian artery cannot be provided sufficient distal arterial flow, we provide adequate decompression, reconstruction with grafting should be done. Conclusion, for successful treatment of arterial thoracic outlet syndrome, urgent assessment, accurate identification of causative factor and compression site, early diagnosis before thrombus of artery event, and surgery with adequate decompression of subclavian artery. Here are my references. Thank you, sir.
Thank you very much. Just want to ask why the patient was so late in presentation. I mean, did she actually consult anybody in between, or?
They consult many centers, but not the actual diagnosis. Not the same.
The chest X-ray was not done before.
No, sir.
Right. Okay.
Thank you, doctor, for good bringing out of one of the important complications of cervical rib. I would like to ask you, what are the different types of approaches you can remove a cervical rib?
Sir, there are two differences. Supraclavicular exposure or transaxillary access.
Okay. What makes you to decide the approach? Is there neurogenic presentation or a vasculogenic presentation? Does it have any binding to the approach?
Sir, for supraclavicular approach, if aneurysm formation any neurogenic compression, then it is best for supraclavicular approach.
What is the percentage of patients come with isolated vasculogenic presentation and a combination of presentation, or an isolated neurogenic presentation?
Most common, more than 90% neurogenic with complication, about less than 1% arterial compression.
What are the reasons for very late presentations?
Sir, in the arterial thoracic outlet obstruction, because this chronic compression, slightly compressed, then firstly claudication, then goes to then goes to claudication, then Raynaud's phenomena, then color changes, ischemic changes seen in distal part of the extremities.
In spite of many of the unstudied population having cervical rape, only few go on to develop symptoms. What are the factors implied upon?
Sir, any exposure which any maneuver which led to compression of thoracic outlet, then it develop in a heavy heavy lifting worker, then they develop complication. Yeah, whiplash injury also cause the thoracic outlet also.
Thank you.
Thank you, judges. Thank you, Dr. Krishan Kumar, for a good presentation. We move on to our next presenter, which is Dr. Avinash Kumar Sinha, and he will be presenting on sacrococcygeal teratoma. Dr. Avinash, please start sharing your screen.
Yes, sir. Just a minute, sir.
No, it's not visible. Please start. Yeah, it's coming.
Sorry, is it visible?
It's still opening. Yeah. Make it full screen.
Yes.
Please make it full screen. Yes. Please start.
Good morning, sir. I am Dr. Avinash Kumar Sinha, a general surgeon from the Bokaro General Hospital, and I am going to present a very interesting case of sacrococcygeal teratoma. So, as we know, that teratoma is a tumor of the retention of the pluripotent stem cell, and among the non-CNS teratoma, sacrococcygeal teratoma is the most common. The incidence of sacrococcygeal teratoma is about 1 in 40,000 live birth, and is the commonest congenital tumor in neonate, and is more common in the female. Majority transformation is low. Diagnosis can be made by the ultrasonographic examination or the alpha fetoprotein monitoring or the fetal MRI. So the objective of this presentation is that being an uncommon tumor, it is its knowledge, its prognosis, and its multidisciplinary approach in the second tier city like Bokaro is important, and along with that also to predict its outcome. So in our case, sir, a 10-day premature female child delivered by cesarean section presented in the surgical OPD with a large mass in the sacral region of size about 12.5 centimeter into 13 centimeter in the gluteal region with ulceration in its posterior aspect. The patient was admitted. Her blood investigation was sent, which came out to be normal. X-ray was done, which revealed a large mass projecting from the lower pelvic region, and it also showed the extent of the tumor. The pre-anesthetic checkup was done, and the tumor was excised with the consent via the chevron incision, along with the removal of the coccyx. The post-operative period was uneventful, and the patient was followed up for 1 year, which was not, and there was no recurrence, and she attended a development milestone very well. So in this diagram, this is the pre-operative diagram where the large tumor in the sacral region is present with the ulceration on its posterior aspect. The X-ray was done in which the large tumor with some extension into the coccyx can be seen in this X-ray. And this is a post-operative case in which the tumor has been excised. So, sir, coming to discussion, the sacrococcygeal teratoma is a rare tumor, but is most common malignancy of the germ cell in newborn and child under 2 years of age. In adult, they cause the no symptom, but may progress to cause the back pain, weakness, incontinence, and even in some cases, many sacrococcygeal teratoma are incidental on routine prenatal ultrasonographic examination. Other specific technique include the CT scan and the MRI to diagnose the tumor, evaluate its size and extent of the tumor. Among these, the fetal MRI is the best. Sacrococcygeal teratoma can grow rapidly in fetus and may result in the heart failure due to increase in the blood flow and blood flow condition called as the hydros fetalis. In benign or immature teratoma, there will be a small rise in the alpha fetoprotein and the beta HCG, whereas in the case of the malignancy, there will be a rapid rise in the alpha fetoprotein and the beta HCG. Also, alpha fetoprotein is prognostically important. According to the American uh, Academy of the Pediatric Surgery, they classified the sacrococcygeal teratoma into 4 types, among which the type 1 and type 2 are most common, and the type 3, type 4 are the rare. In the type 1, which is usually not associated with the malignancy, and the type 4 is often associated with the malignancy. In our scenario, the tumor is a type 2. And the main treatment is the complete dissection of the tumor of the coccyx with the coccyx. If the coccyx is not removed or delayed in the treatment is done, there may be the increase in the risk of the malignancy and the recurrence of the tumor. So, to conclude, this is the uncommon tumor, but the most common of a large tumor in the first 3 months of the life. Majority are benign, and the risk of recurrence and the malignant transformation is low. And along with that, the multidisciplinary approach is required in this treatment, in this tumor treatment. Along with that, the alpha protein and the ultrasonography is the key to detect the recurrence or the postoperative complication. These are my references. Thank you, sir. And there's a golden ribbon which signifies the tumor of the childhood and the adolescence.
Thank you very much. Thank you. You mentioned there's a low risk of recurrence, especially if it's malignancy. How would you tackle that?
For the low recurrence, sir, I have to follow up the patient, sir, for the up to three years of the age to determine whether the recurrence has occurred or not, sir.
But if the recurrence happens, then what will you do? How will you manage it? Would you re-excise or is any
Yes, sir. If the recurrence has happened, sir, in such condition, I will plan for the re-excision along with if the tumor is come out to be malignant. In such condition, chemotherapy is also to be administered along with the resection, sir. Resections.
What kind of chemotherapy? What sort of chemotherapy?
In such conditions, sir, bleomycin, etoposide, cisplatin, or yes, sir. This can be given to the patient.
Okay. Anybody else from other juries? Anything else?
Very well done, Minash. I would like to know 2 things. What is the incidence of malignancy in sacrococcygeal tumors?
It one is very rare, sir. If the coccyx is not removed or if the tumor is not excised properly, then only in such condition.
Is benign more common or malignancy more common?
So the benign is more common, sir.
What is the type of malignancy which is more commonly implied in sacrococcygeal teratoma?
This one is, sir, the germ cell tumor, sir.
Okay, or the other pathologies one can get.
Yes, sir, they can get the yolk sac tumor, sir, in such condition, or the germinoma in such conditions, sir.
What is the percentage of people who end up having some form of neurological loss after the surgical removal?
Sorry, sir.
No worries. All the very best to you. Well done. Bye-bye.
Thank you, sir. Thank you, Dr. Arnab, sir, Dr. Sheetal Malwa, sir, and Dr. Kanagaval, sir, for chairing this session. Please accept this token of.
Thank you. Thank you very much. Started with certificate.
Move on to our next session, which is complications of surgery, and Dr. Sumegha Rana will be taking care of it. Over to Dr. Sumegha.
Yes, thank you, Satvir. And now moving on to our next session. Complications in surgery. Good morning, everyone. Our next session is complications in surgery, where our chairpersons are Dr. M.L. Saha and Dr. Sanjay Kumar. I welcome both of our chairpersons. Welcome, sir. First, let me introduce Dr. M.L. Saha is Professor and Head, Department of General Surgery, IPGMR, Kolkata. And we have all read his books. And he's a famous examiner, and he's a master in his field, as we all know. And now I welcome our next chairperson, Dr. Sanjay Kumar. He is Chief Consultant in Surgery, Tata Motors Hospital. Now, without delaying time, I'm telling about the rules. We'll be getting 10 minutes for each speaker. Sir, are you there, sir?
Yeah.
Yes, sir. Welcome, sir. Yes, now we can see you. And our first speaker for this session is Dr. Arunima Verma with her presentation, Obscure GI Bleed with Burst Abdomen. We all know ma'am very well. She's yes. So I request Dr. Arunima to share her screen and start her presentation.
Thank you very much, Sumekha. And without any further delay, I would just present because we are running a little late. So as a part of organizing team, I would try to be very much on time. Is my screen visible to all?
Yes.
So my presentation is basically this, the theme being renaissance of general surgery. I thought that burst abdomen is something that a general surgeon would usually come across because every surgeon does a laparotomy. And burst abdomen is a very severe post-operative complication which no surgeon would like to see in his career. But on a fifth post-operative day during a ward round, you remove the dressing and you see this. And definitely it's not a good start of a day. So this was a 59-year-old lady who had come with complaints of black stool off and on for 6 years. Previously, she was investigated and a right colonic telangiectasia was reported. And she was managed with argon plasma coagulation at Asian Institute, Hyderabad, 4 years back. In this last 1 month, she was having melena and she had something like a hematochezia of one episode. And she had repeated fall of hemoglobin for which we were giving a blood transfusion off and on. This was during the COVID time and there was no travel possible. UGI and colonoscopy was done by me and I did not find anything. Even a CT did not report anything. So we planned that we would do an exploratory laparotomy and an intraoperative colonoscopy. So a midline laparotomy was done and intraoperatively a colonoscopy was done by making a enterotomy 25 centimeters proximal to the IC junction so that I could see the whole of the small bowel as well, because I was not able to locate till the second part of duodenum as well as the colon. So I wanted to see the small bowel as well. So I did an intraoperative colonoscopy in this patient. And the enterotomy was after doing a right hemicolectomy. I did a right hemicolectomy keeping in mind that she had a telangiectasia of the right colon. And the enterotomy was brought out as a ileostomy. And the purpose of this was that because we did not know the source of bleeding, so suppose she continued to bleed in the post-operative period, we would know from where, whether it is proximal or is it distal that is bleeding. The laparotomy was closed with proline number 1. It was continuous sutures were done and skin were done with staplers. So during the post-operative period, she was having serosanguinous discharge. So a few stitches were opened, but on the 5th day, she had the wound dehiscence. And by 6th day, what we could see was broken sutures with bowel popping out. So on that very day, we took her up for re-exploration. All sutures were removed. Thorough lavage was given. And I was able to find the sheath. So I repaired it with nylon 1 and a subcutaneous drain was put. This is not necessary, but because she was very obese, I thought it is better to put it there. Skin was closed with mattress sutures. This is the intraoperative picture, and what you can see is there is a lot of slough we can see on the bowel wall. And this is the intraoperative picture again, and this is just the magnified view. We can see this is the interrupted suturing that I did for the sheath. So in this second post-operative period, again, her upper part of the wound showed wound dehiscence. So we tried to manage it with VAC. We put a VAC, but the VAC was not successful because there was interference from this stoma side. Now, this patient had a laparotomy wound as well as a stoma, and when we used VAC, the whole fecal matter was getting sucked into that. So we had to abandon VAC. So we decided to let it heal by secondary intention. And these are the pictures that she was healing with secondary intention. The sheath remained intact. And this is the final picture where you can see she has healed well now. Another case that has recently happened is another wound dehiscence with visible bowel loops. You can see broken nylon sutures, and there's a mucus fistula with colostomy. Now, this was a 55-year-old lady who had had a laparotomy somewhere outside for a tubo-ovarian abscess and was in the gynae department. During that period, she developed bowel distension, and she was referred to us. But by the time she was referred to us, she had developed a massive colonic perforation. We did a re-laparotomy, and a segmental colonic resection was done, and the colostomy and mucus fistula were brought out. That time during the laparotomy, a sigmoid colon growth was felt, but definitely it was a damage control surgery, so my team did not remove that growth at that time. She had severe to moderate cough in the post-operative period, and let me tell you that we tested her again. She had come COVID positive, and she developed a burst abdomen in the sixth post-operative day. So a laparotomy was done, and this time I resected the sigmoid growth and a Hartmann's was done. Again, I was fortunate enough to find the sheath, and again I used the same method of closing it with interrupted nylon 1 suture and skin with mattress suture. So just to carry this discussion, it is burst abdomen is defined as a post-operative separation of abdominal musculo-epineuritic layers. There are various terminologies used, like abdominal wound dehiscence, acute laparotomy, wound failure, and burst abdomen. Incidence reported in literature is 1 to 3% of the abdominal operations, and dehiscence usually develop within 7 to 10 days post-operatively, but may occur even up to 20 days. Mortality is very high, reported from almost 14 to 50%, more common in males, though in my case, both were females. So if we look at literature, in 1982, it reported around 1.7%. Even an article that has been published in 2020, it has reported the range of 0.9% to almost 6%. So if we look at the type of surgery which are prone to developing burst abdomen, it is mostly the emergency cases where you find more of burst abdomen. And looking at the type of discharge that you find, it is usually serosanguinous. So having a serosanguinous discharge is not a good sign. Purulent and feculent, every surgeon is very conscious. But even a serosanguinous discharge in post-operative period should keep you on your guard. The risks of burst abdomen are that there is risk of evisceration. There is definitely a need for some kind of intervention. There is a possibility of repeat dehiscence, as we had in one of our cases. Surgical wound infection and later incisional hernia formation are what you're looking forward to. The predisposing factors are multiple, like upper midline and vertical incision, choice of the suture material you use. If you have used tension during your repair, that is a very bad technique. Severe cough, vomiting, and distension in the post-operative period need to be taken care of. Surgical wounds of peritonitis, acute abdomen, or major surgeries like pancreatic, hepatic, gastric surgery, especially for malignancy, are prone to this. If the patient has ascites or a previous laparotomy, or if your surgery duration has been more than 150 minutes, these are other predisposing factors. And definitely the condition of the patient, like anemia, jaundice, hypoproteinemia, uremia, old age, steroid, and malignancy, these all predispose to burst abdomen. In our patient, we have seen she had cough. The second patient had severe cough. Both patients were obese. Second patient had malignancy. The first patient had severe anemia, and both had an element of immunocompromised status. So these were the predisposing factors in my patient. Looking at the management of this complication is relatively unexplored area in the field of surgery, and treatment is associated with unsatisfactory outcome many a times. It can be managed by conservative methods, by saline-soaked gauze dressings or negative pressure wound therapy, or operative managements from temporary closure to a permanent closure to plastic reconstructive procedures. The goal of management is usually to close the facial defect as early as possible without precipitating abdominal compartment syndrome. Just remember that this is the most dreaded complication when you're trying to close. Technically, you might be able to close, but if you land up with abdominal compartment syndrome, the patient might not make it. And that is one of the reasons for the high mortality in these patients. And recommended is that appropriate efforts should be made to attempt definitive facial closures during the initial hospitalization, because the risks with open abdomen are local, like GI fistula, intra-abdominal abscess, abdominal infection, bowel obstruction, and systemic, like SIRS, derangement of fluid and electrolyte balance, sepsis, and catabolic state. So as I mentioned, surgical options can range from simple packing, which is usually preferred if you have a questionable viability in intraperitoneal sepsis. Only skin closure technique is abandoned nowadays. It was done, but it did not prevent ACS, and it varied from 13 to 36% even in these cases. Bogota bag may be used for patients who are transferred, especially if it is a kind of a damage control you have done and you're transferring to a definitive treatment center. Synthetic patch, vitamin patch, vacuum assisted closure, all are used. Facial bridge, by using the closing the facial defect by bridge of a synthetic or a prosthetic or a biologic mesh, can be used, and this can then you have a planned ventral hernia which you can manage later on. So which option? So this is an article published in 2018. They did a randomized prospective study, and they suggested that mask closure with continuous suture is one of the best methods for abdominal wall defect closure in burst abdomen. And numerous trials and meta-analysis have found that mask closure is superior closure method. Insect trial was done for knowing the best way of abdominal wall closure, and it concluded that we need to have better designed randomized control trials to have a consensus on the best method. But I still feel that interrupted closure is one of the best methods, which I have found in both of my patients. And the takeaway message would be that burst abdomen is a preventable condition. You need to use the right technique and the right material. Optimize the condition of the patient as far as possible, and management option has to be decided depending on your case. This is my team of surgery at Tata Motors Hospital. It's a wonderful, vibrant team. This is the company I work with, a very noble company, and that is my hospital. And I thank you all for your patient hearing. Thank you very much. I'm happy to take up questions and comments from the chairpersons.
Yeah, Dr. Arunima, it's a nice presentation. And really, we face up with such burst abdomen patients. And you rightly pointed out that the idea of closure is to have a good post-op recovery, and hernia incidence is not very high in that situation. But the problem is, you see, when one of the patient has burst abdomen. Most important is to find out whether you are closing under tension or not. If there is minimal amount of tension, one should not venture for closure. It is better to have a laparoscopy and then manage with a VAC system of closure. So in the first case, actually, I think the cause of bleeding was not ascertained even before you venture for the second laparotomy. So is it what to have a CT angio to localize the bleeding site?
So we did have a CT angio. That also did not localize. And what I said was that she was reported to have a telangiectasia in the right side of colon. So I did a right hemicolectomy. And the purpose of bringing out the stoma was to know whether she's still bleeding, but she was not bleeding anymore. So her cause was taken care of. She did not bleed after that. That is why we were successful as far as managing her bleeding was concerned. But unfortunately, I have to close the ileostomy now, which I am not touching her right now after so much of post-operative issues.
Yeah. Okay. The paper is open for any question from the audience.
Yeah, yeah. I've got a question. Like, Arundhama, first I compliment you for your wonderful presentation and managing both the patients very, very effectively. Now, I've got a question for the first case. You mentioned that the patient got a history of laser intervention for telangiectasia at Hyderabad around 5 years back. The question is, did maybe annual colonoscopy or a screening program could have helped in coming up to diagnose the cause of bleeding, because this patient had a history of 5 years and maybe earlier also she was bleeding. So if she would have been under regular follow-up, was it possible to detect the site of bleeding which resulted in an emergency this time?
Sir, telangiectasia at times, because obviously there are different types of colonoscopes which can view this. There are magnification colonoscopy, there are other methods. The simple colonoscope, sir, because we did the colonoscopy just before the operation, we were not able to see it even when she was bleeding. So in this particular case, I would not see, but yes, she definitely needs to be in follow-up, at least with a stool for occult blood, so that whenever needed, she could have undergone a colonoscopy. A follow-up in such patients is definitely a must. But I would not say an annual colonoscopy is recommended for all these patients, because our normal colonoscopes might not be able to, visualize this telangiectasia.
No, I'm talking about like Hyderabad. Like the patient has intervention. So if
Yes,
she would
sir.
have reported to the Hyderabad Institute or maybe the institute where they have done
Sir,
intervention.
she has had a follow-up there, but they did not
Yeah.
call her back after that. Basically, she was no more bleeding. She had a stool for occult blood. It was after 4 years that she started having this drop in hemoglobin. So I don't think, because that is not screening for benign conditions is not a part of colonoscopy. I think Dr. Saha can comment on this. We do not have screening as far as benign conditions are concerned, sir. This is what I know.
With the permission of chair, can I come in?
Yes, sir, please do.
See, these are all cases of obscure GI bleed, which is a huge challenge to any, even a tertiary center. In good old days, there was some role of a blind, in these cases, we are not able to find is a right hemicolectomy, because 90% of those obscure GI bleed is usually due to angiodysplasia in an elderly patient and associated with some heart lesion. But in even the best of the centers, sometimes the cause of obscure GI bleed is so difficult to find, whether we do a radioisotope scan, and finding angiodysplasia, which is not bleeding at that time, doesn't mean that is the cause of the bleeding. So it's a challenge.
I agree, because as far as my personal experience is concerned, because we had two young patients. I recall around 7 years back, two young patients again presenting with massive bleeding, and again what Arundhama did, we did the enterotomy to locate from where exactly the patient was bleeding, and ultimately we went for right hemicolectomy. So sometimes despite colonoscopy or whatever facility you have, especially we had a difficulty in coming to a diagnosis, and ultimately these patients, because the hemoglobin dropped to the extent that they both were hemodynamically unstable, so you have to intervene and you have to go for the right hemicolectomy. So yeah.
Can I add? Yeah.
Session. Yeah, I'm really sorry because we are running out of time, and now
No, I'm just want to add one point here. Nice presentation, Arunima. See, obscure GI bleed, you should always rule out small intestine also. So
yeah, that is what I did. That is the reason for the intraoperative colonoscopy.
yeah, that's what. Because obscure GI bleed, it's maybe some small lesion, either IBD and Crohn's disease from the proximal intestine. So what in this case, capsule endoscopy can have been one useful entity if it's done earlier also.
Yes, we had all that in mind, and that is why I mentioned COVID era, where there was no travel possible.
Yes.
Okay. And then they did a small bowel enteroscopy.
Yeah, we did that. We did that intraoperative.
And now we have moved to our next presenter, Dr. Ajay Mandal. He is consultant GI and HPV surgery in CMRI Kolkata, gold medalist in his MS, and now he will present his topic. Welcome, sir.
Thank you.
And now
Thank you, Sumedha.
Presentation with your screen share.
Good morning, Makunda.
Yes, good morning.
So here I am going to present a very rare and unique complications that I managed laparoscopically. Yeah. So now it's visible or audible, everyone?
Yes, you are visible and audible.
Yeah, thank you. So iatrogenic injury during the surgery itself is a nightmare for the surgeon, and definitely it's also not good for the patient. So here is a very rare case of obstructive jaundice. This patient came from the Dhanbad, my native place, and he has known case of simple liver cyst since many years. He recently developed jaundice while investigations found to be have obstructive pictures, and while CT was done, it shows that there is a large cyst in the hilar regions that is the cause of obstructive jaundice. Means investigation reveals the dominant cyst in the polycystic liver that is the reason for obstructive jaundice. So here is the CT pictures. I'm not going the details of other investigations, the blood parameters, other things. I'm going straight to the CT scan. Here you can see there's a large cyst and the triple phase CT scan of the abdomen, and this is a very large cyst. Now you can see the portal phase. This is the portal vein is stretched, and now you can see there is a hilum. So here you can see this is stretched, means the hilum is completely stretched and blocked due to this large cyst. This is the reason of obstructive jaundice. We did MRCP also to rule out any stone related pathologies there or not. So nothing was there. So this is the main cause of the obstructive jaundice. After seeing this investigation, now it's in our mind what to do. Now it's easy, because if you decompress the cyst, the treatment will be over. The decompression of the cyst will release the pressure at the hilum, so the jaundice will be relieved. That is the treatment also. So while we planning for the decompression, this can be done by the laparoscopic method or by the open method. I usually prefer to do by the laparoscopic. So laparoscopic deroofing of the cyst will treat the condition, but unfortunately I landed in some other problem that I will demonstrate in this video. So there is lots of adhesion inside the abdomen. There is a past history of right nephrectomy in this patient, so I have not mentioned that one. Here you can see this is the large cyst. This is the cyst. These are the previous adhesions and cyst up to here. So now this is the things. This is the colonic area. I am doing adhesiolysis so that my surgical field should be the clean. But we should all know where should stop the dissection. I'm go on doing and forgetting about the main concern. And finally, something happened that should not have happened. That is, now you can see in the video, just wait, it will come. Yeah, this is false. Now, this area, now we can have managed by this much of adhesiolysis only. This is the cyst. So now I am doing more laterally so that the colon and hepatic flexure of the colon will go down. This is the gallbladder. Yeah, we should not have done more dissection, more laterally. Now finally open up the hepatic flexure of the colon. So what to do next? There is a lot. Yeah, now you can see this visible. Here you can see that's the colon. The small rent is meant with the help of the harmonic scalpel. After that also I thought कि नहीं कुछ नहीं हुआ है, let's move on. First time I didn't recognize कि कुछ hole हुआ है कि नहीं. Now you can see there is a hole, the small hole. So this is the most important, that identification. I made identification during this procedure only. Now we have the two options: either do the ileostomy in this patient, that is the safest option, or do the primary closure and finish this procedure. But doing ileostomy in this patient, again, it's a morbid procedure, but definitely it's with less complication. Finally, after so much of discussion with patient relative also, see this thing is happened, because I am very means what you can say, I am loyal to this patient. This is something happened, I have to do and I have to manage in this way. So I had given the option of ileostomy and primary closure, and I had given see if the primary closure will leak, we have to do the ileostomy in the later date. So they also understand my concern, and that agreed for whatever the best you can do, you do it. So now you can see this is the hepatic flexure colon. A little bit mobilization. This the primary closure was done with the help of the 40 vicryl sutures, interrupted sutures, single layer interrupted sutures, nothing extra. Here, this one, first suture. Yeah. So around 5-6 interrupted suture was placed, and after that I placed one corrugated drain, and rest of the deroofing of the liver cyst was done. Yeah, first suture is placed. And luckily, we waited for 5 to 7 days with the drain in place. Luckily, this didn't leak. So I am definitely one lucky one, and patient is also lucky one. So I'm just forwarding it. 2 sutures, 3 sutures. Yeah. So this is completed. Now the laparoscopic deroofing of the cyst was done to complete the procedure along with the cholecystectomy. So this is a very rare complications I have not encountered till now, but this is unfortunate. But finally, patient managed to survive. The take-home message for this one: we should all aware of the complication that can happen intraoperatively, means iatrogenic complication. The most important thing, how we handle it. This is most important, and we should always be prepared for how to do if something is gone wrong. So this is all about the presentation. Any question, other things I can take? Thank you.
Nicely managed patient, Dr. Mondal.
Thank you, sir.
My point is, probably you have excluded the hydrated cyst by doing some hydrated antigen study. So if it is simple cyst causing compression,
Yeah.
why don't you consider for a image guided decompression?
Yeah, I discussed with our intervention radiologist. This is simple cyst, sir. This is not hydrated cyst. I have excluded. I have not mentioned all those things. I have excluded already.
Fine.
Intervention radiologist told ki we can do pigtail drainage, but there are chances of recurrence. It will recur after some time because there is no deroofing. Only the fluid will be aspirated. So there will be the recurrence because the once that opening will be closed, the fluid will recollected and the chance of recurrence will be the very high.
Agreed, but point is most of the simple cyst does not require treatment unless it is symptomatic or it is having some complications.
That's why, sir, this patient has presented to the obstructive jaundice of bilirubin of 12.
Yeah. But
that's why this is very rare. Yeah, this is very rare complication, sir.
Yeah. Okay. But
very rare complications of simple cyst and very rare complication of colonic injury also.
Yeah, actually, most of the right colon you can manage with primary closure, but you see the patient has got very. I can appreciate there are a good amount of even hard stool in the right colon.
Yeah.
So it will be a bit risky. You have explained. I agree that you have explained everything and then did. So if the particularly it's a thermal injury, and you need to refashion the margin and you close. But there should be no inhibition in doing a.
Yes, no, definitely there should not be any inhibition. And my take-home message to the other surgeon who are doing in the periphery: if you have definitely encountered the colonic injury, don't try to venture with the laparoscopy only. Open it, do it properly. Like there should not be any low threshold for the ileostomy and stoma, any type of the stoma. There should be the low threshold.
Okay, open for discussion. Yes.
Ajay, you handled it very nicely. And the best thing is you communicated very effectively with the patient, and patient party decided what are the options you have given, and then taken a call go for the primary repair. Ajay, I have got one question. Like in your dissection laparoscopically, now if you have to do a similar case next time, will you do something differently?
I will prefer to do more with the scissors, and I will try to avoid going close to the colons. And when the operative field is clear, should not go unnecessarily dissecting, go on. In this case, the same thing happened. I have enough area in medially, but I don't know why I'm go on dissecting laterally. क्या है थोड़ा सा और नीचे कर देते हैं, you will get more wider area. So ultimately, I injured the colon.
Do the adhesive up to the point you require, because it's going to reform.
That's what. Definitely, sir. You're right.
Adhesive is going to reform.
Yeah, that's the learning session for me also. We should not go on dissecting.
Nice.
Thank you.
Okay, thank you. Now we are about to end the session. And these are certificates for our chairpersons, Dr. ML Saha and Dr. Sanjay Kumar, and certificate of participation too for the presenters. And now the next session will start, and Dr. Saha, you please be there for the next session also. That is
Yeah.
the debate.
Yes, I'm
Which
there.
Dr. Sadhvir will be doing. Okay, over to you, Sadhvir.
Good. Can I intervene for a minute? Good morning to everybody. I can see Chintamani and our dear friend, Vice President-elect Siddesh. Good morning and welcome. Greetings from Jharkhand ASI. Good morning, to all of you. Yeah. So we'll
Sunil, don't forget to see me.
Good morning, good morning, good morning. The
Abhay also is there. I think I
for
saw
20-25 minutes. I'm sure you all will be here with us. Okay, Sumega, get on with the scientific program.
Very good morning to all the esteemed surgeons present here. To start our next exciting session, we are having a very good debate, and this debate says general surgery, a career for young surgeons in the present era. And for the motion, Dr. Makhan Lal Saha will be talking about, and Dr. M. Kanagaval sir will be against the motion. And moderator will be Dr. Chintamani sir. And as we very well know, Dr. Chintamani sir, an extemplate educator, and Dr. Makhan Lal Saha sir, who every undergraduate and postgraduate has read Makhan Lal Saha's book, and Dr. M. Kamagaval, who is also an extemplate educator, and his videos were followed by all of the surgeons. And so we ask Dr. Chintamani sir to take over.
Thank you, Satyavir. Good morning to everybody, Dr. Abhay, Dr. Siddesh, and on air. Many, many congratulations, Dr. Siddesh. Truly a joy to see you again. Now, we have a very interesting debate on, and I think this is something that is being discussed almost everywhere, although we reach nowhere, but then still it's worth it. General surgery as a career, and both Dr. Makhan and also Kanagwell are into training and teaching. So I'm sure we'll have a very good and exciting discussion. I'll request the other participants and the others who are watching, especially the postgraduates, to also be ready with their questions, because we must have questions. There's no point having debates between two individuals and then at the end of it, me concluding it, although I'll do my best to do so, but everybody would have a viewpoint. So I think without wasting much time, because I think we're already late, I'll start off with, for the motion, Dr. Makhan, are you ready with your slides? You can start sharing and we can get on with it.
Yeah.
And you'll keep to time, Dr. Satyavir, you'll keep the time, right? Thank you so much. We'll have 10 minutes of presentation each and then rebuttal and some moderation at the end of it. Over to you, Satyavir. Dr. Saha, you can share your slides now.
Yeah, I'm trying. Is my screen visible?
Very much.
Yeah. Can I start?
Please.
Okay. The debate today is general surgery as a career for young surgeon in the present era. So present era is the era of technology explosion. So how do you become a general surgeon? It's a MBBS for 4.5 years, followed by 1 year of internship, and then most of the students go for a lot of coachings, and they spend about 1 to 2 years to get into an MS course that goes on for 3 years. And most of the state has got some bond, maybe varying from 1 to 3 years. So it takes about 9 to 10 years to come out as a general surgeon. And what do you do at the end of your MS course? There are a lot of options. After that, you can either join a government service, you join a private hospital as a registrar, you can build up your own clinic and start practicing what you learned in the period of your MS course, or there are a lot of youngsters who will go for super specialty MCH or DNB in super specialty. So who is a general surgeon? You see, the term is changing, and I consider general surgeon is a versatile genius. He is accustomed to do good number of abdominal surgery. He is a very expert in hernia surgery, the skin soft tissues, breast endocrine, and most of the trauma patients are well managed by general surgeons. The newer areas of minimal access and robotic is again in the domain of general surgery, but you need some amount of training and some certificate courses so that you can venture onto this minimal access and robotic surgery. And how a general surgical training goes on. It's a 2.5 year posting in general surgery during your course, and you have rotational posting in broad super specialties. And now there is a shift towards super specialty after your MS course in the new generation. And it's true that super specialty creates a highly skilled persons in particular areas. But I believe there is still a huge room for general surgeons, particularly in a country like India. Why? You see, if you consider India, it's a vast country with huge health setup, and basic surgical care is still not available in all rural and suburban hospitals. I believe an accomplished general surgeon is an asset at any subdivision or district level hospitals. And if you go to the caseload in surgical patients, the emergency and accident cases are almost 50% of your surgical work, and a general surgeon are the key persons for management of accident emergency cases. And a broad knowledge of trauma care by a general surgeon can provide a holistic care in the complex injuries. And a competent general surgeon can manage most of the emergency cases. Yes, I agree. Super specialty is posing a threat to general surgery, and we have to believe that in addition to this super specialist coming up with MCH and DNB degree, we need a huge number of general surgeons to manage our vast surgical patient in rural, suburban and most urban hospitals. And I believe a young surgeons who opt to be in general surgery will continue to be a good option as a successful surgical career. However, I believe that there is tremendous progress in different stream of surgery with advent of newer techniques, with advent of newer gadgets, and there are different super specialties, even subspecialties. In GI, now you have subspecialties of colorectal, hepatobiliary pancreas, upper GI. So it is difficult for one person to cope with all advances in surgical field. However, once you go for this super specialization and subspecialization, you confine yourself to a narrower field. But I agree that there has been a crazy new generation to achieve a MCH degree or DNB in super specialty degree. And there is a prevalent trend of super specialization. And apparently, general surgery is losing its sheen in the form of glory and scope. And this image of general surgery is suffering in the eyes of trainees. They start believing while doing MS, they have to do MCH. There are a lot of public who will venture to have the surgery done by super specialists rather than by general surgeon. And even a general surgeon looks at his colleague as just a general surgeon and not specialist in the particular field. Is it general surgery the obsolete stream? No, not at all in India. There is huge surgical patient load, and most of these surgical services are provided at our subdivision and district level hospitals, which are manned by general surgeons. We need huge number of general surgeons to cater to our patient load. We have more than 400 medical colleges in India, and if you find the MCI eligibility for teachers appointment in these medical colleges, it is just an MS in general surgery, and you have a clear route of promotion in a medical college being a MS in surgery, and you need to have some publications along your ascent in the ladder of senior resident to professor. You need not specialize, get an MCS degree or a DNB degree in super specialty to assign you as a professor and at the end a professor director of the particular department. So all faculties in Department of Surgery at all medical colleges are basically general surgeons, and there is a huge scope for a general surgeon to excel as a medical teacher. In spite of super specialization, general surgeon continue to be essential part of our healthcare system in India, and general surgeons need to update him by doing some fellowship program or certificate courses, and by this a general surgeon can enhance their skill and he continue to practice in his field with some interest in colorectal or upper GI or hepatobiliary pancreas, but you need not give up your general surgical practice. So I believe there is a huge scope for the general surgeons. Not entering MCH or DNB supervillainity is not the end of a road for general surgeons, because there are enough opening for general surgeons. There are limited number of super specialists in India, and they are mostly confined to big cities and medical college and corporate hospitals, and they are not sufficient to cater to the vast population of India. So I believe that general surgeon can perform most of the job efficiently. The minimal access and robotic surgery has become a new tool for general surgeons, and now minimal access surgery is being taught at MS level. And I can assure you, our postgraduate students, when they're leaving our medical colleges, they can perform basic laparoscopy independently. They can perform a lap chole, they can perform a lap appendicectomy, they can do a diagnostic laparoscopy. And once they pass out, if they go for some advanced training, not even a fellowship course like FNB or MCH, with some amount of training in a good center, they can excel and continue to do advanced laparoscopic surgery training. And this robotic surgery training is again open for general surgeons. So general surgeon will be continue to be an asset in healthcare system in India, and a good general surgeon can perform wide range of procedures, but a regular updating and certificate courses may allow a general surgeon to achieve perfection. And I believe general surgery as a career is still a viable option. Thank you.
Thank you, sir.
Yeah.
Chintamani sir, you're on mute mode, sir.
Yeah, we won't have any questions at this point. I'll invite Dr. Kanagavel to make his presentation, and then we'll have a rebuttal and discussion. Thank you, Dr.
Sir, can someone unshare this so that I will be able to share my PowerPoint?
Yeah, please. It started. Can you share it now?
Yes, sir.
Please share it, sir.
Lovely to have you, Dr. Kanagwal, and your PG.
Good morning, sir. Good morning, everyone. Thank you for the kind invitation. And it is indeed a proud moment for me to debate with my teacher and gurus here. So lovely team in Jasicon for giving a good conference. I bring warm greetings from the ASI Chennai City branch. The surgical specialization have been evolving as a general surgery in general, and now it has moved on to the surgical specialization. Let us look upon the importance and benefits of specialization. And I'm sure all of us will have to eventually agree, general surgery as a broad specialty is slowly on its way out. The general surgery initially comprised of GI, endocrine, neuro, surgical oncology, and bariatric. This was the era of Dr. Mayo. And then now we move on to my colleague admitted to most of the facts, like GA surgery is also getting branched into foregut, bariatric, HPV, transplant, and on. So everyone should agree that eventually it is ongoing change and ongoing specialization, ongoing micro specialization. Now look upon one specialty like surgical oncology. Initially it was a generalized oncology. Now they are also moving on to a specialization. So it is very pertinent to understand general surgery evolved from the branch of medicine, or initially it was called as operative medicine. Then it moved on to general surgery. Then specialization and subspecialization have already started to take place. Now let us look upon what are the benefits of specialization. It's not the question of availability. It's not the question of what is happening at this point of time should drive the people towards general surgery. People should very clearly understand there are current very clear evidences to say specialization gives improved standards of treatment, gives the most optimal outcome. And of course, when you are committed to one single organ, the initiation of new developments and fostering focused research are pretty much easier. So can the benefits be realized? See, at this point of time, what really happens is, as a general surgeon, people look upon specialists and they become a residual specialty of doing certain set of procedures repeatedly. And of course, emergency surgery in India as such has not taken up as a specialization, but other countries, the accident and emergency has taken up as a different specialization, which India should adapt on soon. So the general surgeons can no longer be all things to all people. That is very well accepted by colleague Dr. Saha sir. And obviously, specialization leads to better care. To give you real-time data, minimum expertise for any surgeon can be a maximum of 20 types of procedure. Please understand, a surgeon becomes very safe when he has operated or clocked about 10,000 hours of operating room experience. That technically means one who has crossed 40 or 45 years of age and who's on quite active practice from the time of graduation and post-graduation breaches this barrier. And then a mean surgical operative time is about 120 to 200 hours. But then please understand, this depends on what type of practice a person is and what type of establishment a person gets in. A person who is practicing in an institutional practice like All India Institute is not equal to a person who is going to practice in his 20 or 50 bedded own setup. The spectrum of the procedure is not going to be the same. And please be aware, people can continue to operate as variable from less than 3 hours per hour to 327 hours per year. So again, it depends on where you are practicing. That doesn't matter, you are 40 plus, you are specialized, or you are 45, you are safe. In surgical training in India, we have been initially onwards, have oriented towards 3 years program and 3 years of subspecialization. But in USA, they have been always from the beginning as 1932 onwards, they have gone to the 5 years plus 1 years of program. But then now fellowship has become mandatory. In Japan, they have gone for 5 plus 2 years program, or now they're adapting to less of general surgery and more of fellowship oriented thing. There is a gross mismatch of availability. India has, as of date, 8,684 MS seats, whereas close to 1,500 MCH seats. Whereas in USA, close to 60 or 90% of the general surgery people are given an option. They continue to go on to the fellowship, and most of them do a fellowship of their choice. So, is general surgery a specialty or a general surgeon as a specialist? At this point of time, general surgery is taken as a tool for education, not specialization. The present orientation of the academics of general surgery is to train undergraduates, train postgraduates, but eventually lose out on the cream of the general surgeons to go on to become specialization, just losing on what we have. I'm sure people may comment on my word. General surgery continues to be the mother of surgical specialties. Various specialization can come. But please understand, a change is inevitable, and eventually general surgery should get bifurcated into various branches. Maybe it is matter of time. It is a huge presence of pool of general surgeons in this era. We'll have to accept, and it is matter of time where people believe and change into this model. One could appreciate this is a branch of various specialization, subspecialization, but one cannot be master of everything. So the American board has migrated into various specialization. In India, the MCA as well as the national board has agreed to most of these similar pattern of approach. But newer specialization in India, we have MCH hand, MCH hepatobiliary, MCH minimally invasive, and by the year, we also get into more subspecialization. Several subspecialties have already developed well-developed form paradigms for training programs independent of general surgery residency. Please be aware, the programs of 6 years course in MCH plastic and MCH pediatric or DNB courses are slowly excluding general surgery, and then less and less of general surgery are going in. So then the next question comes in, specialization is the ultimate end of the road? No. But then people across the globe who are going for 5 plus 2 years or 6 years of training are taking up less and less of general surgery, because the longer they spend in the specialized paradigm, vascular B, or it can be a HPB or a plastic. So the less of general surgery is going to be the in thing. So the American College of Surgeons, as early as 1990 and 2000, formed a very important core group where people are brought into early specialization in surgery. Say within second year of surgical training, they go on to specialization, but they continue to believe, yes, this is going to be a long-term option. Eventually, early specialization gives better training program and better results. So let us ask one question. Do our colleagues, patients, medical students, or general surgeons believe we are specialists? Yes, this was the scenario about 40, 50 years before. At this point, no. What is the reason for the declining image of general surgery? We have been working, we have been mastering smaller procedures, or the spectrum of general surgery is widening. Imagine in 1930, a fracture fixation or a burr hole or a laparotomy was the only procedure. Now we end up doing repeat resections for retroperitoneal tumors. That is the amount of specialization we go in. So I won't tell this is a declining image, it is a changing paradigm. So very complex factors follow why subspecialization come in. It is market driven, the leadership driven, and innovations and technology of equipments and gadget availability. And single organ focus gives optimal results. Focus on specific patient populations, focus on specific disease processes, and complexity of procedures. Now we end up doing IVC resections, we end up doing aortic resections. A general surgeon cannot be expected to do into all those things. And of course, the training paradigm and the training quality is totally different when they move on to subspecialization than general surgery. And last, not to mention, the incentives are always better in the subspecialization. So eventually, I wish general surgery should not be the dumping ground of all the troubles of super specialization. General surgeons should graciously accept evolving into subspecialization and super specialization rather than accepting what is left behind of the super specialists. So the next important question is, will general surgeon become extinct? No. There are many areas which do not have fundamental medical facilities. There are many areas which do not have broad specialties. There are very few areas which are blessed with subspecialties. So this is not going to be immediately extinct, but then I would advise the younger fraternity to gear up for the change. Thank you for your attention.
Thank you, Dr. Kanagwel. And I mean, truly a delight listening to both of you. And I think there's an old saying, there's nothing more deceptive than an obvious fact. So we probably were saying the same thing, but differently. And it is true that this jiggery-pokery about specialization keeps getting more and more confused. Now, there are some points that I'm sure Dr. Saha would like to rebut if he wants to.
Yes.
Over to you, Dr. Makan.
Yes, yes. Actually, I want to start at the last slide shown by Dr. Kangavel. He said that general is going to extinct. He said no. That is what I'm debating at the moment. If you take off the scenario in India, you see in the West, if you go by the patient population, you go the health facilities, they are going for more and more specialization. They are going almost organ specific. But if you take the whole Indian scenario, you see the huge population, you see our patient population, our health setup, and if you see the ratio between our MS seats and the MC seats, all cannot go for specialization. And if I give a simple example, in our medical college, we do have a surgical gastroenterology department manned by 3 super specialists. And we have 6 surgical units, general surgical units manned by general surgeons. And I can assure you the total number of surgical procedure done in the general surgery department is almost 3 or 4 times than catered by our surgical gastroenterology department. So it's not that a general surgeon cannot deliver. All depends on training. Once you have a basic surgical training in MS, and if you are groomed in a good general surgical unit in a medical college or in a peripheral setup, you can excel in all the fields. But I am not claiming a general surgeon do a aortic bypass. I am not saying that general surgeon do a endourology or do a radical prostatectomy. What I am saying to say is confined to the general surgical stream and the abdominal surgery, try to excel in breast, endocrine and soft tissue surgery, try to go into the minimal access surgery and robotic surgery, get some training. You continue to be a general surgeon and you can deliver. So what I'm trying to give a message to the young star, whoever is in the super specialty is good. I am not denying that there is no role for doing super specialization, but what I'm saying is, even for this young generation, a general surgery can be a good option for him to survive and excel in the field of surgery. Thank you.
Thank you, Dr. Shah. And I think you made that point. There was a beautiful article, editorial in British Journal of Surgery in 1991 by Johnson. He was very much into training and the curriculum making, which happens more often in US and UK. We don't have professional bodies participating in curriculum making in this part of the world. So there's actually a gap. You may have associations, but they don't have any role in the curriculum. So even when we discuss it, the policies continue to be made in the bureaucratic circles or medical bureaucracy. So in that article, he mentioned about the average age when a surgeon actually comes out or is delivered. He used the word. It is 37 years. And if you consider the retirement age, he gets very limited time to be able to practice. And now this delivered surgeon is not only very old, according to that editorial, he's also very expensive because he has spent a lot of time and money into getting trained. So end of the day, you're getting a more expensive surgeon than you were getting earlier. So there was what Dr. Kaneval was referring to. There was therefore an intent to train them early into subspecialization. Now, there is a debate about super specialization versus subspecialization. The super specialization is also a very confusing term. Now, we have DNB courses in almost everything now. Whether they're indicated or not is another question. So, MCA was a little rigid earlier, but even they're flexible. So, you may probably one day have a right eye course and a left eye course. So, I think that's another extreme. What I liked about the presentation of both of you, and in the beginning, you and then Kanavel had the advantage of having heard you, was there is still a gray zone, and we actually are talking about training rather than degree training. So if you have a degree but no training, it's worse than not having it. I'll give an example. MBBS student is already thinking in terms of post-graduation. Postgraduate student is already thinking in terms of MCH, and MCH is already thinking in terms of something else. So by the time he comes out, he's a half-baked everything. So when he cannot put two ends of bowel together properly, and he is an MCH, we get to see a lot of them. I examined for both MCH and MS, so I can share with you that basic general surgical principles are not adhered to. UK is struggling. US has done a little better there because they don't have this term super specialization. Otherwise, you'll hear this in medical schools, especially. I think training still happens in these are the the nurseries of training are the medical schools, and in those places, still the training happens in the conventional way, while the world has moved into a non-conventional way. So there is a mismatch. That's one. Number two, he is not yet prepared to be a basic good doctor before he becomes a basic good surgeon and before he becomes a good MCH. So people are trying to subspecialize even before they've learned the basic, as Dr. Kanaval brought out, the mother of all specialties, that is general surgery. Now, eventually, end of the day, you both agree it's training. We have got a tool-based specialty. Minimal access surgery is nothing but just using another tool. And when you create a world out of that tool-based specialty, it is basically a tendency amongst all of us to kind of get a narrow corner of comfort and kind of make it exclusive. When you had minimal access surgery beginning to start in National Board, it was just an opportunity to be there when people presented their minimal access background as to why should they do it. A lot of questions were asked. There's just a tool that you're using. It can be training. I'm not denying it. So training is more important rather than the super specialization as we talk about. Therefore, US has a concept of subspecialization in the form of fellowship of the board, which gets certified based on your training rather than your degree. So you may have an MCH who has not even done basic surgery, and it's true, with the number of seats in DNB coming, MCH surgical oncology I can tell you about, and DNB surgical oncology adding up, you may have more general surgical oncologists than you actually really look for. That again is a fallacy. Therefore, organ-based training immediately after you become a general surgeon looks like a middle path where you at least train in one organ sufficiently. Now, when you go to any place, US or UK, you say, I'm a surgical oncologist. They ask you, so what do you do? You are a surgical oncologist, doesn't make any sense there at all. And I agree with both of you. I'm sure, Dr. Kanavel, you will have some points to make in response to couple of questions that I asked. I had two questions which I put for both of you. One is super specialization versus subspecialization. This term super specialist should, according to you, should it stay or it should disappear? And number two, do you think we are going too far and we tend to go overboard in everything into making subspecialization almost like at microscopic levels? So first from you, Dr. Kanaval, and then over to you, Dr. Shah.
Thank you,
2
Mr.
minutes.
Chintambani, sir, for such a broad perspective. Let me take your question first on the super specialization and the subspecialization. Before answering this question, let us lay a very clear paradigm or limit for general surgery. See, if you are going to do a thyroidectomy, do a mastectomy, you do a gastrectomy, you do an emergency colon resections, let that be reserved for general surgeons. You want to go for super specialization, you end up meddling with bile duct, you end up meddling with liver. What the current problem happens is a MCH surgical gastroenterologist coming and doing a hemorrhoidectomy or a fissurectomy or a fistulectomy, or a surgical oncologist coming and landing up doing a conventional orchiectomy. So let us have a clear domain. The only request from my side will be to accept general surgery as a specialization. Let general surgery have a domain. What really happens, like a mother, we end up handing over all the surgeries to the branch of upcoming branch. It can be a liver transplant. I'm sure general surgeon is not going to touch upon liver transplant. I'm sure a general surgeon is not going to work on IVC replacement or aortic replacement. My only wish is general surgery has to be given its share of common procedures, maybe emergency or elective. Subspecialization can have its own share of procedure. Super specialization can have its own procedures. If this line is clearly drawn, the question of remaining a general surgeon will never be a challenge, and nobody is going to be challenged remaining a general surgeon. Number one. Number two, the question of how far is too far. I would say, see, imagine now we are doing a hybrid approach with endoscopic, laparoscopic resection of pancreatic neuroendocrine tumors. It has to happen. There is no point in making a big rooftop incision for taking a 1 centimeter insulinoma or something out. That's where minimally invasive surgery and hybrid surgeries come upon. Let there be a clear governing body, what a general surgeon will do, what a subspecialist will do, what a super specialist will do, and how we have a multidisciplinary approach in oncology. Let us have a multidisciplinary board in surgery, which surgery goes for open, which surgery goes for minimal invasive, and a graded approach of newer procedures. I think let us have a controlled progress towards newer things. See, eventually you have to catch up with the newer developments, but let us have a controlled access. Let the students have a clear path. Okay, if I want to do a right lobe of liver, I have to take this path. So general surgery is at the bottom of the pyramid. I would say doing a right duct bile duct operation or left bile duct operation is at the top. And as well, the amount of procedures are also less. So nothing is too far, but a controlled and graded too far approach will be the right approach. Thank you.
Thank you. I think you made that point. Dr. Shah, quickly.
Yeah, actually, this super and sub specialization, you will agree that most of the presentation that comes, one of the prognostic factor in oncology is being getting operated in a high volume center. So the point of high volume center is you are doing the procedure in large numbers, and same way, if somebody is confined to a particular organ, he is going to have a better situation that he is doing the same procedure, his time will improve, his oncological clearance will be better than a average general surgeon. So I don't disagree, there is a role for doing super specialization or sub specialization, but what I'm trying to emphasize is we need to have sub centers or areas of excellence in a particular area, in a state, agreed, but as a whole it is not possible to refer all such in a patient in a particular state to that particular center. It is theoretically impossible for them to cater. So what I'm trying to say is, let super specialists come, less subspecialty occurs, but at the same time our attention should be confined to our basic general surgeons, train them up so that they can deliver a standard work. Thank you.
I think you both said the same thing, just one line at the end. General surgeon continues to be the general, and you'll have the colonels and brigadiers all working. The problem with the pyramid being that way is that it gets relegated as something which is not essential. Now we have a specialization in terms of general surgery also in US, and people can be super special. The term super specialist is actually disappear. My question was different. The term is subspecialization. Whatever you do is not super. It's an addition. It's a part of the major chunk. Thank you very much, both the speakers. I thoroughly enjoyed the debate. Both
Can
of
I
you
come in,
agreed
sir?
on all the points. And if there is a, sorry, I heard something. Dr. Satyavir, over to you. Thank you so much.
Thank you very much,
I
sir.
appreciate your, remarks that you made, and take home could be many, and people would have different opinions. But let's agree to disagree on some factors, and we can actually finally find a way forward. But I truly agree with what Dr. Kanavel said at the end. The multidisciplinary team approach should be mandatory for whatever you do. It shouldn't be a free-for-all approach where you become a super specialist entirely just because you got a degree with you. It's about the training. Thank you all very much. Thank you.
Chintamani, can I come in?
Sadhvir?
Thank
Oh,
you.
yes.
Sorry?
Can I come in here?
Sadhvir, can I say something?
Yes, please.
I'm 100% agreed by super/sub speciality.
That's it.
It is knowing more and more about less and less, as we all know. So this super specialty is just a superfluous word.
Correct.
And I think it is high time that we start taking a note of it. And like the Americans say, not the Britishers, super specialization redundant, and it should be sub-speciality.
Absolutely, sir. That was the question, and you hit the nail on the head. And that's actually what is the way forward. To you, over to
Yes.
you.
Abhay sir is raising his hand. Yes, sir, please.
I'm asking him. I don't know. I'm doing that. Thank you. Okay.
Dr. Chintamani, very nicely moderated debate.
Thank you.
Congratulations to Makanlal as well as Kanagwel. With whatever experience I have, I can say two things. Remember Shushruta, he warned that specialization is a bird with one wing.
Correct.
Way back, he had said that. Second thing I would like to also tell Dr. Kanagwel, do not open an umbrella when it rains in US or the UK.
Absolutely, very well said. That actually says it all.
India is a different ball game.
We need Indian solutions to Indian problems, as you rightly said.
We have moved from MCI to now National Commission. The basic motto is health for all. There is a very good publication which has come up in 2020 September, which you should read. I will send you the mail. One more thing, what I personally feel is identifying a person who can be a good subspecialist. That is the role of a general surgeon teacher, because something known as proficiency gain curve should be there. Identify a PG who will be good in hepatic surgery, not just because he gets a good rank in NEET that he will become a good surgical oncologist or a hepatologist. You have to identify that person. There are people who will never improve. There are people who will gain proficiency very early. So identify these people and guide them is the role of a general surgeon teacher, as I see. Further, I will talk in my oration many things of this sort. So just wait for it. Thank you.
So much, Dr. Abhay, and I agree with you completely. And as the comment made by Dr. RP, I was basically trying to get the answer for that. The term subspecialization sounds and looks a little better. Super specialization takes it out of the orbit. So it still remains, and I think bottom line is still good training and identifying the right people for the right kind of a subspecialization is that's how it happens in the US. So they pick up the fellowships based on their background and their curve. Thank you very much. Thank you very much, all the...
Arunima, I have to say one more line, Chintamani.
Sir.
With Abhay, our incoming president, and you having done the lot of responsibilities of ASI, I am coining a word, think over it, community surgeon for India, an Indian situation, where a community surgeon will be trained to do everything masterly, not just half it. And this is going to solve the issues and problems in nook and corner of the country. Not just the general surgeon. You know, general surgeon also, sometimes it's quite well-meaning, but sometimes it is very demeaning. So let's coin a new philosophy, a new word. I will discuss with Abhay. I'll discuss with you. And I have just thought that let
there be a community surgeon who will go to the community to serve everything.
Thank you very much, sir. And as expected, we got such such wisdom poured into the already existing knowledge that was being shared by both the speakers. The debate was really worth it. I truly enjoyed it. Both of them did it. Thank you, sir.
Excellent.
Thank you very much. Have a great.
Excellent.
Thank you very much, sir. Thank you for this debate.
Thank you.
As a token of respect, please accept this e-certificate, sir.
Thank you so much.
Chintamani, sir. And thank you, Dr. Makhan Lahal Saha, sir,
Thank
for
you.
their illustrative expression about general surgeons, and Dr. Kanal Gawal, sir, for inspiring young surgeons to become super specialists. Thank you very much, sir. To move on to our next, I will hand over to Dr. Arunima ma'am for the inauguration ceremony.
Thank you very much, Satvir. Can you please allow me to share my screen?
Yes,
Is my screen visible?
yes, ma'am.
Yeah, so I think we have all our guests here, and I want all the delegates to be a part of this. I've already informed Hall A, B to join in. So a very good morning to all of you. On behalf of the organizing committee of Jasicon 2020, I, Dr. Arunima Verma, welcome you all to the inaugural function of this mega virtual conference, which is the 19th annual conference of the ASI Jharkhand chapter. So these are the proceedings for the function, and I take this opportunity to welcome our chief guest, Dr. P. Raghuram, National ASI President, our guest of honor, Dr. Abhay Dalvi, National ASI Vice President, our special guest, Dr. G. Siddhesh, National ASI Vice President-elect, to the conference and inaugural ceremony. I also welcome our patron, Dr. R.P. Srivastav, GC member, Dr. J.K. Chaudhary, Chairman, Dr. Uday Srivastav, Secretary Muhammad Azad, Chairman Organizing Committee, Dr. Sunil Kumar, and last but not the least, all delegates to this inaugural ceremony. And before we go ahead with the proceedings, making up for the welcome of a physical conference, we welcome you all with a tribal dance of Jharkhand. One second, sir.
So it is a typical dance of Jharkhand, not a tribal dance of Jharkhand. Even I dance this tune.
Yes, sir. We all are Jharkhandi, so we all dance to this tune.
Madam, we are not able to see the screen. We can only see your folder. Video is not
Okay, just
playing.
1 second. Okay, just 1 minute then. I'll just start again.
Yeah, stop share screen and do it again.
Just 1 second. Can you see the screen now?
Yes. Please make it full screen.
As we all know, dance has no barrier and it is something everyone can feel, understand and enjoy. So I'm sure it did convey our warm welcome. To increase the warmth, I would now invite Dr. Sunil Kumar, the organizing chairman, for the formal welcome address. Sir, please.
Yeah. Thank you, Arunima. Good morning and greetings from Jharkhand. It's my proud privilege to welcome formally to each one of you. Dr. Raghuram, P. Raghuram, a dear friend and a ASI president who has led from front this year with his creative leadership and accountable governance. Welcome, Raghu. I take this opportunity to welcome Dr. Aved Alvi, incoming president of ASI. Welcoming Dr. G. Siddesh and congratulating him, who is the vice president-elect for 2022. I take this opportunity to welcome again Dr. R.P. Srivastava, a dear friend, philosopher, guide, and patron, who has been a leading light in the ASI Jharkhand activity. My fellow council member, Dr. Jugal Kishore Prasad, and obviously the dynamic young lady, Dr. Anima Verma, who has taken all load, and our ASI Jharkhand chapter chairman, Dr. Uday Srivastava, and dynamic secretary, who will be president-elect, Dr. Muhammad Azad. Welcoming each one of you to this conference. I'm sure all of you have been enjoying this scientific bonanza. If there is any lapses, the organizing team has worked very hard, led by Dr. Arunima and all these young people like Satvir and Sumega and Sumit, and also the website team, which is based in Bangalore, led by Anand. But however, there can be little lapses here and there. I take as a chairman organizing committee, I take the whole responsibility and will try to improve upon in the future. Thank you. Back to Arunima.
I take immense pleasure in introducing our special guest, Dr. G. Siddesh, who is Vice President-elect of National ASI. He's Director of Sigma Hospital, Mysore. He has been Professor and former HOD of Surgery of JSS Medical College, Mysore. He was Secretary and Chairman of ASI Karnataka chapter. He has conducted 3 state-level conferences in Jasicon 16. He is active in many academic bodies, including ASI, AMRC, IAGES, Hernia Society of India, and SGEI. Has 18 publications in index journals and has made many scientific presentations at national conferences. He was the first to do therapeutic endoscopic laparoscopic surgery in his part of the state. Sir, I welcome you to the Jasicon 2020. Saraswati is the goddess of knowledge, art, wisdom, and learning. In a conference having a mixture of all these, it is imperative that we offer flowers and seek her blessings. For this, I request our special guest, Dr. G. Siddesh, to offer flowers digitally by making a Namaste sign. So can we have a Namaste sign from you?
You know how to make it. Let me see.
Sir, can you please put on your camera?
Okay. I'm on there. I'm on your camera. I'm saying Namaste.
Yes.
Start your video.
Thank you, sir. We pray for the health and wisdom of all of us. I now request you to say a few words.
I think I'm audible.
Yes, you're audible, Siddesh.
Okay.
You're logged in from 2 devices. That's why.
Yeah, that's why I'm switching off that one because it doesn't take up the. Yeah, okay. Now I think you are audible now.
Yes. Yes.
Yes, yes.
Yeah, I think I switched off the other one. Sorry. At the outset, let me thank the Jharkhand chapter for having given me this opportunity to be part of this wonderful occasion, their annual meet, Jasicon 2020. Dr. Sunil, I am really thankful to you for having given. This was a real good opportunity for me to meet all of you and be a part of this wonderful meeting. And from morning, I'm seeing the flawless way the meeting is being conducted. So many stalwarts exchanging views. Very nice topic, especially the debate was really enlightening, and I could learn a lot of things from that, as well as you said, the chairman said we are learning through these debates and symposia. What is important to see here is that ASI and its chapters have become so fast adopted to the new changes which has evolved because of the pandemic. We have become virtual in all the meetings. We have become so versatile, and we have adopted to the newer changing modalities in the learning and conducting of meetings. I think this change is bound to continue for a time to come. I don't know how long, but we have adopted to it. We may improve, keeping aside some of the glitches, and improve and see how nicely we are continuing to conduct these meetings. So that is what I learned from today's meeting. And I take this opportunity to thank all the members of ASI who have really given me a big mandate, and the numbers really doesn't matter. But what makes me feel is that it makes me more responsible and committed to the cause of ASI. With stalwarts who have been in the past contributed to the ASI, starting from Shiva Mishra, I have been seeing Santosh, and then later on Arvind and Abhay going to continue, and Raghu having done such a wonderful job. It's going to be a tough job for me in future as I look forward to match these stalwarts in their performance. And I promise with my best ability, I will continue to contribute to the best of ASI without turning any stone. And I will definitely stand up to, try hard to stand up to all your expectations. And lastly, to the Jharkhand chapter, what I see is though the number of members there are small, but what I came to know going through this elections process when I was campaigning, a lot of members who are practicing in Jharkhand state, they have addresses from other states. The reason what I felt was there are not many medical colleges producing postgraduate students. All the practicing surgeons, either during their postgraduate studies or during the training, they have become members of ASI in different states. So I think the state chapter should consider updating their addresses, so your Jharkhand numbers go up. So that is what I saw as an observation, just as a small suggestion, Sunil, and the people at Helm of Fire can take it up, and we can at ASI headquarters can contribute to whatever way to do these corrections. And with people of senior cadre like RP being there as a part of your team, definitely Jharkhand can look up to a big improvement in the future. And this meeting today, if I go through as any standard of measure, I think you are none second to anybody in the chapter meetings. So congratulations to all of you again, and thanks again for giving me this opportunity. Sunil and your team have done a wonderful job. Continue doing the good job, and thank you for again for giving me this opportunity to be part of this meeting. Thank you.
Thank you very much, sir, for your kind words. And now it is indeed my proud privilege to welcome our chief guest, Dr. P. Raghuram, the National ASI President, to this gala meeting. He needs no introduction, but I just remind us of his few achievements. He is a Padma Shri awardee, a Dr. B.C. Roy awardee, and he is at present the president of the Association of Surgeons of India. He is the director and consultant surgeon at KIMS Usha Lakshmi Center for Breast Diseases. He was conferred with Edward Kennedy Memorial Award for outstanding contribution to breast oncology in South Asia. He conceived, designed, and established South Asia's first purpose-built freestanding comprehensive center for breast health in Hyderabad in 2007. He has been the overseas coordinator of in 2005 to 2008 Executive Committee member and Editorial Secretary of IASO. Sir, we welcome you to our gathering. And lamplight brings brightness and dispels darkness, helping us to see clearly. By lighting the lamp, we bow down to knowledge, which is the greatest forms of wealth. And for this, I request Dr. P. Raghuram, our chief guest, to do the digital lamp lighting by giving us a namaste sign. Sir, Dr. P. Raghuram, sir. Sir, are you there? Yes, sir.
Holding hands is the best form of expressing gratitude.
Thank you, sir, for lighting the lamp. And as we move ahead with our proceedings, I invite our GC member, Dr. J.K. Chaudhary, who is well known for his philanthropic activities, recognized also by ASI, to say a few words. Dr. J.K. Chaudhary, sir.
Our chief guest, I am audible?
Yes, you are audible, sir. Please go ahead.
And my chief guest, Dr. P. Raghuram, President ASI, guest of honor, Dr. Aved Dalvi, Vice President ASI, special guest, Dr. G. Sidesh, Vice President-elect ASI. Congratulations, sir. Patron and past President ASI, Dr. R.P. Srivastava, and mentor of our chapter. Our chapter chairman, Dr. Uday Srivastava, and secretary, Dr. Muhammad Azad. Organizing chairman, Jasicon 2020, Dr. Sunil Kumar. Secretary, Dr. Arunima Verma. Our guest speakers, my seniors, colleagues, and member delegates. I welcome you all from the holy city of Devghar, of Baba Mandir of Baba Vaidnath. I am delighted that our chapter organizing annual conference on virtual platform for the first time in this pandemic era of COVID. It will be remembered new technology coming out and meeting conferences are organized. Our organizing team has done tremendous work for organizing the conference. My thanks to organizing committee and especially to Dr. Sunil and Dr. Arunima. Thank you all. Long life ASI.
Thank you very much, sir, for your kind words. And now request our dynamic secretary, Dr. Muhammad Azad, to present the secretary report. Dr. Azad? Yes, please present your secretary report.
Johar Jharkhand. Actually, secretary report has been circulated on WhatsApp and to every member of ASI Jharkhand. It is there. It's a great occasion for ASI Jharkhand to host Jasicon 2020 on virtual platform. On this occasion, I welcome all seniors, colleagues, and friends who are attending this conference. Organizing Secretary Dr. Arunima and Organizing Chairman Dr. Sunil has done tremendous work to make this conference a grand success. On behalf of ASI Jharkhand chapter, I do hereby extend heartfelt thanks to all who are attending this conference. Thanks. Long live ASI. Thank you.
Thank you very much, sir. I now request our chairman, Dr. Uday Srivastava, for his chairman address. Dr. Uday, please unmute yourself. Please unmute yourself.
Dr. Uday, you need to unmute yourself. Please unmute yourself, Dr. Uday. We are not listening anything.
Dr. Sunil, I think he's already unmuted. He should unplug his device that he's using, because I think if he unplugs, he will be heard.
Please unplug your headphones from the computer, Dr. Uday. Okay, sir, we'll have your address after a while. Please log in again. Please log in again. We'll have your address after that. We would move ahead. And as we move ahead, it's as I'm the master of ceremony, I'm just asked for the formal installation as the incoming chairman, which has to be done by our patron. RP sir, are you there? Please say a few words, and you have to do the installation.
Dears, it is a great moment in life, sitting in the corner of Jharkhand in the home confines and still having friends like incoming Vice President Siddesh from down south Mysore, our dear Abhay Dalvi, the incoming president of the ASI, our reigning champion president of this year, Dr. Raghu, and all my Jharkhand friends as well as friends from overseas and all over the country to this meeting. This meeting has set a milestone in the history of Jharkhand. As 20 years back, Jharkhand chapter came into being, 2020, it's a perfect 2020. The collar was donned by no other in 2 months by Sunil, Arunima, and your team. When you were given this opportunity and challenge that can you host this virtual conference, we were a little skeptical, but we were very firm on the strengths you have. And you have proven, you have raised the bar. It will be difficult to follow for anybody else incoming. I'm very happy that the challenge is falling on the shoulder of this young girl who is in the frame. Please bring me also occasionally into the frame so that I can be viewed by others. So this girl, she has proven worthier. And now the challenge has fallen on her head to be the incoming chairperson of this chapter. And this is the first time that we are giving it to your gender. And I'm 100% sure that you will give it a motherly and sisterly concern. You will sort out every issue and you will come out with flying colors. So may I request our chief guest and all others on the dais, virtual dais, to clap for Arunima, who is being donned by the incoming chairperson of the Jharkhand State Chapter. Great.
Thank you very much, sir.
Having said that, can I have a minute more?
Yes, sir.
Is this my time or my time is going to come again?
No, sir, this is your time. Please go ahead.
So the history goes like that 20 years back we started. We were not being believed by so many. But I'm very happy that Raghu has visited Jharkhand. Incoming President Abhay has also visited Jharkhand once, and it is high time that he is going to come next year to us, not virtually, in real and physically.
Surely, sir.
Siddesh, you have probably not come here. If I am remembering the history, you have not come here. So we Jharkhandis on saying a Johar, and we are welcoming you to be a part of us physically as well. Virtually, you are a part of us. And incoming year of ASI will see all the humble, dynamic, and very, very straightforward approach in the leadership who will show us the path the ASI has not seen in the past. I wish all the successes to the organizing chairman. He has done it with impeccable humility. Arunima has followed his suit, and the Jamshedpur team of organizing committee, as well as the youngsters chosen by this team from all over Jharkhand, right from the far east, northeast of Jharkhand, Sumit, then the center of Jharkhand, Sadbir, and then the west of Jharkhand, Sushil. You people have done a wonderful job. In between came Sumegha, who chipped in and did excellent job. And I'm really proud of every one of you at this moment. Thank you very much. Long live ASI, long live Jharkhand chapter, and long live our motto to excel. Give us the challenge. We will definitely accept the challenge, and we will try to overcome it like we have shown in this pandemic by doing this excellent virtual conference.
Thank you very much, sir, for those words. And I am sure you would continue to guide us throughout as you have been guiding us. Thank you very much. We have with us Dr. Abhay Dalvi, the National ASI Vice President, and having interacted with him closely on few occasions, I realized how he made every occasion significant by understanding every minute detail and giving it the due importance. He is a well-known national and international figure and is professor of surgery at GS Medical College, Mumbai, and professor at Surgery King Edward VII Memorial Hospital, Mumbai, and is a consultant surgical gastroenterologist at Jasicon Hospital, Mumbai. So we welcome you to this occasion. And before we ask you to say a few words, we have to commemorate this first ever virtual conference of ASI Jharkhand chapter. We have come up with an e-souvenir. And we want you to release this e-souvenir. And since it's a virtual one, again, we would go ahead. You can give us a thumbs up sign. We can release this e-souvenir then. And sir, I would just open the e-souvenir. And this is the e-souvenir, which as has been released now, will be available for all on the ASI Jharkhand website to download. It'll just take 1 minute because we are just releasing it. Yes, sir. And I'll just scroll through to show that this is our e-souvenir and it is in PDF format, which can be downloaded.
Madam, you need to change the screen now. So PDF we are not able to see.
Okay, just a second. Share screen again. Can you see the screen now?
Yes, yes. Please come from first page.
So this is the e-souvenir, sir, that you have released. And this is the content. I'll just scroll through just to show what it is. I thank all the guest faculty who have given in guest articles for this e-souvenir. And then after the guest articles, we have got all the abstracts that we received, and we had an overwhelming response. We had almost 80 paper presentations, including poster and free paper and best award session papers, and all have been compiled in this e-souvenir. And at the end of the e-souvenir, it's a gratitude from the organizing team for this kind of participation. And I request all members, whoever is interested, to just download this PDF and have a look at it. I do not recommend any kind of, as we are going to the green world, we do not want any paper print of this. It is going to be an e-souvenir, and this is our gratitude at the end of it. This was our souvenir that we released. And before we move ahead, I just want to hand over this certificate of appreciation to the organizing team of Jasicon 2019 from Jasicon 2020. And now I want Dr. Abhay Dalvi to say a few words and address the gathering.
Yeah, good afternoon. Let me really congratulate Dr. Sunil Kumar and Arunima, who have staged a wonderful state chapter conference here. I have attended yesterday, especially Arunima's lecture, which I was quite impressed. And today itself, since morning, I have been attending this. It has been really, I don't know what to say here. Such good scientific deliberations. The debate, last one was something which was really an eye-opener. And let me thank you for asking me to release this e-souvenir. I wish the state chapter all the best. And Arunima, you as incoming president, I'm sure you will reach more heights in the next year to come as I take over the presidency of ASI. Thank you so much, and let the proceedings go ahead.
Thank you very much for those motivating words, sir. And we have the delight of having with us the chief guest who has been witnessing the performance of a chapter. And now I request Dr. P. Raghuram to address the ASI Jharkhand chapter.
Thank you, Dr. Arunima. May I share the screen, please?
Yes, sir. I'll stop sharing my screen. You can go ahead and share your screen. Yes, sir. Please share your screen.
Right. Good afternoon, everyone. On behalf of the National Executive Committee, warm greetings from our headquarters. It is such a great pleasure to have the incoming president and the vice president-elect on the same podium. I think this is the very first time Siddesh is on this podium, and all credit to Jharkhand, starting from there onwards. And I always believe this is part and parcel of my life. This is a part and parcel of my life when I wake up in the morning and before I go to bed. And on this occasion, yes, gratitude is due to the visionary chairman of this Congress and also to the dynamic, secretary. I mean, attention to detail is something that it's not everybody's cup of tea. And Dr. Arunima, your attention to detail speaks a lot. Not only during this conference, not only during the previous conference that was held about a month ago relating to the ABSI, but throughout, you have demonstrated extraordinary commitment to the association, and the association will undoubtedly benefit from your experience. And of course, I must mention here that Dr. Jugal Kishore Chaudhary, an esteemed member of our National Executive Committee, has been chosen by virtue of merit as the Social Service Award recipient of 2020. Many, many congratulations to you. We have taken great care. ASI believes in creative leadership and accountable governance and no-nonsense approach. We don't believe in doing any favors to anybody, regardless whether he or she is my friend, my colleague, we have always throughout this year, Dr. Abhay Dalvi is here, therefore I can say with confidence there are several things that I have discussed with him, and we believe that we will ensure creativity, and I have put my hand on my heart and kept everybody aside, my friendships, my contacts, my requests, pressures, and then delivered justice. And all our awards this year speaks volumes about that. Dr. Uday Srivastava, our chairman of the Jharkhand chapter, Dr. Mohammad Azad, you have done great work for the chapter. So my year began last year, December, and as I said, my mantra has been from day one, creative leadership and accountable governance. This is an editorial published in the February issue, which has the highest number of views that an editorial has been accessed ever since IJS has come into existence. Very, very grateful for that. My presidential term can be easily classified into 3 phases: the first 3 months, then March to June, and then June onwards. So we have at any given point 15,000 trainees, and so the core of my presidential planning started off with this by introducing a number of skills courses for our trainees, some of which were held for the very first time in our association. Between January and March, we did close to 15 courses across the country. And then the second phase began. I was put into the deep end, never ever expected that I will have to get into this. And the very first interaction during this pandemic started off with the video interaction with our Honorable Prime Minister. This is a video that went viral, not only amongst the medical fraternity, but also outside the fraternity, not only in this country, but elsewhere as well, because I had many calls from friends who are in the US, UK, Australia, and many other places. And some of the points that I had highlighted were was actioned by the Prime Minister on the very, very next day. And I take great pride, privilege to share this slide that, we as an association, you as a chapter, and everybody in the association have risen to this occasion and have mounted a never before witnessed philanthropic exercise in the 82 years history of our association. And instead of just giving away the PPEs, which were so much in scarcity during the months of March, April, May, and June, there were only 8 companies that were making the PPEs. Now India makes the largest number of PPEs, but at that time I was spending close to 3 hours every day begging the supplier to make available these things, and used all my resources, all my contacts to put pressure on him so that these PPEs are hand delivered to our chairmen and secretaries of various state chapters so that they can reach out to the grassroots healthcare workers. These are some of the images. Not only this, we have also partnered with Amway India and have provided 12,000 hand sanitizers to 56 COVID designated hospitals across the country. This exercise would not have happened without the active intervention, active help from the chairman and secretaries of the chapter. And once again, with folded hands, very grateful to Jharkhand for taking a lead in helping ASI to deliver its promise of philanthropy. And somewhere along the middle of this pandemic, we also came out with guidelines which were published as an editorial in the June issue, because at that time there was no clarity what we should be doing from the time the surgeon leaves his home, what he should do in the hospital, what he should not do in the hospital, what he should do after he comes back. This has received a lot of appreciation from our members. And pleasantly surprised, I was pulled into the front line of the national media, print and electronic, where I was invited to give my comments. And as I have done in the ASI, I have spoken my mind fearlessly, boldly, representing your views, representing the association's views, not only on aspects relating to deal with the medical aspects relating to surgery, but so many things I have learned. I have improved my common sense, and my children are also surprised at me, at the way I have delivered on national television. also invited to contribute editorials and invited articles in many print media. And finally, the third phase began in June with modifying, adjusting to the new normal. We started off with conducting the online National Skills Enhancement Program and just finished the RRC, where the chief architect was Santosh John Abraham, all along very ably assisted by our incoming president, Dr. Abhay Dalvi, nurturing this program. And as I said yesterday in the concluding session, as all good things have to come to an end, but RRC is so good that it will not come to an end. It is our flagship initiative. It is our main academic program, and this will get better as we progress to next year and year after next under Siddesh's leadership in 2022 as well. And finally, before I conclude, I would like to request all of you in Jharkhand and all of you watching this program to participate in our flagship annual conference, the 80th annual conference of ASI, being held in the virtual platform. It is my wish, it is my desire, it is my dream that this virtual conference should be the biggest ever and most successful virtual congress that any medical congress has happened in this country so far. So I request all of you, and through your chairman, through your secretary, I request all of you to please register and participate. It is your conference and it is with your participation that it will be successful. And finally, I'd like to pay tribute to the organizers. To organize an on-site meeting takes some effort, but to transform this on-site meeting and transpolate this to conduct a virtual conference takes some vision, courage, determination, and tremendous hard work. Once again, very grateful to you for inviting me to participate in this historic Jharkhand chapter annual conference. Namaskaram. You're muted, Dr. Arunima.
Yes, sir. Thank you, sir, for those inspirational and heartening words. And as we come to the end of this inaugural ceremony, because Dr. Uday, have you been able to sort out your mic?
Verify. Am I audible?
Yes, sir. So just 1 second. I want you to present this e-token. So Dr. Uday, please present this e-token to Jasicon 2019 on behalf of Jasicon 2020. Thank you very much. You want to say a few words?
Let us proceed. Proceed.
So, as we come to the end of this ceremony,
No, Uday, you must address. Uday, you must address.
Okay, sir. Thank you, Dr. Arunima. It is my privilege to welcome our President, Dr. Abraham, our coming President, Dr. Abhay Dalvi, and President-elect for 2022, Dr. Siddesh. We are very much thankful to our patron, Dr. R.P. Srivastava, whose suggestions always mean for us and helped us to do whatever we do in our state. And Dr. R.P. Srivastava is always there to scrutinize our functions. And I'm very much thankful to Dr. Sunil and Dr. Arunima for this good academic session, the Jasicon 2020. Thank you.
Thank you very much, Dr. Uday. And now I would like to take this opportunity to thank our eminent guests for sparing their valuable time. Dr. P. Raghuram, Dr. Abhay Dalvi, Dr. G. Siddesh, and all the national and international faculty who joined us for this conference and have given us immense enthusiasm. I also thank each member of the organizing committee, Dr. Sunil, our organizing chairman in particular, for all his patience and leadership from the front. I thank the ASI Jharkhand pillars, Dr. R.P. Srivastava, for being a guiding light, office bearers of ASI Jharkhand chapter, especially Dr. Uday and Dr. Azad, for their support. It is indeed a very heartening moment for me to thank the young team who took over as session in charges to make this conference so seamless by putting in days of hard work. Satvir, Sumegha, Sumit, and Sushil, all of you were exemplary. I thank each presenter, chairperson, judge, and delegate for coming to this platform and contributing in the success of this conference. Last but not the least, I thank our website team, Anand, Sachin, and Sabha, for the excellent and flawless e-platform created and managed with months of hard work. At the end, please excuse us if there were any lapses or inconvenience during the conference. And now, as we come to the end, I ask everybody to rise up for the national anthem. And you can switch off your cameras if you want. Please rise up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे गाहे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you very much, everyone. We will now continue with our scientific session, and I would just remind everyone that the e-souvenir is now available on the website to be viewed, as well as the e-posters are available in the e-poster arenas. Please view the e-posters and the e-souvenir. Now we move ahead with a scientific program. I would want Satvir to take over, Sumegha to take over. Sumegha, please take over.
Yes, thank you, ma'am. So we move on with the next program, and that is Dr. Rambali Sinha oration. I would like to welcome our chairpersons for this oration, Dr. Sunil Kumar, GC member and editorial board member of JMS, and presently the organizing chairman of this conference, Dr. Diptinder Sarkar, immediate past president ABSI and honorary secretary Asian Association of Mastology. We all know him very well, and not delaying much time, I request Dr. Sunil sir to invite and introduce Dr. P. Raghuram, who is already with us.
Okay, I invite Dr. P. Raghuram, who is a well-known national and international figure, for this oration, prestigious oration of Dr. Rambali Sinha. Sumegha, do we have the introduction of Dr. Rambali Sinha? Which
yes, sir.
Okay. Dr. Raghu is supposed to read that oration, sir.
Exactly, yeah. So I'm inviting Dr. Raghu for this prestigious oration. Back to you, Raghu.
May I share my screen, please?
Yes, you have the Dr. Rambali Sinha, or yeah, you can.
Okay. Good morning, good afternoon once again. On behalf of the Association of Surgeons of India, warm welcome to all of you once again. I have a pleasant duty here, and it is such a pleasure to know about Dr. Rambali Sinha, a distinguished and a legendary surgeon par excellence. Having graduated in medicine and after completing his MS, he went on to pursue higher surgical training in the UK. And it rings a bell because I too went and did my FRCS in the UK from multiple colleges. And it's so nice that he secured his FRCS from London, Glasgow, and Edinburgh within 15 months of going to the United Kingdom. And then he came back and joined the Rajendra Medical College and trained a number of surgeons. He further established a nursing home in 1974, which is named after his mother, Keshri Nursing Home, which has really championed really modern healthcare in many ways, because it became a very popular center of excellence, and he performed over 50,000 surgeries in this nursing home and really got name and fame to Jharkhand because of this hospital. In 81, he became a fellow of the International College of Surgeons, and Dr. Rambali Sinha was known to be a distinguished academician, and he was associated with a number of academic activities, including the ASI and the IMA. I was so delighted to know that he was very actively championing the social activities. The social service was in his heart and soul, and therefore he contributed immensely to social service. And I was also equally very happy that he was a man of all seasons. He would enjoy aspects unrelated to medicine, which very few doctors are aware about. I think it's very important as doctors that there is a lot of life outside medicine as well. It is important, and it is so nice to know that he embodied to be not just a distinguished surgeon, but not just a humane surgeon, but also had a life outside medicine. He continued to operate until he was a victim of CVA in April 2004, and then he was hospitalized and passed away. Dr. Sinha is survived by his wife, Srimati Shanti Deviji, Dr. Anita Singh, daughter-in-law, practicing at Ranchi, and Dr. Renu Chaudhary, doctor, practicing in Jamshedpur. Many surgeons were trained by Dr. Rambali Sinha and are indebted to him. So it is indeed a God-given opportunity and a distinct pleasure to deliver an oration which has been instituted in his name. Thank you very much, Jharkhand chapter. So I go on, and I would like to just yeah. I'm just trying. Can you see the slides?
No.
Okay.
Raghu, please share your
You
screen.
need to share here.
Is this okay?
No, it's
No.
not coming, Raghu.
Is it not? I think
No.
the share has gone off.
Anand,
Okay.
did you?
I'll come back again.
Yeah, it's coming. It has come, Raghu.
Yes? Is it there?
Yeah, it's there.
Yeah.
Okay.
Yeah.
So I'd like to begin off by saying it may sound a little blasé, but it takes a lot of courage to show your dreams to someone else. And therefore, I did have that courage. Even before relocating to India, I did share my dreams to everyone in this country. And I am here speaking to you because of my parents. Without them, I am a completely nobody, and I would have been a nobody. As they say, everything begins with a story. My story began when my mother was diagnosed with breast cancer in 2002. When I was working in the UK, I realized that in our country, lack of awareness and absence of an organized screening program is the reason why majority of women present with advanced breast cancer, and every 10 minutes, someone succumbs to breast cancer. This is a lady from the city of Hyderabad who is educated, comes from an educated family, but because of the taboo, she has not presented herself earlier and presented with advanced breast cancer. And I realized that it was time for change. I had a strategy to work alongside colleagues, friends, and the government to improve the delivery of breast healthcare in our country. For the purposes of this presentation, I shall only touch upon two aspects, advocacy and population-based screening, and see whether this can be replicated in a state like Jharkhand. The foundation that was established in 2007 bears my mother's name, Usha Lakshmi. And the foundation had three phases. The first phase was priming the community and empowering the community. Because there's no point in my coming back from UK and say I'm foreign returned. Nobody is going to listen to me. I have to integrate into the community to be able to empower them. That is what we did for the first 5 years. The second 5 years implemented a population-based screening program. And in the third 5 years, which we are in now, outreach programs being done through a number of innovative initiatives. So what did we do in the first phase? The first phase focused on breast cancer advocacy. In India, breast cancer is a closet issue. It is an issue that is hushed up. And that is why more than 60% present in the advanced stages. And I knew very well before relocating that I had to disrupt this attitude. And so this foundation principal goals were to create awareness, to reach out to the community and support survivors with the slogan, empowering people, impacting lives. Awareness, awareness, and awareness is what I focused on. When I came back and started going to various non-medical associations with a view to creating awareness, there were only 5, sometimes 2 people attending the meeting. Today, I can tell you that if the foundation goes to create an awareness, there is a hall full of people. There is no space to sit. People are even standing. That is the kind of awareness that we have created over the years. One of the first things I did was to collaborate with Breast Cancer Care UK, which is UK's largest breast cancer charity, which is the only organization that they have associated outside the UK, was with our foundation, where we have printed and published and distributed more than 100,000 information booklets on every aspect of breast health, explained in simple, easy to understand language, so that people are better informed, better prepared, and feel in control at every stage of their treatment. The Pink Ribbon campaign was launched in October 2007, coinciding with the International Breast Cancer Awareness Month. Rather than me going and speaking, I knew that if we get a celebrity survivor, it would make a greater impact. So this started off with a mesmerizing performance by a celebrity. Those of you who are in the Bonniam era will recognize this lady, Marcia Barrett. She asked for first-class return, not only for herself, but for her entire troop. I said that we will not pay you anything other than offering them Hyderabadi hospitality. She said, why? I said, because my mother had breast cancer, you had breast cancer, she had breast cancer, metastatic breast cancer. And I said that it is as much your duty as it is my duty to create awareness so that early detection is a distinct possibility. She was touched by this comment and came on her own and performed at the Hyderabad International Convention Center in February 2008. Many of you have attended the historic Jasicon, which was held there. For the very first time, I was able to get Gautami. Gautami, who had breast cancer, did not want to speak about it. She's an actor, and I have known her. And I said, not only you, madam, you have to bring Kamal Hassan. She said, no. I said, no, you have to. Otherwise, you're not coming to Hyderabad. So I ensured that Gautami and Kamal Hassan, both of them came. For the first time, they opened about their experience of what it is to go through breast cancer. This is the former United States ambassador's wife, who is now back in the US. She is our patron and the strongest advocate in the United States. This is Pamela Yash Chopra, the wife of the legendary producer, late Yash Chopra ji, who is a dear friend and a patron of the foundation. We have had many people unconnected with breast cancer. Asha Bhosle ji, who came 3 years ago and mesmerized more than 5,000 people in Hyderabad. Did we pay a single rupee? No, we did not pay a single rupee to anybody so far in the past 13 years who have participated in the foundation's initiatives. It is a matter of principle. We take great pride in that. This is Shabana Azmi, and we launched the Pink Ribbon Walk in October. And to salute survivors, this is a patient of mine. Day one after surgery, she had neoadjuvant chemotherapy. She came with a drain bag to flag off the Pink Ribbon Walk. We have had this 23-year-old lady who comes from the old city of Hyderabad, where breast cancer is even more a taboo. She again, as somebody who had neoadjuvant chemotherapy, and I brought her from the hospital with the drain bag. She fought with her family. She came there. She said, no, I have to go. I have to flag off this walk. I have to create awareness. And this is the kind of passion and zeal that we have created amongst the Hyderabadis, not just the Hyderabadis. We extended this walk to Warangal, to Vijayawada, where we had more than 10,000 people participating in the walk. Initially, I would look for celebrities to flag off the walk. We've had film stars, we've had sports stars, we've had politicians, we've had people from all walks of life. Today, I can tell you that when September comes, people call me, celebrities call me, can we come and flag off the walk? Can we come and participate in the walk? This is the kind of movement that we have brought about in Telangana. This is the Buckingham Palace in pink. This is the Tower of London in pink. This is the White House in pink. And similarly, several monuments, not just one monument, several historic monuments and buildings, ladies and gentlemen, turn pink for the 10th consecutive year. And so impressed was this Paint the City Pink campaign that the Honorable Governor, the First Lady of our state, approached the foundation and said, we will illuminate Raj Bhavan in pink. This has never ever happened before in the history of our country. And so the Raj Bhavan also turned pink on the 31st of October. So has the breast cancer advocacy over a 13-year period created an impact? Yes, it has made. In urban India, in urban Telangana, in urban parts of Andhra Pradesh. But what about screening? And when I speak about screening, I'm not going to speak about the opportunistic screening. I'm going to touch only about the population-based screening. And I do not want to waste too much time speaking about the evidence relating to screening, because we all know that screening mammogram saves lives. There is no doubt at all. Several randomized controlled trials have demonstrated this fact, and that it prevents death from advanced breast cancer by detecting breast cancer in the early stages. So opportunistic screening is what we launched in October, but I will not go through this because I'm going to skip all of these slides to take you back to the screening, population-based screening. So in this second phase, we launched the population-based breast cancer screening because all of us are aware 70% of our population live in rural India. And what applies in urban India doesn't apply in rural India. And therefore, to implement a population-based screening program needs to modify what you want, modify our way of approach. Is mammography a screening tool? Will it be a screening tool in the population-based setting? The answer is no. Why? Huge costs. Huge variation in mammographic reporting. We have very, very few breast radiologists. And the important thing is less than 17% of our population is over the age of 50, where screening mammography is very, very effective. So therefore, breast self-examination is not useful. Clinical breast examination as a screening tool, there has been a lot of circumstantial evidence to show that it works, because it is simple, it is inexpensive, it helps to downsize the tumor size, and an excellent opportunity to empower people about breast awareness. So as I said to you at the beginning, I utilized the first 5 years of relocating to prime the community, to empower the community, And in 5 years' time, we were so well known that the government of the day took notice of our proposal to the government saying that we want to partner with you. If I had come back in 2007 and said to the government, look, I've come back from the UK, I'm UK returned, I want to bring about a change, nobody would have given me a damn. It is because of the fact that we have demonstrated on the ground the impact. When I had approached the government that I'd like to partner with you, they readily agreed. And we had the chief secretary, the health secretary, the district collector, you name the people in the district, in the Hyderabad region, they were with us when we launched this program where we were training the healthcare workers. This is the Honorable Chief Minister of our state. I presented him with the pink illuminated legislative assembly, something that has never happened. And he was so happy. And this is the chief minister of the neighboring state. Now it was the undivided Andhra Pradesh in 2012 at that time. So what did we do? We produced audiovisual aids and booklets and we printed them. It took me 1 year to make the audiovisual aids. And we trained the healthcare workers to perform clinical breast examination. Women between 35 to 65 years were screened, and if it was normal, they were brought back for further screening. And any abnormality, it was reported to the district health officials, and treatment was provided free of cost. I must confess here that I am working in a private hospital which also treats Arogyasri patients, that is free treatment. I wanted to ensure that this program, hospital where I am working, should not be a beneficiary to this program. So therefore, this hospital was excluded from free treatment because nobody should raise a finger that somebody is doing social service and at the same time is attracting patients. This is a lesson and I want to share this lesson because this is something as a model which also can be implemented in Jharkhand. These are the healthcare workers who are trained in several batches. I personally took my time off to ensure that this training program was supervised. This is a typical village scenario, a community hall where you have a healthcare worker educating people in Telugu. Then you have the video which is being played, and these healthcare workers are so closely connected with these women that they, without hesitation, would allow them to examine them. If I would go to the village, which I tried, and tried to implement this, nobody will listen to me. But a healthcare worker is the nodal person. She takes people into confidence. She doesn't go to the village and say, okay, come, I'm going to do a clinical breast exam. No, she takes them into confidence. She empowers them. She gains their confidence. And then there is no problem. It is half the battle won. I had unrestricted access to the secretariat, the government secretariat, where every week, twice a week, I would be involved in clearing the doubts of the district healthcare team and also from the healthcare workers. And over a 4-year period between 2012 to 2016, over 200,000 women between the ages of 35 to 65 spread across 4,000 villages in Telangana and Andhra Pradesh were screened for early signs of breast cancer. So much was the impact that was made in the Telugu states that I was invited to be part of the technical advisory group set up by the Ministry of Health in 2016. There you see the health secretary, and I had pitched for this program to be implemented pan-India. And I'm very pleased that the clinical breast examination based screening program is now part of the National Health Mission's screening program alongside cervical and oral cancer and is being rolled out across the country. And in 2009, to assist the National Health Mission in Telangana, I submitted once again another proposal for a second round training of healthcare workers. This is the Chief Secretary of the Government of Telangana, and this is the Health Secretary. This is the Director of the National Health Mission who is standing next to me. And we were able to start this training program once again, renewing the training program so that it reaches out to so many people. So we have now entered the third phase. The third phase of the foundation is to utilize innovative initiatives to reach out to the community like never before. So what did we do? Inspired by the Prime Minister's Digital India campaign, conceived, designed, and established the world's first mobile app on breast health, which is in 12 commonly spoken languages. This is called ABCs of breast health. This has got information on every conceivable aspect of breast health. It is freely downloadable on App Store and Google Store. No questions are asked. No mobile phone number is taken. Nothing. You just go in, you can download this app. And when I had approached one of India's icons to launch this app, he readily agreed. And I said that we are not paying you anything, sir. You may charge crores of rupees, but for this app, you will do it without taking any money. He called me. He grilled me for a few hours at his home. He understood the nuances, and then he launched this, and he has now become the face of this campaign. I don't think you can hear this, but he was so very, very kind and very, very generous. Not resting on this, I had taken the help of my good friend Sindhu, who is an international icon. She and I were conferred the Padma Shri on the same year. And I said that you have to help me with launching artificial intelligence. So with augmented reality, you can reach any part of the country. If you can download that app, I can go to my adopted village sitting in Hyderabad and create awareness there. And when that person downloads that app and he just switches it on, he will see a life-size image of me or the celebrity with the local background. Here you see me in Kim's hospital. I'm in the hospital today at work. You see my background here in my office. But I can create a background just as the background is in that village. Just I can go into anybody's home, and if they download this app, they can watch me with the background of their home. And therefore, this concept is that the celebrity and the doctor can go there. This is a different presentation altogether. I don't have time to do that. So therefore, I'm just bringing in that concept of life-size augmented reality introduced for the first time in the world for breast cancer awareness. This was launched last year, and just very recently was part of another virtual on-site online initiative reaching out to 725 districts in 29 states in 12 languages. So in conclusion, ladies and gentlemen, the rising incidence and mortality and advanced stage at presentation is certainly a cause for great concern. The breast cancer advocacy over the past decade has certainly disrupted the taboo and has created that much needed awareness about early detection. Screening significantly reduces the risk of advanced disease, and in a country like India, clinical breast examination is an effective population-based screening tool. We must not, all of us sitting in this audience, all of us watching this program virtually, we must not deny our loved ones a screening mammogram every year. Deepavali is coming up. For the men in this audience, for the men watching this, please gift your loved ones, your spouse, your mother, your aunt, your grandmother, your friend, a screening mammogram. Instead of gifting a sari, or in addition to gifting a sari, the men watching this, please gift your loved ones a screening mammogram, because somewhere, someplace, some part of the country, every 10 seconds, every 10 minutes, someone is succumbing to breast cancer. You would have gone a long way in saving the lives of those who are close to you. A nationwide strategy by individuals, hospitals, NGOs, partnership with the government of India can improve the delivery of breast health care. I was so delighted when Dr. Arunima said that she was launching a foundation, a Sparsh Foundation in Jharkhand, to create awareness about women's cancers and pediatric cancers. More power to you, Dr. Arunima. If someone like me with an average or an above average intelligence can implement a program in Telangana and Andhra Pradesh, so can so many of you, intelligent people, distinguished people, connected people with the government, with the people, you can make this a people's movement. And I wish you all the best in replicating this. And I'm sure you can replicate this in Jharkhand. If your heart beats for early detection, you can certainly do so. Once again, very grateful to you and to the entire chapter for giving me this distinct honor. Namaskaram.
Very well spoken. My chairperson, Deependra, can you take over? And
Yeah. as usual, it's a spellbound presentation by Raghu. And in spite of the fact that we have been working together for almost 1.5 decades, he never fails to inspire me as a breast surgeon and inspires me to carry on my work. And as a founder of ABSI, I know the background he created. And ABSI was formed in spite of the tremendous obstacles at that point of time. And he is the guy who is responsible for creating and giving breast a subspecialty which it deserves. Thank you, Raghu, for giving this subspecialty an entity. We are deeply indebted to you. And
you are no less, Dipten, you are no less, you are no less. Your contribution has been invaluable along with Somshekhar. It has been invaluable. I am very, very grateful to you.
Thank you. Thank you. And once again, you have inspired so many of the trainees who are sitting in the virtual auditorium. And you must follow this gentleman way he created the whole story. Speaks beyond breast, how to prosper, how to go up in the ladder and keep on motivating yourself. And thank you, chapter, for giving Raghu this wonderful opportunity to present in front of the upcoming surgeons and inspire them. Thank you very much, Raghu. Over to Dr. Sunil, please.
Raghu has trained so many people. So I'm happy to announce that the person also who trained Raghu has just logged in. Can I request Rachel to say hello to Raghu? There was some concern yesterday. Can you make yourself visible and say hello to Raghu?
Hello, Rachel. Very nice to...
Hello, can you hear me?
Yes.
Thank you. Raghu, that was an absolutely fantastic talk. I am so glad that I heard it. It was absolutely inspirational. I think we need you to come back to Wales and inspire us over here if we can steal you away from India, because they are very lucky to have you. The work you've done over the last decade or 15 years or so since you've been in India is absolutely phenomenal. And I found that talk very inspiring. Thank you very much.
Thank you very much, Rachel. Can never forget, I never forget to express my gratitude. And it is because of the teachers, my parents and teachers, that I am what I am. And I can't forget, because I'm going to introduce you, of course, but you were my first trainer when I came to Wales in 2007 September, where you were a senior lecturer and a consultant surgeon appointed at the University Hospital of Wales.
Thank you. Thank you. Very inspiring talk. Thank you.
Okay, thank you very much. Arunima, back to you. Now we are done with it.
Just want to thank Dr. Raghu for introducing our organization Sparsh, which is almost in the process of completing the registration. And we would take help from you, sir, for launching that program here as well. Thank you very much. Yes, Sumegha, please take over.
Yes, ma'am. And this was the certificate of appreciation. Now I thank Satvir for the next oration.
Thank you, Dr. Arunima, ma'am. Thank you, Dr. Sumegha. And now we move on to our next presentation, which is Dr. A.K. Sahai oration. So Dr. A.K. Sahai oration, the speaker will be our president, Dr. Abhay Dalvi from Mumbai, and he will be talking upon looking back and looking ahead. We welcome our esteemed chairpersons, Dr. Jugal Kishore Chaudhary and Dr. Uday Srivastav. Our esteemed Dr. Jugal Kishore Chaudhary is a senior consultant surgeon at Deoghar. Sir has an MS, FIAS, FICS, FMAS, and FIGS. To talk about Dr. Jugal, we need to have much more time about it, but to be brief, sir is an executive committee member of 2019 to 2021 ASI, and sir has been recently awarded with ASI Social Service Award in 2020 for rendering exceptional social services in the remotest part of the country. Sir has also been a COVID warrior for his continued medical and social service during his pandemic. We welcome you, sir, as a chairperson. Our next chairperson is our esteemed Dr. Uday Srivastav, sir. Sir is a consultant general surgeon at Apeksha Surgicare Hospital, Ramgarh. Sir has an MBBS MS, and sir is a chairman of Jharkhand chapter from 19 to 20 and a secretary to Jharkhand chapter from 16 to 2018. I request the chairpersons to invite our speaker, Dr. Abhay Dalvi.
I invite Dr. Abhay Dalvi, our incoming president, ASI, to give the oration, Dr. A.K. Sahay oration. Dr. Dalvi.
Could I share my...
Dr. Avnikant Sahay, oration of Dr. Avnikant Sahay, born on 26/1/1943 at Fatehpur, Gaya district. The only child of his parents did his early education at Gaya, then shifted to Hazaribagh and did his schooling from there. Passed from St. Columbus, Hazaribagh. He passed his MBBS from Rajendra Medical College, Ranchi in the year 1966. After completing housemanship, he worked in different specialties at UK, did his FRCS from Edinburgh, UK. He published articles in British Journal of Surgery and Lancet, etc. He joined Patliputra Medical College in 1976, retired from here as HOD surgery in January 2002. He was president of Dhanbad chapter of surgeons, president Dhanbad IMA in the year 2003, was president of Jharkhand Surgeons Association in year 2010-11, was an active Rotarian and a former president. Wife Pramila Sahay, blessed with two sons. Elder son Dr. Vibhas Sahay, general and laparoscopic surgeon, married to Nitu Sahay. Grandson Aditya Adivik, younger son Dr. Vikas Sahay, married to Svetlana Sahay, settled at St. Petersburg, Russia. Granddaughter Amelia. He left all his near and dear ones in tears after a massive brain hemorrhage on 26 December 2012. But a person like him carves his name and hearts. His legacy shall remain alive in mind of others and stories they share about him. Dr. Dalvi sir.
Thank you, Dr. Chaudhary. Can you see my screen, please?
Yes, sir.
Yes, sir. Yes, sir.
First of all, let me thank the state chapter of Jharkhand for bestowing upon me this Dr. Abhini Kant Sahay oration. I believe I was supposed to speak about him. So let me just shorten it off that he moved from Gaya as a child, went to Hazaribagh, went to Ranchi, and ultimately settled in Dhanbad. He was responsible, according to me, for actually developing the Department of General Surgery, because Pataliputra Medical College, where he was the HOD, was sanctioned in 1971 and he had joined in 1976. His two publications in British Journal of Surgery and Lancet are landmark because that paved the way of safe cholecystectomy and hernia surgery, as I read from the PubMed. He was obviously the president of the Jharkhand state chapter, as well as did a lot of philanthropic work in the Rotary Club. So in his honor, I deliver this oration looking back and looking forward. Let us see what is a surgeon. Surgeon is nothing but a poisoned goblet. Many a times surgery is successful, the patient dies. What are then the surgeon's problem? He may have the technical expertise, but the nature of the disease, the pathological changes that take place in a patient, and response of a patient to treatment determines the final outcome. If I have to look back into the history of surgery, this is a picture that comes to mind. The operating surgeon was usually garbed in a black Prince Albert coat, kept hanging in the closet for occasion, and showing numerous evidences of previous operations in the way of dried blood and wound secretion. Needless to say, most of these patients who were surgically intervened died of sepsis. Speed was the hallmark of surgery without anesthesia. This is Robert Liston, who was known for his speed and skills, but while operating on an amputation, he cut his assistant's fingers, as well as one in the audience also died. So he had 300% mortality in one operation. Two revolutions in surgery were advent of anesthesia by Bigelow and antisepsis by Lister. The picture on the right up is of Semmelweis, who brought in just washing hands to decrease the maternal mortality, which is so relevant in today's corona world. And then came Halsted, who introduced the concept of rubber gloves. Between mid-1800 and 1900, there were major advances in surgery because of the support forces of anesthesia and antisepsis. And surgery and the surgeon became dominant force. Lord Berkeley Moynihan always advocated large incisions for any abdominal operation. In fact, he said, big surgeons make big incisions. And that is how we were able to do real major surgeries that are done in a minimal access way today. William Halsted brought in the training residency system into this world, which has trained countless general surgeons today. The same thing is practiced even till date, where there is a 3-year residency system which is existent in India. In my time, we had optional rotations. So we could do general surgery, orthopedic surgery, plastic surgery. There was no entrance examination for subspecialization or super specialization, and there were less number of trainees who were under training for general surgery. My mentors assured that I developed technical skills which included clinical knowledge, judgment, decision-making, dexterity, and use of correct equipment. They also ensured that I developed non-technical skills, that is ethics, logic, psychology, communication, teamwork, and situation awareness. Not only did they do that, but they also ensured that I covered my syllabus, dissertation, etc., and also made me develop a relationship not only with my juniors and seniors, but even paramedical staff and patients. Through the years that I have graduated and now nearing superannuation, specializations came into picture. Plastic surgery, neurosurgery, surgical gastroenterology, urology, cardiovascular surgery, endocrine surgery all came into market. Surgical gastroenterology has now again developed into upper GI, colorectal, and HPB surgery. The third revolution came somewhere in 1980s when Kurt Sem introduced laparoscopy. Seeing him do a laparoscopic appendicectomy, in spite of being a gynecologist, Eric Muhe went to him, observed him, and settled with, in 1985, the first laparoscopic cholecystectomy in India, in the world. In France, in 1987, Philippe Mouret was the first one who also performed the first laparoscopic cholecystectomy. On 31st of May, 1990, my respected teacher, Professor Timton Udwadia, performed the first laparoscopic cholecystectomy at the Grant Medical College and Sir J.J. Group of Hospitals in Mumbai. That possibly changed the life all over for the surgeons in India. I was destined to become an engineer. I secured a very good rank in IIT entrance examination, but with sheer pressure from my parents, I joined medical college, did my PG in 84, and joined as a staff in 1986 at St. G.S. Medical College. Graduate sometime in April next year, but I have to go on record that I was blessed with proper mentors and even mentees. Over these years, when I graduated and there were no investigations like ultrasonography or even endoscopy. I have seen the development of growth in technology over these years, and people now relying more into technology rather than hard work, self-pride, accountability, and trying to reach an excellence has resulted today into curriculum, entrance examination, bonds, super specialty considerations. One has to be politically correct, be defensive in medicine, and rely on investigations. What change have I seen in life? In my time, it was history, examination, and come to a diagnosis and then only ask for relevant investigations. Whereas now it is investigations and very little of history and examination that takes place, and nothing but high touch medicine has now become high tech medicine. The result is seen here. If you see this, this is a patient in my ward who was about to be discharged because CT scan was normal. All I had to do was examine the abdomen with visible peristalsis, and which required nothing but exploratory laparotomy and surgical resection. Just because CT scan was normal, this patient was about to be sent home. And this is what is the reality today. Time has gone very fast and the things have changed over the years. Reliance on technology is becoming more and more. But then what is happening to a resident doctor doing general surgery? There is a stressed and compressed curriculum which has to be done and learned in a 3-year time frame. There are no rotations whatsoever that take in subspecialties. No minimal access curriculum during PG is described, and the boy always has eyes on NEET to gain access into super specialty. There is less OR time that the patient, that the candidate also. The scenario today, the mentee looks at All India entrance examination. There is a language barrier when an All India candidate comes into state of Maharashtra. There is focus towards CET for super specialty. What has happened to the mentors? They are trying to cope up with the new technologies that have come up like robos and have themselves become mentees, and mentors are not looking after the mentees the way I was looked after. There are very serious problems to tackle as far as the residents are concerned. There are too many things to learn. There is no time to read or attend conferences. There is poor accommodation that is given to them, and there is no family time, leading to emotional exhaustion and depression. There is revolt and politics that comes into picture. At the same time, the relatives' wrath is also overhanging sword on their head. And this is the situation in wards in my place. The patient crowding, the relatives crowding, this is the accommodation where the residents are made to actually stay, leading to all sorts of problems that the mentors and the mentees face. Corona has exaggerated the problems. They are now made to do corona duties. All routine work is stopped. Wards are taken over by corona patients, and they themselves, the resident doctors, are getting infected, which is a cause for worry. Also, let us look at the reality that is happening at least in the state of Maharashtra and is going to come in the other states. One passes MBBS at the age of 23. Then is compulsory 1-year internship and 1 year of bond. Then you do 3 years and pass your MS. You are leading to 27 years of age plus 2 years bond now, because 1 year bond you have not done after MBBS. You do MCH at age of 30, and now you are left with 4 years bond. Otherwise, you got to give almost nearing 2 crores of rupees to get rid of the bond. So you start your career at the age of 34. I was settled by the age of 34 with a nice son and on the staff of St. James Medical College and KEM Hospital. More things are coming in. Competency-based medical education is now being thrust upon the students who are in graduation and post-graduation. Compulsory primary health care duty for 3 months is also done. There are bonds, as I said, at MBBS, MS, and MCH levels. Surprisingly, if one takes up DNB, there are no bonds. In private medical colleges, there are no bonds. There is reservation confusion in promotions. And that's why, as I see, good doctors are leaving Maharashtra and going to places for super specialty in places where either there is DNB or there is no bond. Today, the mentor's responsibility, as I see, is to enthuse confidence, protect their OR time, give good clinical sense to a patient, involve them in research, and above all, make them humans again. Make them realize that reliance on technology or investigations is not a good thing. What can be covered? You can tell them to operate slowly but think quickly, have good sound judgment, know your limits, and do only what you can practice properly. Keep learning from mistakes and learn continuously. What is faded is analyzing the data, enjoy the work, establishing relationships, humility, ethical behavior, and most important, balancing of life. The mentor should guide and advise following things which are non-existent today: pre-operative communication, clinical performance, technical expertise, post-operative hawk's eye communication, and the future of any given patient that you are treating. In '92, when I got a unit, I was a good open GI and HPV surgeon, but was thrust into minimal access surgery by the then head of department. I think I have done a good job as a minimal access surgeon, training my mentees into minimal access surgery, and most of them are now known nationwide and are called as faculty all over. From the Department of Surgery, as I'm nearing superannuation, we had completed 25 years of minimal access surgery, and a token of appreciation I received from my own dean, Dr. Avinash, as well as my teacher of laparoscopic surgery, Dr. Agarwal, whom all of you all must be knowing. What is even more sense of satisfaction is my own student who has penned a book, Clinics in Surgery, writes to me, "You are not only my teacher, but my friend, and always remain guide. I will be always grateful for your support and kindness. You are my role model, and your leadership is the source of inspiration for giving me a tool to dream big and to reach success." Dr. Rai Patankar, whom everybody knows, I'm indebted to him to have given me this reward, saying leaders don't create more followers, they create more leaders. And I have to go on record and thank Roy for this wonderful thing that he has bestowed upon me. A person like him carves his name on hearts. His legacy shall remain alive in mind of all. This is what is written in favor of Dr. A.K. Sahai. I take this opportunity to thank ASI Jharkhand State Chapter for bestowing upon me this prestigious oration. And with folded hands, I thank all of you all for bestowing me this oration. Thank you so much.
Thank you to our incoming ASI President, Dr. Dalvi, for this, showing a good picture of evolution in surgery in time and the guidance for us. Thank you, sir.
Thank you. Thank you.
Go to Sukhbir.
Thank you, sir. This is a small token of appreciation from Jharkhand, sir. Jharkhand Jasicon.
Sir, this will reach you after the conference is over. This is a real piece.
No problem. Otherwise, I'll come and collect it.
Yes, sir. That would be the best.
Very nice. So touchy. Very nice.
Please accept this certificate, sir. And please, Dr. Dugal, sir, please accept this certificate for chairing this wonderful session. And Dr. Uday Srivastav, sir, thank you very much.
Thank you. Thank you.
Thank you.
So now I
Thank
hand
you.
over to Dr. Yes, ma'am. Yes, sir. Now I hand over this session to Dr. Sumegha for Dr. Rambali Sinha oration.
Rambali Sinha is already done.
Dr. Shabir Alam oration. Dr. Shabir Alam.
Thank you, Satvir. It's Dr. Shabir Alam oration. Now I welcome my eminent chairpersons, Dr. Vijay Kumar and Dr. Professor R.G. Bakla. Dr. Vijay Kumar from Jaltanganj, Sahibganj. We all know him very well. Executive Committee in ASI Jharkhand chapter, and also working in many professional bodies. We welcome our next other chairperson, Professor Dr. R.G. Bakla, presently heading the Department of Surgery in RIMS Ranchi. Now I request Professor Bakla to invite and introduce Dr. Chokar. So, Professor Bakla.
Okay, Dr. Vijay can only introduce him and do the rest if Dr. Bakla is not able to log in.
Hello.
Let's go ahead. Yes.
Okay,
Yes,
I request Dr.
Vijay.
Vijay to please introduce Dr. Chokar.
Okay. My honorable guest speaker for this oration, Dr. Devendra Chokar. He is HOD, Head and Neck Onco Surgery, Tata Memorial Hospital, Mumbai. Currently appointed as office in charge HBCH and RC and NCG coordinator, speaker in various national and international conferences. He has numerous publications in various and international journals, author in several textbooks, principal investigator in various ongoing research projects. You are most welcome.
Sir, now I request Professor Vijay sir to please read the oration, read about the Shabir Alam. Vijay sir, please.
This oration is in the memory of late Dr. Muhammad Shabir. He was a young surgeon. I would like to say words. Dr. Muhammad Shabir Alam, Dr. Mazid Alam, had a small but bright career as young laparoscopic surgeon of Jharkhand. He was born on 6th February 1972. Did his schooling and college in Ranchi and Ranchi. He did his MBBS from JN Medical College, Belgaum in 1996. Postgraduate examination in general surgery from SC Medical College, Cuttack, with a gold medal, 2001. He joined as assistant professor in KMC Manipal, where he was loved by the students as a very good teacher. On coming back to Ranchi in 2005, he worked as consultant general and laparoscopic surgeon at Alam Hospital and Research Center, where he was also a DNB guide. He had many publications to his credit and had received Rashtriya Chikitsa Ratna Award in New Delhi in 2009. He had conducted the first workshop in Jharkhand in 2012. Apart from his academic achievements, he was a human being par excellence who was known for his philanthropy. He was loved and admired by the masses, and he was awarded Jharkhand Seva Samman posthumously. I had an opportunity to come with him, and he was really a gentleman par excellence. He was son of Dr. Mazid Alam, my co-guide during my MS examination, MS course. Thank you.
Thank you, Dr. Vijay. I think we have Dr. Bakla. Dr. Bakla, you can welcome our guest speaker.
I request Dr. Devendra Chowkar to start his oration.
Thank you, sir. Thank you for the invitation. And at the outset, I would like to thank the organizers and the Jharkhand chapter of ASI for bestowing me with this prestigious oration. Enough has been said about Dr. Shabir Alam, a surgeon par excellence, a great human being, a philanthropist. And the thing to learn about from him is that you can achieve so much in such a short period of time if you're focused and if you continue to work for the masses. So the topic given to me today is management. Can you see my screen? I'll make it full screen. Are you able to see my screen?
Yes, we can see your screen. You can just make it full.
Yeah, okay, perfect. So the topic today is current trends in the management of thyroid cancer. And we just heard a great oration from Dr. Dalvi, who's been an inspiration to all of us surgeons, young surgeons, when we were training. And he talked to you about the evolution in surgery and how from fast surgery we went to safe surgery. And it is true even in thyroid cancer, where one surgeon used to hack out the thyroid in no time. And then we had a lot of palsies and a lot of parathyroid, hypoparathyroidism. And then the concept of safe surgery came in, where we learned to do surgery not the fast way, but the safe way, and to preserve important structures. So we moved away from doing surgery quickly to doing surgery safely. And it is very true and important in thyroid cancers. If you look at thyroid cancers, over the last 2 decades, there's been a steep rise in the incidence of thyroid cancers. The rise is mainly in papillary thyroid cancers and mainly in small tumors, 0 to 1 centimeter and up to 2 centimeters. And even if there is a sudden rise in thyroid malignancies, the mortality of thyroid from thyroid cancer has almost remained the same, telling us that we are probably only detecting more and has changed nothing as far as mortality or death rate is concerned. This is also true. America reported around 470,000 women and 90,000 men may have been overdiagnosed with thyroid cancer in the last 2 decades. A problem acute in USA, France, and Italy. This is mainly because of, we do a lot of investigations. Dr. Dalvi mentioned that we have moved away from clinical examination to investigations, and for everything now we do investigations. And with the advent of PET scan, we see that PET is being done right, left, center. And we are now picking up lesions which we probably would have lived and died with. We are picking up more prostate cancers. We are picking up small nodules in the thyroid. And once you pick up, the patient has anxiety, and then you have to do something about it. So there has been a major problem because of overdiagnosis, because of technology that has infiltrated the medical scene. And this problem was acute in Korea, a completely different story in Korea. In Korea, they implemented screening for common cancers, the breast cancer, cervical cancer, gastric cancer, colon cancer. And these places where you could get this screening done, they said that if you pay another $30, you would get your neck screened and get your thyroid screened. So many people opted for that and got themselves screened. And because of that, the ultrasound picked up nodules in the thyroid, small nodules, mainly less than a centimeter. So once you pick it up, you stick in a needle, it comes as thyroid cancer, and now you have to do something about it. So robotic surgery, and that is one of the major reasons why robotic or scarless surgery, as they call it, or neck scarless surgery, as they call it, developed in Korea, because they were picking up smaller nodules, they were operating more patients. Acute problem, there's no problem picking up more thyroid nodules. The problem was that you would probably not need to treat these if you had never picked them up. They would live and die with these sub-centimeter cancers. If you look at autopsy rates, 30% would have thyroid cancer. They never knew about it, and they died without having any problems of that thyroid cancer. And because of this high incidence of thyroid cancers, my today's talk is going to be based on the ATA guidelines and mainly the change in the ATA guidelines. There has been a substantial change from 2009 to 2015, the ATA guidelines. There have been significant new changes, about 30%. But if you look at the tone of the 2015 ATA, the entire tone of 2015 guideline tells us less is more. They changed their philosophy because we were picking up more thyroid nodules and probably causing more harm by way of more recurrent nerve palsies and more hypoparathyroidism by operating lesions that we probably did not need to operate upon. So the entire tone of 2015 is less is more, and we'll look at that. Just for the residents in the auditorium, thyroid cancer is treated, we should know what thyroid cancer is basically, a follicular derived cancer. And because it retains the features of the parent cell, it concentrates iodine, it secretes TG, and is responsive to TSH. So you have radioactive iodine you can fall back on for treating thyroid cancer. It secretes TG, so you have a marker for detecting recurrences or monitoring response, and it is responsive to TSH, telling us that you have one more tool of suppressing TSH in treating thyroid cancer. So the entire basis of treating thyroid cancer is an understanding the biology of these well-differentiated thyroid cancers. How do you evaluate a solitary thyroid nodule? Well, the first investigation when we were training, a lot of our patients went for a scan, and we were told that if it's a cold nodule, 80% there's a high chance it can be malignant. Stick in a needle only if it's cold. That's done away with now. So if the patient is euthyroid, we don't need to do a scan unless the patient has low TSH. So if you do a TSH first, if you're suspecting hyperthyroidism and the TSH is low, the patient goes for a scan. Otherwise, you do not need to do a scan. The two basic investigations that you need to do is ultrasonography and FNAC. And I'm going to talk of this a little more, looking at what changes have happened from 2009 to 2015. And a couple of investigations that we talk about is whether do we need to do thyroglobulin and calcitonin in the preoperative workup. Not necessary. An intact thyroid will secrete thyroglobulin, so it does not add much to your clinical judgment. And calcitonin, well, there is nothing for and against, but given the incidence of medullary thyroid cancer is so low that doing calcitonin for all patients is not cost effective. So let's look at sonography. Now, when you send the patient for sonography, I urge you to tell your radiologist to report it in a certain format. You know, we normally get the size of the lesion and they tell us there are a few microcalcifications here and there, and there's some amount of solid and a cystic component. Doesn't help you too much. Ask your radiologist to classify the sonography findings by taking into all the features that tell us whether it's malignant or not, and then classifying it according to the TI-RADS. The TI-RADS tells us the chances of the nodule that is likely to be malignant, helps us make our clinical judgment a little better. So make use of technology to make your clinical judgment, as I'm going to talk about later in my talk, and how do you clinically judge which nodules to operate or not. So basically use technology to make a clinical judgment. Ask your radiologist to report in the TI-RAD format. While I'm on investigations, a touch upon CT scan and PET CT. There's a lot of talk when to do the CT scan. Clearly, the indication of CT scan is when you think it's a locally advanced thyroid tumor. So if it's not moving well, if there are multiple bulky nodes, it's going into the retrosternal area, you're unsure about upper aerodigestive tract involvement, that is the time you ask for a CT scan. Again, as Dr. Dalvi said, let your clinical judgment guide your investigation. Do a CT scan if you feel that it is invading the upper aerodigestive tract, or it is going beyond what you clinically can see or what the ultrasound is telling you. Well, there are there's a school of thought now which is emerging, which does a CT scan routinely to look at nodes. As you all know, ultrasonography is not very good in picking up central compartment nodes because the thyroid gland is in situ, and a lot of people do CT scans to pick up central compartment nodes in guiding extent of surgery. The one point I would like to make mainly for the residents is that when you ask for a CT scan, always ask for an IV contrast. There's a lot of debate whether we should give IV contrast in a thyroid patient preoperatively. There is no problem. This gets washed off in 3 to 4 weeks. By the time you operate and the patient gets ready for radioactive iodine, if at all he requires, the contrast will have washed off. So please do an IV contrast. You can look at the vessels. It gives you a better delineation of the extent of your thyroid lesion. PET scan is a new tool, and everybody asks for a PET scan. Thyroid, not necessary unless it is a very poorly differentiated histology where you are expecting metastasis out of the thyroid, out of the thorax. Mainly, the well-differentiated thyroid cancers will metastasize to the lungs. You can do a CT neck and chest, but if you think that it's a poorly differentiated cancer and you are expecting metastasis elsewhere, then you can get a PET CT done in one investigation. You will get all the site of metastasis. Right. So coming to FNAC, we've looked at ultrasound. Let's look at FNAC. There are a couple of changes that have happened in the field of FNAC from 2009 to 15. In 2009, they told us that if there is a high suspicion on ultrasonography, you should stick in a needle. In 215, they did away with that. And they said that if the size is less than a centimeter, you don't need to stick in a needle. And I'll come to that. It's not only regarding FNAC, it is regarding treatment also, because of the biology of thyroid cancers that we learned over time. However, they said that if you have high risk history, that means if you have family history, if you have history of radiation therapy in your childhood, then you need to evaluate these nodules. Also, if the nodule is a solitary nodule which is picked up on a PET, it's not a diffuse uptake, but a solitary uptake in the thyroid, a focal uptake rather in the thyroid, and not a diffuse uptake. And again, for the residents, there is something called as a flip-flop phenomena. That means in well-differentiated thyroid cancer, you have more of sodium ion importers. That is why you pick up radioactive iodine. As opposed, as it gets more and more de-differentiated, you might get more of GLUT receptors, and that is when the PET uptake or 18-FDG uptake increases. So well-differentiated will pick up less of 18-FDG and more of radioactive iodine. And as it gets more de-differentiated, you get. So again, it's high risk if there's a focal uptake on PET, not a diffuse uptake. Diffuse uptake is usually inflammatory, but if you have a focal uptake, then you need to evaluate these nodules. So the tone of the ATA guidelines has changed. It has told us that you don't need to stick in a needle for all nodules that are less than a centimeter, even if it is high risk feature on ultrasound. And this is because of a study that comes from Japan initially. What they did was from 93 to 2002, because there was an increased incidence and the incidence was going up, they decided why not observe sub-centimetric nodules. So they offered the patient that if you are a sub-centimetric, even if you are papillary thyroid cancer positive, we will not operate on you and we will just observe you. They obviously did not observe nodules in certain locations. That is, if it was close to the trachea or the recurrent laryngeal nerve, that was exclusion criteria, even if it was sub-centimeter. So they offered observation. Obviously, less people chose that because it was a new strategy. But of the people who chose observation, very few needed surgery. More than 70% had no change in their nodules, and very few developed lymph node metastasis or increase in size, which prompted surgery. This is an old paper, but a recent paper from the Tuttle US group looked at Japan, Korea, and the US, observed patients more than 4 years median follow-up. You look at enlargement, 4.7% in Japan, 9% in Korea, and less than 4% in the US. Very few patients went on to develop nodal metastasis, less than 2%, and very few patients had to be transferred into the surgical arm, telling us that sub-centimetric thyroid nodules, even if they are malignant, have an indolent nature and do not, may not affect a patient in their lifetime. And maybe we have another mode of treatment, that is observation. So this concept is coming in from Ito's group from Japan, and now more and more countries have adopted this strategy. So clearly, we have gone down. So no FNAC for less than a centimeter, and probably surveillance. And we look at it again when we look at the extent of surgery. So I told you that please ask your sonologist to report it in the TI-RADS form, and now the ATA has told us cutoffs on size. So even if it is high risk or intermediate risk, there is no need to do an FNAC if the nodule is less than a centimeter. If it's more than centimeters, stick in a needle. As you go down the ladder and it is appearing more and more benign, you obviously do not have to stick in a needle unless the size is bigger. If you have a bigger nodule and there is some suspicion, then you stick in a needle. Otherwise, you do not need to investigate these patients. The next question that comes to your mind is, fine, I have observed this patient. It was low suspicion. How frequently do I do it? Will it grow? Will it develop lymph node metastasis? So how frequently? You know, our patients, the classic teaching or the classic thing that is told to us is our patients are come from far off. They can't come from for sonography repeatedly. The thing is that you do not have to do repeated sonography. If you look at the guidelines of 2009, they told us that if you have a nodule growth, which is 50% volume or 20% in diameter or more than 2 millimeters, you need to evaluate that nodule. Well, as all of us know, ultrasonography is very operator dependent. So this 50% increase can vary from people, from person to person, or depending on who the sonologist and what is his experience. They have done away with that in 2015 and told us that unless you have suspicious sonographic features, you do not need to stick in a needle. And you don't need to call the patient every 3 to 6 months. You can do a repeat sonography a year later, and if that is benign, you do not need to follow up the patient again and increase your the duration of follow-up. This is because we know that thyroid cancer is indolent. They do not grow overnight. It grows at a very, very slow pace. So you can keep the patient under surveillance and not stick in a needle unnecessarily. Once you decide to do an FNAC, as it's true in radiology, you ask a pathologist also to report it in what is called as the Bethesda system. Now, Bethesda is a place where the pathologists got together and devised this system so that the pathologists could talk to each other over the countries, and we could have a systematic reporting pattern of the FNAC. As all of you know, Bethesda has 6 categories from non-diagnostic to malignant. What changed the Bethesda classification was something that was discovered later. One of the encapsulated low-risk follicular variant of papillary thyroid carcinoma was absolute indolent behavior. And they thought that this, rather than calling it as a carcinoma, because then you will have to operate the patients, the patient's anxiety level goes up. They classified these low-risk encapsulated follicular variant into NIFT-P, that is non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So they changed some of the cancers from cancer to non-cancer, and that had an implication on the incidence of positivity of your FNAC diagnosis. So it from if NIFT-P was initially cancer and Bethesda 3 had an incidence of 10 to 30%, it came down to 6 to 18%. So if you have a Bethesda 3 reported, the chances that the patient will have malignancy is now 6 to 18%. A thing about Bethesda that I want to tell you is don't apply this classification immediately into your institute. Look at your own institute risk of malignancy. For example, in Tata Hospital, most of the class 4 Bethesda are malignant because we are a tertiary center. Most of the patients that get referred to, we are biased towards malignancy, and most of the patients that come to us are malignant. So most of the Bethesda 4 are classified as turn out to be malignant. So look at your own classification system, develop your own risk stratification in your own institute based on the Bethesda classification. So the next question that comes to our mind is, what do you do for 3 and 4? For 1 and 2, easy. Don't do anything, non-diagnostic, benign, very less chance that this may turn out to be malignant. Observe them. For 5 and 6, definitely you need to intervene, a high chances of malignancy. 3 and 4, we don't know what to do, or difficult decision whether to operate or not to operate. And this is where molecular markers have come into practice. I'm not saying they've come into practice, but this is where they may help in future. And as you know, that no talk or no oration is okay without talking of either molecular or the word molecular or the word genetic, though I understand very little of it. But yes, it has come into our lives, and we have to deal with it. So there are a lot of molecular tests. There's 6 different types of tests that are available. Complex talk, it's a talk by itself. But the basic thing that we need to remember is these tests are classified into 2 types. One is the rule out test and the rule in test. Now, to rule out test means that you rule out cancer. So it has a high sensitivity or a negative predictive value. So if you use this test and it tells you that this test is negative, then it rules out malignancy. That means the chances of malignancy from, say, 30 to 40% for type 4 Bethesda comes down to less than 5%. So if a patient walks to your clinic and says, "Doctor, I do not want surgery. I do not, can you avoid surgery? It's Bethesda 4. Can you avoid surgery in me?" You will use the rule out test as a marker to tell the patient, yes, it's less than 5%. The chance of you having malignancy, we can observe you safely and tackle this at a later date. When do you use the rule in test then? Well, rule in test is rarely used. It is used when you have decided to operate on the patient and the size of the nodule is, say, 3 or 4 centimeters. And if you had the diagnosis at hand, you would have done a total thyroidectomy. So when you are contemplating a total thyroidectomy, but you do not have a positive diagnosis in hand, then you use the rule in test. Very rarely used. It will tell you that this is malignant or very likely to be malignant, and then you're justified in doing a total thyroidectomy. So if at all you use the molecular test, use the rule out test. Current situation, these are very expensive. We do not use them regularly. even the ATA guidelines of 2015 have used it as a permissive language rather than a directive. So you don't need to compulsorily use a molecular test for Bethesda 3 or Bethesda 4. And they are also not easily available. So what do you do then? How do you decide what you're going to do with class 3 and class 4? Go back to what Dr. Dalby told us. Use your clinical examination, your clinical judgment. Look at the history. Extremes of age, very high likely it's going to be malignant. Male gender, higher chance. Any positive history, look at your examination, if you have nodes, if you have fixity. Look at the ultrasonography features. Look at styrides. If it says styrides 4, Bethesda 4, then you know that the chance of this becoming malignant are higher. As I said earlier, use investigations to your benefit for your clinical examination. So if ultrasonography tells you it's high risk, if Bethesda tells you it's high risk, your clinical examination tells you it is slightly firm and higher risk, go in and operate. If thyroids is 2, it's a Bethesda 3, you can tell the patient, I'm going to follow up. It's a small nodule. You can tell the patient it's an indolent cancer. Even if you have cancer, I can observe you and we can see how it progresses over time. So use your clinical judgment in operating or not operating Bethesda 3 and Bethesda 4. Once you decide to treat, a decade-long or a long-standing discussion in thyroid malignancy and debates in various forums has been total thyroidectomy or hemithyroidectomy. What do you do? Now, this is a major change that has happened in the ATA from 2009. It was more than a centimeter. You had to do a total thyroidectomy. In 2015, they changed this and said that if it is between 1 and 4, you can do a total or do a less than total, that is a hemithyroidectomy. You need not do a total thyroidectomy in all cases of 1 to 4 centimeters. Also, one change that occurred in 2015 was the definition of T3 was altered. So microscopic ET was removed and more emphasis was placed on gross ET. And I'm going to talk about this a little later. So let's talk of the extent and why this changed. In 2009, before 2009, we had this Bilimoria paper, which told us that the 10-year survival rate of total thyroidectomy was slightly superior to lobectomy. And that is why the 2009 guidelines included total thyroidectomy for more than 1 centimeter lesion. This changed when Adam and Sosa looked at the same database in a better way, slightly more patients, and said that there is no survival advantage doing a total thyroidectomy. And this is why the language from 2009 to 2012 changed. And between 1 and 4 centimeters, they confused us further, telling us that, okay, you decide what to do. We can't tell you which is better. You want to do a hemi, fair enough. You want to do a total, that is also acceptable. So again, what do we do in our practice? Clearly, we follow this. Less than a centimeter, we would do a hemithyroidectomy. We generally in India, not many of us have adopted the wait and watch policy for less than 1 centimeter when it is FNAC positive. So we would do a hemithyroidectomy. So clearly low risk, no other features, less than 1 centimeters, hemi, no debate. More than 4 centimeters, high risk, more than 45, 55. I put the age as 45 to 55 because there has been a change in age from 45 to 55 in the recent ATA guidelines, and the cutoff now is 55. So age is a continuous variable. You can't really put a cutoff. But as the patient gets older, the chances of malignancy increase. As the size increases, the chances of malignancy increase. So if you have more than 4 centimeters or any other features which make it high risk, you do a total thyroidectomy. The real problem is 1 to 4 centimeters. What do you do? Again, you go back to discussing with the patient, looking at all your clinical inputs, the ultrasonography findings, and making a decision on whether you want to do a hemi or a total. So I'll give you an example. So if it is a 2 centimeter lesion with a minor ET, I may not want to do a total thyroidectomy as opposed to a 3.5 centimeter lesion which has a minor ET. Now, minor ET is taken off, as I said earlier, from the T3 classification. But it for me as a clinician, a larger lesion, minor ET, slightly elderly patient, a male patient, I would go towards doing a total thyroidectomy. A younger patient, less about a 1.5 2 centimeter lesion, no ET or minor ET, I would then do a hemithyroidectomy. Now remember, though the ATA guidelines tell us that between 1 and 4 centimeters, there is no difference in survival. All these papers have looked at survival and not at recurrence. And ATA itself admits that there may be a higher recurrence chance if you do a hemithyroidectomy. So base your decision on the size, the age, your clinical inputs, and then make a decision between 1 and 4 centimeters about doing a hemi or a total thyroidectomy. And that's how what policy we would follow at the Tata Hospital. So we had one debate, which was hemi versus total. And now, because we got bored of it, we have another debate that comes in, is the management of the neck, mainly the central compartment of the neck. Now, if you want to manage the neck in thyroid cancers, you must look or must understand the importance of nodal metastasis in thyroid cancers. And this is a very elegant paper from Michael Tuttle's group, which looked at whether all patients with N+ disease have the same magnitude of risk of recurrence. Always when we talk of nodes, we talk of risk of recurrence because thyroid is the only cancer where age is significant and nodal metastasis does not impact outcomes in thyroid cancer. This is probably the only cancer, at least in the head and neck, I know, that nodal metastasis does not have an impact on overall survival, but it definitely has an impact on recurrence rates. So they classified nodal metastasis into clinical palpable and CN+, ultrasound detected, and pathologically detected. And what they saw was if you had a clinically N0 and pathologically N0, or even if you had a small microscopic nodal metastasis and less number of nodes, the risk of recurrence did not change. It remained at 4 to 6%. The moment you have more number of nodes, or you had gross extrathyroidal extension, or the size increased, the incidence of metastasis, the incidence of recurrence increased. So then they classified nodal metastasis as low risk, clinically N0, micro metastasis, small number of metastasis or less than 5 nodes as low risk, and high risk was if you had a larger node, you had extrathyroidal spread, or you had more than 5 nodes. Then you need to take oxygen. So basically, the tone of telling us whether to do central or not changed. Even if you had low volume metastasis, it does not change anything. You did not convert this into a total thyroidectomy unnecessarily. Well, this debate has been ongoing, and there are a lot of meta-analysis whether or not to do central compartment. There is no consensus yet, but what is known that even if you don't do a central compartment, the risk of structural recurrence in the neck is extremely low if you had low volume or no central compartment metastasis. So what do? We definitely do the central compartment if there's a nodal disease present, if it's a large size T3, T4, if you have gross ET, or if you have lateral compartment nodes. Otherwise, in all cases, we inspect the central compartment. And even if you have Bethesda 4, what I urge the residents to do is, when you do a hemithyroidectomy, you don't have a diagnosis. Sometimes you can have a pathological surprise, and that may come as papillary carcinoma later, and then you don't know what to do with the central compartment. So always when you do a hemithyroidectomy, inspect your central compartment. Just open up that fascia. Don't do a gross exploration, but just inspect the central compartment and note it in your findings that there were no central compartment nodes. Because even if you miss the microscopic nodes, it's not going to change the risk of recurrence. So that's as far as the nodal metastasis goes. And just to complete the nodal metastasis, lateral neck dissection is done for palpable lateral disease, if there's radiological evidence on ultrasonography, or if you have positive central compartment. One of the factors for positive lateral compartment is a positive central compartment node. Of course, you can have some skip metastasis. Usually upper pole, 22 is a high number, but usually the figure is about 10%. And we do not operate the lateral compartment in the absence of central compartment disease or clinical radiological involvement of the lateral compartment. Do I have another 5 to 10 minutes? Because I'm just ending my talk in about 5 to 10 minutes. If that's all right. Otherwise, we can talk later.
I think, if you can finish in next 2-3 minutes, 2 minutes.
Okay, I'll do that. So once you operate the patient, then you classify them into the risk stratification. It has been modified. You have low risk because of the nodal disease. So if you have low nodal disease, it's still low risk. So classify your patients according to this risk classification: low risk, intermediate, and high risk. Now, this has 3 implications. The first is you will decide whether or not to give radioactive iodine. So if you have a low risk patient, you need not give radioactive iodine. And we do not have level 1 evidence for it. It's being generated as we talk. The ION trial in UK is looking at low risk and low intermediate risk patients, whether or not to give radioactive iodine. So currently in low risk, you may or may not give radioactive iodine. In intermediate risk also, you may consider not giving radioactive iodine, but in the high intermediate risk and the high risk, you must give radioactive iodine. If you decide to give radioactive iodine, this is one change that has happened. We don't give more than 30 millicurie because the high-low trial told us that 30 millicurie is as good as 50 to 100 millicurie. So if you have to give radioactive iodine, 30 to 30 millicurie is as good as 50 to 100 millicurie. The second implication of risk stratification of your patients is to for TSH suppression. So if you have a low risk, you keep it at the low range of normal, 0.5 to 2. The intermediate risk, it goes to 0.1 to 0.5, and high risk, it is less than 0.1 suppression. Now, suppression has an impact on your cardiac and your bone function. So you do not want to suppress unnecessarily. And this is the change that has happened from 2009 to 2015. As I said, this classification is not static, but is dynamic. What do you mean by dynamic? So suppose you have an ATL low risk patient whose TG is rising. He does not continue to stay in the low risk. He's going to become intermediate risk because his TG is rising. As opposed to that, you have an intermediate risk patient who was intermediate risk initially, but now has been okay for 20 years. Why do you want to suppress him so that his cardiac and bone takes a hit? He does not remain in the intermediate risk, and he moves down from intermediate to low risk. And I will skip a couple of slides. So this is the risk, response assessment. You have excellent response. You have biochemical incomplete response, where you have only the TG rising, and you have structural disease, and where you have structural disease present. That is called structural incomplete response. And the indeterminate response, we don't know whether what is picked up on your scan is actually disease, and you have a fairly small increase in the TG. So look at your response rate, and then you dynamically stratify these patients. So if you have a patient who is in the intermediate risk and has been okay for a long time, you can come down, and this dynamic has basically, impacted on the intermediate risk, where they migrated to low risk. You could come down on the TSH suppression. You could come down on the need for follow-up. So don't keep the patient in any one risk stratification criteria. And finally, my last slide is, in the long term, we all know that we follow up these patients with sonography and thyroglobulin. Now, 2009, they asked us to do a stipulated thyroglobulin at 12 months. They've done away with that. We have more sensitive thyroglobulin monitors. So you don't need to do a stimulated TG at 12 months, and you don't need to look at the patients before 1 year, because thyroid cancer usually, especially in the low and intermediate risk, grows very slowly. So do it after 1 year, and you don't need to do a stimulated TG. Just do a sensitive TG assay, and that should be good. Finally, to conclude, we have gone down. Less is more. We are doing less FNACs. Don't poke in a needle if it's less than a centimeter. You also may observe the patient or defer surgery for some time if the nodule is less than a centimeter. So we have higher threshold for surgery, 1 to 4 centimeters. Many of us would now do a hemithyroidectomy and safeguard our parathyroids and the recurrent laryngeal nerve. So less extensive surgery, lesser role of radioactive iodine, the low risk and the low intermediate risk, no need. Even if you have to give, you can give a lesser dose of 30 millicurie, and lesser surveillance. Don't keep calling your patients every 3 to 6 months. You can call them in a year and then increase the gap as you go on. And the last but not the least is more communication with patients and caregivers, which will save you all litigations and problems that happen because of thyroid surgery. So thank you once again for inviting me and giving me this prestigious oration. I thank the organizers, and I would be happy to take any questions if there are any.
We do not allow questions and orations, Dr. Chokar.
Okay,
so
fine.
I will ask the chairpersons to conclude.
Many thanks to Dr. Chokar. You have given so informative and latest information to the audience. And on behalf of ASI Jharkhand chapter, again, I'm very much thankful and grateful to you.
Well, thank you very much for your brilliant oration, Dr. Devendra.
Thank you.
Yeah, I would just like to say that I have met Dr. Chokar as a patient's relative, and it was very important for me to meet him as a non-patient. So having him here as in Jasicon is a pleasure. Welcome, Dr. Chokar, to Jharkhand.
Thank you, Dr. Verma. I was hoping to come there. I've never been there, so maybe next year.
Yes, absolutely.
We are very grateful from Jharkhand state for looking after all our patients from Jharkhand. We always look up to you whenever there is any head and neck issue.
Anytime,
so
Dr.
thank you very much.
Anytime.
Yes, Sumegha, take over.
Yes, this.
So Megha, please take over.
Yes, ma'am. This is the memento which you will be getting, sir. And I thank all the chairpersons and Dr. Chaukat to give his precious time. And now I think we have to move on for the next oration, which we left yesterday, if I'm not wrong.
Oh, Lady Angie.
Yes,
Yes. Sumit, please take over. Let's start because we do not have time to delay. Thank you, Dr. Bakla.
Okay, thank you.
Sumit, are you there?
Yes, madam, I'm here.
Yeah, just start. Just invite.
One minute, madam, just PPT. That's it. Are my slides visible?
Yes.
Sumit, go ahead.
I welcome all my delegates to Dr. G. Das Sir oration. I also welcome my esteemed chairpersons and speaker. Our chairperson, Dr. P. Raghuram, is Padma Shri Awardee, Dr. B.C. Roy Awardee, and President, Association of Surgeons of India. Dr. Arunima Verma, she is Head of Department of Surgery, Tata Motors Hospital, Jamshedpur, Chairman-elect, ASI Jharkhand Chapter 2020-21, Editorial Board Member, Indian Journal of Surgery, Editorial Board Member, Journal of Minimal Access Surgery. Now I'd like Dr. Arunima Madam to kindly introduce our speaker, Ms. Rachel Hargest.
I would ask Dr. Raghuram to introduce the speaker and I would read the oration details.
Yes, madam.
So thank you very much once again. Nothing gives me more pleasure than to introduce Miss Rachel Hargest. I've been a trainer. In fact, my first SHO job was at the University Hospital of Wales when she was just appointed as a senior clinical lecturer in the University Hospital of Wales. So it is a tremendous pleasure to introduce Ms. Hargest, who qualified at the Charing Cross and Westminster Medical School and undertook training posts in and around London. Her first training post as a registrar in Johannesburg was in fact the defining moment of her training. A cancer research campaign clinical research fellowship led to an MD degree, and then she was appointed as a consultant surgeon in Abergavenny in 2000. She then moved on in 2007 to the University Hospital of Wales as a clinical senior lecturer, her main interest being colorectal surgery and especially familial cancers, anal cancers, and intestinal failure have been her special interests. She has served on a number of committees on the All Wales Surgical Training Committee, Executive Board of the Welsh School of Surgery, the Welsh Board of the Royal College of Surgeons, and she has been an active member of the Royal Society of Medicine, which is an organization that is responsible for conducting a number of CME activities. And there are a number of subsections in that. And she's been a very active member of the surgery section of the Royal Society of Medicine, for which she has also served as the president. She was also the council member of the Royal Society of Medicine and has also served as a treasurer. She has served as a member of the executive committee of the British Association of Surgical Oncology, the management board of the National Institute of Clinical Excellence, National Collaborating Centre for Cancer, and an active member of the British Society of Gastroenterology and British Society of Gene and Stem Cell Therapy. So she has, very extensive experience. But what I'd like to highlight is in the year 2017, she was conferred the Surgical Trainer of the Year by the Association of Surgeons in Training. This is the highest recognition that is given by this independent professional body and charity that promotes the highest level of surgical training in the United Kingdom. It is extremely difficult to get selected. It's a robust selection process which involves, looking into various aspects such as leadership, resourcefulness, training and development, professionalism, and communication. And she is the only lady, if I'm not mistaken, in the 20 years since ASIT was formed, that she has been conferred this very prestigious honor. And it is well and truly a great pleasure to welcome her virtually to India. She, of course, will be participating in our flagship annual conference as well. And she's here today to deliver Dr. Das' oration on enterocutaneous fistula. Welcome, Rachel.
Thank you. Thank you. I'm very honored to have been invited to give the Dr. Gyancham Das oration here at the Jasicon conference. I wish I could be with you in person in India. I have only visited India once, but I would very much like to visit again. But virtually one can visit any country in the world. Dr. Das was born on the 7th of November 1933 at Jambor village in Aurangabad district in Bihar, and he resided at Neelam Cottage, Tagore Hill Road, Moradabadi, Ranchi. He completed his MBBS with honours in 1956, his MS in general surgery and MS in plastic surgery and diploma in anaesthesia from Patna Medical College and Hospital. He joined the State Health Services on the 20th of November 1957, and he started his career as a teacher at the Patna Medical College and Hospital in Patna in 1961. Thereafter, he joined the Rajendra Medical College Hospital and now the Rajendra Institute of Medical Sciences since its inception in 1963 as a founder teacher within the Department of Surgery. Later, he became Professor of Surgery in May 1980 and headed the departments from 1985 onwards. After his retirement as Professor and Head of Surgery at the Rajendra Institute of Medical Sciences in 1991, he was appointed as a specialist member of the governing body for 3 years by the Health Department of the Jharkhand government. He also worked as a general surgeon and plastic surgeon at the Agarwal Nursing Home in Ranchi. He was a very popular teacher and teacher of so many teachers par excellence, and a legendary personality, having a very soft and polite behavior towards his colleagues and students. He was one of the founders of the Association of Surgeons of India Jharkhand chapter and was respected as a guardian of the chapter till the end. He actively participated in state, national, and international conferences regularly, and it is a great loss to the Jharkhand chapter as he's departed for his heavenly abode at the age of 87 years. May he rest in peace. Thank you. I'm very honored to be invited to give this oration in his memory. And I'll just share the screen. I hope you can see it. Can you see the screen? No?
Yes, we can, Rachel.
Great.
Yes, we can see the screen.
Lovely. Great. I was reading about Dr. Das, and I was so impressed by his abilities as what we would consider as a true general surgeon. His clinical practice encompassed not just abdominal surgery, but the range of general surgery, including plastic surgery. And Through that, he was able to teach and mentor and train a whole generation of surgeons, many of whom have gone on to very successful careers of their own. I think that is something that I, and indeed all of us, would like to emulate. And I'm very honored to be invited to give this talk in his memory. The topic for the talk is intracutaneous fistula, which is something of an interest of mine that I've developed over a number of years. And in fact, I think plays into what I've just said about Dr. Das, because intracutaneous fistula occurs in many general surgical situations. I have no conflicts of interest to declare, but I do apologize for the confusion over the timing yesterday. I'd like to take you on the journey of the lessons I have learned over the last 25, 30 years since I was a medical student at the Charing Cross and Westminster Medical School. And it was there that I learned the basics of science, the anatomy and physiology and pathology of the intestinal tract and digestion, secretions, physiology, so that I began to understand what a devastating physiological insult an intracutaneous fistula could be. As I progressed through surgical training, as Dr. Raghu has mentioned, I did my first registrar job in Johannesburg, and it was there that I learned the importance of surgical resuscitation and particularly emergency surgery in terms of how to avoid intracutaneous fistula and other complications. Towards the end of my training, I was a resident surgical officer at St. Mark's Hospital in London, which at the time hosted one of only 2 intestinal failure units in the UK. And it was there that I learned about the importance of getting a really good total parenteral nutrition service in line with the surgical service in order to care for these patients. And in recent years, I've practiced at the University Hospital of Wales, where this has become a major part of my practice. And I've developed my thoughts, learning some hard lessons along the way about how to manage these patients long term. Now, I'm sure that many members of the audience will have their own personal copy of this book on the right of the slide, The Famous Bailey and Love. I often say to the trainees, you can't be a proper surgeon unless you own a copy of this book. And so I went back to my rather battered copy of the book and I looked at what it said there about the etiology of intracutaneous fistula. And as you can see, there's quite a long list on the left of causes of intracutaneous fistula. And in the chapter, it emphasizes some of the common ones at the time, which are things like diverticular disease, Crohn's disease, colon cancer. It also mentions a number of infectious causes. But in my practice in Cardiff, I don't see any of the infectious ones, although I am sure that in India, you do see TB and some of the other ones fairly frequently. Unfortunately, what I do see in Cardiff are predominantly post-operative intracutaneous fistula. And this is borne out by my own practice. I've reviewed our patients who require long-term TPN, most of whom have intracutaneous fistula. And as you can see, 10 years ago, the single biggest cause of requiring TPN, as evidenced in the blue segment, was inflammatory bowel disease, mainly Crohn's. But when I looked at this year's patients who've been put onto long-term TPN, you can see that actually the biggest single cause is the orange segment, which is post-operative complications. And for the fistula patients, this is even more true. The Crohn's patients are actually a very small segment now of intracutaneous fistulae presenting in Cardiff. And the orange segment, the vast majority, are unfortunately post-operative fistulae, comprising over 80% of the fistulae we deal with. And this fits in with the literature where some of the more recent papers have shown quite high proportions of iatrogenic or post-operative fistulae. So this brings me to the second lesson that I've learned over the years, which is that we must try to avoid intracutaneous fistulae. Now, intracutaneous fistulae can occur after either elective or emergency surgery, but it's particularly more common after emergency laparotomy. And it was in Johannesburg that I learned the principles of emergency laparotomy. Really, you're trying to achieve one of three things: to stop hemorrhage, to relieve obstruction, or to drain sepsis, which means removing any necrotic bowel as well as any other ischemic tissue. And the emergency situation is not the time or the place for dealing with incidental abnormalities or correcting every little thing that you find wrong. It's important to just do the things that are necessary. Iatrogenic intestinal fistulae break down, I think, into three groups. There are an unavoidable group where, as the surgeon, you just think this could have happened to anyone. One has undertaken a major operation, such as an anterior resection or a cystectomy, which has to be done, or one is doing operation in a Crohn's patient that has had multiple operations before, or occasionally operating on a desmoid tumor. And complications can happen even to the best of surgeons, and a fistula results. These are unavoidable. We all worry about technical errors, but in my experience, these are quite a small proportion of the fistulae that we see. There are occasionally catastrophic problems from a complete failure to identify the anatomy correctly, but those are very few and far between. What happens more frequently is that at the end of a long and difficult operation, when everybody is getting tired, the small bowel gets caught in the wound closure, thus allowing a fistula to form. And I think it's really important when you are tired as a consultant, not to go off at the end of the operation, leaving the resident to close up the wound with no assistant, but actually to stay and let the resident do the closure with you assisting, so that you can pull on the suture and keep the small bowel and the abdominal wall separated. Unfortunately, though, a large proportion of the intracutaneous fistulae we see are due to errors of decision making. And these vary from some common themes, such as performing an anastomosis under adverse circumstances, or the inappropriate use of a mesh or a vacuum, through to more difficult to define problems where one wonders why the operation has been done in the first place, or where repeated procedures are being done. And looking at these, some are due to simple lack of experience, and others are very bizarre, where you just wonder what the surgeon was thinking at the time. So I have come to conclude there are some principles about what to do and what not to do in order to avoid fistulae and keep out of trouble. I think when performing an anastomosis, one should not do this if the patient has low nutritional bloods, particularly low protein, low albumin, and one should not be doing an anastomosis in a cold and acidotic patient at the end of a long operation. And it's Murphy's law that anything you join together the day before you go on holiday will probably leak as well. So I think that it is better to bail out and give the patient even a high stoma if necessary, because that's a temporary problem that you can come back and deal with later. Nutritional support has improved so much in the last decade that even quite high fistulae or high stomas are relatively easy to manage with TPN, and that can buy time for you to go back and do restorative surgery. Now, as I mentioned, I learned a lot of these principles when I was working in South Africa, and the guy in the red shirt in this photograph is the best surgeon I have ever had the privilege of working for. He was called Mario Suarez. He worked in Johannesburg. He was a very brilliant technical surgeon and a very strict trainer who would hit me with the instruments if I was doing things wrong. But he always said the first time is the easiest time to get things right, which is why one should avoid getting into a cycle of repeated operations. I think it is unlikely that a patient is going to need more than 3 operations. The first operation is done to deal with the presenting complaint, whether that's an elective operation for cancer or an emergency operation for hemorrhage or obstruction or sepsis. It may be necessary to do a second operation if you plan to relook an emergency patient because you've been unable to close the abdomen, or occasionally one has to do an unplanned relook laparotomy for leak or sepsis or whatever. And the third operation may then be necessary to wash out and close. But if you find yourself doing 4, 5, 6 operations over a short length of time, and we do see this with the patients that are referred to our unit, I think that one should stop. Stop operating and stop to think about the situation. Reassess what is going on. You may wish to take a second opinion at this point, and then take charge of the situation. And at this point, one normally has to regain the confidence of the patient and family, because obviously things are not going according to plan. The third lesson I've learned is to avoid mesh directly on bowel because of the risks of adhesion, fistula formation, and perforation. Now, many of us will have spent time with the representatives of various commercial companies who assure us that their particular mesh will not cause any problems with the bowel. But myself and other people who work in intestinal failure units have seen fistulae through all of the meshes on the left, including vacuums and some biological meshes. I personally have not seen a fistula as yet through the meshes on the right. And this leads on to the fourth lesson, which is whether one should do a laparostomy or not. And my thinking on this has evolved over the years. In general, the first time is the easiest time to get things done. So therefore, if the sepsis is cleared and if the abdomen can be closed technically, I would choose not to form a laparostomy on the grounds that your best chance of getting the abdomen closed without future complications is the first time. However, occasionally it is necessary to perform a laparostomy. This needs to be done if one is definitely planning to relook the patient because of the potential for unresolved sepsis or ongoing ischemia. Also, if one is unable to get the bowel back into the abdomen without raising the intra-abdominal pressure such that it would impair respiration, one may have to perform a laparostomy. And I'm sure the surgeons in this audience will each have their own favorite way of performing a laparostomy. There are many different commercial and homemade devices available. I think whatever device you choose to use, certain technical points should always be remembered. The bowel in these cases is extremely friable, which is one of the reasons why the patient is in trouble in the first place, and therefore it needs to be handled with extreme care. Whatever you decide to put on the bowel must not be adhesive. So whether it's a homemade bag taken from the bags which hold liters of saline, or a commercial dressing of some sort, or a soaked gauze roll, you must use something that is not adhesive. And in the case of the latter, it should be removed within 48 hours. If you decide the patient needs to have a chronic laparostomy and that you're not going to attempt to close the abdomen, then I think that a wound manager is very helpful for nursing care, and indeed patients can be taught to change wound managers themselves if necessary. My thoughts on a VAC have evolved over the years, and I now take the same position as the Salford intestinal failure unit, which is if the abdomen has no fistula present, a VAC should not be used. However, if a fistula is present, then there is nothing to be made worse, and a VAC may be the best option for hygienic nursing care. And I think these all play into the lesson that I have learned, which is about attention to detail. These patients are extremely high maintenance and require the input of a lot of vigilance in the perioperative period. Sepsis is what kills these patients and may occur anywhere. They have a number of indwelling lines and catheters, which may be a problem. They've often had long operations and have atelectasis predisposing to chest problems. And of course, the abdomen may be the source of ongoing sepsis. And during this time, they are very catabolic. they need full nutritional support along with the paramedical specialties as listed here. I really learned about the importance of nutritional support when working at St Mark's Hospital in London. The nutrition support team, which is present in many hospitals now, provide nursing care which looks after lines with huge attention to detail in order to prevent line sepsis, which can prove fatal. These patients also need to undergo regular and frequent blood monitoring, and one needs to be looking after patients with a high output intracutaneous fistula in a unit where the pharmacy can prescribe personalized prescriptions, because many off-the-shelf preparations that you buy commercially do not provide the right TPN requirements for these patients. And not every hospital is able to provide a pharmacy which can produce both lipid and non-lipid TPN for the protection of these patients' livers. And this brings me to my most important point, which is that all of this really extols the virtues of a multidisciplinary team. This is the team I'm very fortunate to work with in Cardiff, and as well as gastroenterologists and a surgeon, the bulk of the team is made up by nurses from stomach care and nutrition, pharmacists, dietitians, psychologists, biochemists, and a manager who makes sure that we are able to do this. The team approach takes us right back to medical school. And many of you remember the aide memoir on the right of the slide, SNAP. Sepsis is the most important thing here, and the whole of the patient's journey should be aggressively directed to resuscitating the patient and to controlling sepsis. Nutrition, as I've mentioned, is essential. Later on down the line, the anatomy will need to be defined, and this can be done by cross-sectional or contrast-mediated radiology. It is important to have a radiologist who is interested in this sort of work, because these patients often need many different investigations. I would say, however, that in recent years, the quality of CT scanning is now so good that fistulograms are much less rarely performed than they were a decade ago. And as a surgeon, we always think that surgery is the most important thing, but actually the procedure that is going to put these patients right comes quite a long way down the line, because they need all the other things put in place first. And this has been a lesson which I've had to learn about preparation for restorative surgery. When the patients are referred to the intestinal failure unit for me to treat, they're often told, oh, go down to Cardiff and you'll have an operation and everything will be fine. And one has to really think about why you are going to do restorative surgery. It is now perfectly possible to live very well, even on long-term TPN. And if you have a low output intracutaneous fistula, it may not be that much of a bother. So one needs to think, why are we doing restorative surgery? And the reason why is either to reduce or at least remove the requirement for any TPN, and to deal with the high output of the fistula in question. You do this by bringing more bowel into continuity, and the patient has to want to have this done. It is surprising that some patients do choose to live with their fistula, with or without TPN, because they cannot face or are not fit for another operation. And in those cases, their wishes must be respected. If you decide that you are going to operate on a high output intracutaneous fistula, which has occurred usually, as I say, post-operatively, one has to decide when is the best time to do it. Now, because so many of these patients have had quite a traumatic course with their previous surgery, they are often very unfit at the time that the intracutaneous fistula develops. And therefore, one must spend time to get them to their optimum fitness. We use CPET testing, cardiopulmonary exercise testing, to see whether these patients are likely to be fit for this major surgery. And we aim to have an anaerobic threshold of over 11. If the patient is not fit, I keep them on TPN for another 3 to 6 months, doing physiotherapy and exercises and building up their stamina, and then retest them. And of course, their albumin and other nutritional bloods should be back in the normal range. One will have performed the radiology to define the anatomy for the entire length of the remaining bowel. And when examining the abdomen should be soft and the fistulae should be spouting, as in the lower picture here. If the abdomen is still very hard with no give in it when you palpate the abdomen, and the fistulae are retracted, as in the upper picture here, then this abdomen is probably not mature, and the peritoneal cavity is likely to be extremely hostile, and it is better if one can wait until things soften up. And then one is going to now get on with the restorative surgery. One needs to think about how this is going to be done. Planning is essential. As well as knowing the anatomy, there are some practical considerations. These are long and difficult operations, and you need to set enough time aside for this in a theatre where you have an anaesthetist and theatre nurses and staff who are familiar with these kind of major cases. Obviously, you need the backup of an intensive care unit for post-operative care. And one needs to decide in some of the cases who have very complex combinations of problems, are you going to address all of the problems in one operation, or are you going to address them sequentially and make sure that the patient and the family are consented appropriately to understand what can and what cannot be achieved in one operation. At the time of surgery, one, like Lord Moynihan, who was mentioned in the wonderful talk by Dr. Dalby, one needs a generous incision for these patients. And one should assess the entire length of the bowel from the stomach to the rectum if it's still present, and measure and record the lengths of the different sections of the bowel. Any bowel which is non-viable or damaged should be removed. And then one has to decide what to do about anastomoses. If one is doing multiple anastomoses or a low anastomosis in the colon, one should have a low threshold for defunction in these patients for a further 2 to 3 months, performing a gastrograph in contrast study, and then closing the high stoma. Sometimes, however, things do not go according to plan, and one needs to know when to cut the losses and just wait, bail out, and live to fight another day on it. If one encounters severe hemorrhage or a peritoneum which is so hostile that each time one mobilizes the small bowel, one is making more enterotomies, then it is better to cut one's losses, even if you and the patient are going to be very disappointed by that outcome. And obviously, if one finds unsuspected sepsis or a suspicion of malignancy, then this is the time to step back and reconsider the whole case. Now, some of these lessons have been quite difficult to learn, but I want to end on a cheerful lesson, which is despite all the hard work involved in these patients, and despite many setbacks when things don't go according to plan, even patients who have had TPN for a long time can get off their TPN with restorative surgery and live a very active life. Of the patients who we've operated in Cardiff with high output intracutaneous fistula requiring TPN preoperatively, you can see the blue section here, the majority have come off TPN. The gray section are those who've come off most TPN but require some intravenous fluid and electrolyte supplementation. And even the orange section, which are still on TPN, have reduced their requirements. And for a patient to go down from, say, 4 liters of TPN 7 nights a week to 3 liters 3 nights a week is an enormous improvement in their quality of life. Plus, it gives much better long-term outlook for their liver function in terms of protecting that. So these are just some of the intracutaneous fistulae that I've operated on in the last few years in Cardiff. And down the center of the slide are the professions which patients who've had their fistulae operated on have been able to go back to following successful surgery. One can see that some of these patients go back to very worthwhile professions such as nurses or mothers of children, or go back to studying in school or college. And I've even had one patient who was a career thief and criminal who was discharged from the hospital straight to Her Majesty's pleasure. So in summary, intracutaneous fistula is a difficult and serious surgical condition that unfortunately nowadays in the Western practice arises mainly as the result of previous surgery. However, with the benefits of a well-functioning multidisciplinary team and attention to detail to address sepsis aggressively, to provide expert nutritional support, and to define the anatomy, one can then come to the point where the surgeon can do a procedure which will improve these patients' quality of life by removing the high output fistula and reducing their requirements for total parenteral nutrition. I would like to thank the patients with intracutaneous fistula who come to the Cardiff unit for their forbearance and fortitude in the face of really very difficult conditions, and to the wonderful nutrition team with whom I work. And thank you to the Jasicon conference organizers for inviting me to speak, and thank you for your attention. Best wishes for the rest of your conference. Thank you.
It was a wonderful deliberation, and as mentioned during her talk, lesson 5, that is attention to detail, was palpable throughout the talk. Ms. Hargest is the editor of the reputed Recent Advances in Surgery, besides the various other attributes Dr. Raghu mentioned. And her eye for detail is what makes this book so popular among the students. Ms. Hargest, thank you very much for joining us. We look forward to having you more often, especially now that we have virtual conference, but also to Jharkhand in person. Thank you very much. And thank you, Dr. Raghu, for co-chairing this session with me. It was a pleasure having the two of you together. Thank you.
Thank you very much. I'm very honored. Thank you.
We in fact look forward to Rachel joining us virtually.
We'll have the final word. But Rachel, thank you very much. We were all right. We thought there will be some confusion, but we are so honored and graced by your presence. Back to Raghu.
Thank you very much.
So I must thank Sunil for connecting me with Rachel. And Rachel, you only visited India once. I think you must, India is such a huge country. You must visit India a number of times. Certainly next year, we hopefully will have our on-site conference in Visakhapatnam, which is not too far from Hyderabad, where I live. This is going to be the first time that ASI will be hosting its conference on the ocean front. And so we will definitely have you next year. But this year, certainly we look forward to your participation in our virtual Jasicon.
Thank you very much. I'd be very honored. Thank you.
Hello.
Yes, Sumit.
Thank you, madam. Now I would like to ask the chairpersons to present the memento, which would be handed over in later on in the original form.
Dr. Sunil would carry it when he goes next for his council meeting.
I've not been able to attend the Edinburgh Council meeting for the last 6 months, but I'm there for the next 1 year. So I will carry it personally to Rachel. Possibly next year.
Wonderful. Thank you.
I would present the certificate of participation on behalf of organizing team to Ms. Rachel Hargest for her participation. Thank you, Raghu sir. Thank you, Anma madam. Madam, should we move to the next program?
Yeah, thank you very much, everyone. And as we are running a little late, so we are not breaking up for lunch. We will directly go on to our next session. So Megha, are you there? And we welcome Dr. Deepraj Bhandarkar, Dr. Sandeep Agarwal, and Dr. Anil Sharma who have joined in. And Sumegha, please take over.
Yes. Yes, so good afternoon, everyone. Now we move on to our next session, that is Introduction to Medical Writing. I welcome all the three eminent persons, Dr. Sandeep Agarwal, Dr. Deepraj Bhandarkar, and Dr. Anil Sharma for this session. It's a symposium. And our moderator is Dr. Deepraj Bhandarkar. His consultant, Minimal Access Surgery, Hinduja Hospital, Breach Candy Hospital. He has more than 90 and more than 500 presentations, more than 90 publications. Now, over, and we have Dr. Sandeep Agarwal from AIMS. He'll present how to write a paper. And we have Dr. Anil Sharma from Max Super Specialty Hospital. So over to you, Dr. Deepraj.
Thank you very much. And it's indeed a pleasure and an honor to be amongst you all today. Thank you, Dr. Sunil Kumar. Thank you, Dr. Arunima Verma for this invitation for moderating. It's something that I think needs to be taken more seriously amongst our postgraduates. There are many reasons why one hopes to write. Advancement of science is one of them. Career advancement is another. But perhaps the most important idea of learning to write well is to be able to communicate your ideas, the new ideas that you may have with your colleagues. And in today's day and age, with the advent of internet, the ideas that you have, the ones that you are able to put down in the form of a paper can reach. I would invite Dr. Sandeep Agarwal for the first talk of how to develop and research idea into a study. And the second part would be by Dr. Anil Sharma, who would be talking about writing a medical paper. So over to you, Dr. Sandeep.
Yeah, a very good afternoon. At the outset, I'd like to thank Dr. Deepraj Bhandarkar and Dr. Arunima Verma and the organizing committee of Jasicon for giving me this opportunity to talk about a topic which is very close to my heart and which I enjoy sort of talking about. And so can you see my screen? Can somebody confirm that? And hello?
Yes, we can see your screen. Please go ahead.
Okay.
Please
right.
just maximize it.
Right. So, okay, I'll maximize it. Yeah, okay. 1 second, and then that'll be okay. So, I'll be talking about developing a research idea into an article, and I'll be talking about from my own practical experience and the way I sort of teach most of my resident colleagues who, every time we get new fellows and new residents, and some of them are very interested in writing. So this is how I sort of advise them. So from my own practical experience, I have developed this talk. So you may find it a bit unorganized, but I'm sure you'll get what goes into writing an article. So as I said, I always tell is research, writing in a manuscript for a good journal. It's not rocket science. It is anybody who has a passion, who wants to write, can write an article. But then it's not child's play either. You just can't write an article in a day or two, or say, okay, I want to write an article, and I would just have 1 or 2 days to write about it. It's a lot of hard work, I must tell you, at the outset. You must have enough time, enough passion. Maybe you have to sit at night after a dinner onto your laptop till whatever time it takes you to finish a particular part of the article. But it's a lot of article, and a good original manuscript, I'm not talking about a case report, can take up to 6 months from the time of conception to submission or even the first sort of result. So it requires a certain amount of commitment to write an article. It requires persistence and self-belief. For example, I'll just tell you my own experience. When I was a resident, my first article got rejected by three journals before finally being accepted in pediatric nephrology, which was a higher impact journal than the first 3. It requires a lot of honesty about what you report, because when you're honest about what you're reporting, you can discuss it, and you can discuss the complications, and that makes it more transparent and more, the readers can make out, yes, there is an honesty. Because if you try to fuzz data, the experienced students can make out where you have fuzz. You may put something in the table, another thing in the introduction, and that may easily get caught. And a reasonable command over the English language. You may not be the master of sort of language, but a reasonable first draft you can prepare, then somebody else can modify it for you. And I always say it's like writing a story. You have an idea, and you have to create a story out of that idea. and you should be very clear what you want to convey to the readers. And so when you want to do this, what does it involve? First of all, a clear conceptualization of the research idea. This is what I want to talk about. This is the primary outcome I want to talk about. These are the other objectives. And for that, I think that's why I've highlighted this point in a lot of in bold and red, is that you have to read the relevant literature, because without reading, you don't know what is the gap, what do you want to convey, and it gives you a lot of things for lateral thinking. You have a very good study, but how do you discuss it? So if you read about the literature, you get a lot of points about your own study, especially for the discussion part. I'll go into the details of each of these points. Ethical clearance, then the data collection, choosing an appropriate journal right at the start, organizing into various sections and refine that. I think Dr. Anil will cover about writing an article, but I'll touch upon all these ideas briefly so that you get an insight into how you create an article. So what you want to say in your article, what do you want to say is exactly, you may have a big study, but you can't really say 20 things and as your main objective. So what is the research question? And I'll give you an example in the subsequent slides, or the concept we want to answer or talk about. As I said, the primary objective or the outcome should be very clear. It should be something new, something novel, and something original. Because there are a lot of articles and manuscripts written all over the world, especially in this COVID times. Everybody is busy writing. And in general, because of the availability of resources, literature, there are a whole lot of manuscripts. There's a drastic increase in the number of manuscripts being produced. So in order for your own manuscript to be published, you should have something new to say, which is not repetitive, which is not stale, which will somehow give even a small step towards advancement in that particular field. And so whatever you must say must have significant scientific value to be published in a good journal. And it must add to the existing knowledge. I'll give an example from our recently published study, and I'll give you an example of my own studies because I know the depth of those studies. So that's why I'm giving example of my own studies. Now, this study was about data from the one anastomosis gastric bypass in our patient population, and obviously we had the weight loss outcomes, we had the complications, we had other things. But in the study protocol, we had put endoscopy at 1 year, and we found that there was a significant rate of marginal ulceration in asymptomatic patients. So had we just titled it outcomes after one anastomosis bypass, maybe the editor wouldn't have a look at it, or maybe he would just outright reject it, saying it's very common to publish outcomes. But we did say something novel, which we found in our study, was that we had a high rate of marginal ulcer. Then we sort of laid stress on that outcome and said, okay, and that caught the attention of the editor. So your primary objective, one objective, yes, endoscopy detected high rate of marginal ulcer, was then the a clear-cut objective of our article. So as I said, you should have a single primary objective in your manuscript, and your study should be powered based on a primary outcome. Secondary outcomes have less important, and the studies are not powered according to that. Okay, for example, if you are comparing stenting in the transplant of the uretrovesical anastomosis, your primary outcome should be leak, not UTIs, because obviously leak is the most important thing we want to look at when we stent a ureteric anastomosis. So you shouldn't have that in bed. Now when you're writing an article, does your results, when you write it, answer the research question you raised? You thought something. Now are your results answering the research question, yes or no? And when you describe your research, can your results support a conclusion with a greater global impact? For example, again, this study, we have a huge cohort of patients. We do a routine liver biopsy in our bariatric surgical patients, and we have roughly a 5% rate of incidental cirrhosis in our patients. And there's a lot of papers in cirrhosis. But when we looked at data, we found a lot of patients with advanced fibrosis. That means grade 3 fibrosis. And there was no paper, in fact, on this cohort of patient which is the most important thing, the advanced liver fibrosis, both cirrhosis and grade 3 fibrosis. And there are a lot of other papers on mild NAFLD and other NAFLD, but this paper again, clearly said something which is extremely important, that bariatric surgery So when we said this study aims to evaluate the safety and outcomes of bariatric surgery in severely obese patients with advanced liver disease. So we had a very clear-cut aim. And then when we said our results supported this conclusion, we were able to show clearly that it can be safely performed in well-optimized patient with advanced fibrosis. So this was a clear-cut result, which was an advancement, because generally these cirrhosis is considered a contraindication. And although there are papers on cirrhosis, there was none on fibrosis plus cirrhosis. So again, you have to look at your data and see that you have to say something different. Of course, you don't have to really make up 10 papers out of one, but then if there's something very, very significant, to try to focus on that. Again, another example where we analyzed just without any aim. We analyzed our data. We had about 200 cases that time of gastric bypass. But then we found what is there to write. There are papers with thousands of cases reporting on outcomes of RYGB. It will not get accepted in any of the journals of which we want to publish. And therefore, when we did not start with a clear aim, we lost out. We could not write any paper out of this. So that's what I mean by saying that have a clear-cut objective when you start analyzing your data as to what is the primary objective you're looking at. So we made the mistake of not defining the purpose of research question in this data, and hence this data just sort of is good for us to just analyze it, but we cannot translate it into an article. Again, so how do you formulate a research question? This is an important point. As I said, the first step is a research question. And this is generally the PICO format talked about as a way to define a research question. So we should have a population of interest. What is the population we're interested in studying? The intervention to be studied. What is it surgery? Is it a medical therapy? Is it something else? But clearly define intervention. If there is a comparator arm, what is the intervention comparator arm? Outcomes to be evaluated, again, can be divided into primary outcomes clearly and secondary outcomes. And the time duration at which you are evaluating that outcome. Okay. So look at this. Now we can have a free-form question. That's like, can surgery cure diabetes? That's a free-form question versus a well-defined research question. So can intensive medical therapy plus bariatric surgery reduce HbA1c to less than 6? Okay, that's the outcome. Time duration after 6 months in obese patient, which is the population to be studied with uncontrolled type 2. So that's the population. I is the intervention, which is the intensive medical therapy and the bariatric surgery. C is the comparator arm, which in this case is intensive medical therapy alone. Outcome is the HbA1c less than 6, and the time duration is at 12 months. So if you have this sort of a formatted question, there's no way you can go wrong. Okay, then you put in your data into this sort of a framework. So if you look at this paper, it's a very much talked about paper in bariatric surgery published in NEJM by Dr. Phil Sharp, which compared bariatric surgery with intensive medical therapy in obese patients. So it defines everything. So obese patient with diabetes, the interventions, the comparator arm. So that's the way to go about when you're defining a research question. So I'll come to the case report first now, because a lot of us start with a case report, and that's a good way to start writing actually, because case reports are simpler to write. There's no data analysis, and if you have all the resources and material about the case and you do a good lit search, it's fairly easy to write. But the problem is that it's most difficult to get published in good journals, because most of the good journals do not accept case reports, as there is a plenty of case report going around with all sorts of novelty, and some of them are just sort of routine things. So when you think about writing a case report, think what is the novelty of your case you want to stress. Okay, so you may think your case report is very novel, but it may not be. For example, I'll give you examples again from our own publication, because I know the the depth of this publication. So this is this is a totally new approach for excision of an extraadrenal pheochromocytoma. So this is a novel approach, novel technique. A rare pathology, a hemangioperiscytoma of the renal pelvis, maybe less than 10, 12 cases are reported. A rare complication, again 4 or 5 cases, or maybe none have been reported. A phrenic nerve palsy, a rare complication of indwelling central venous catheter. So you should have, it should be really rare. Okay, it's not like 200 cases been described and it's okay. Unless there is something else to it. Maybe you have added a new technique, or the presentation was novel. So you have to think whether it's really novel. So what you may think is novel may not be as unique once you do a lit search. So for example, everybody comes across a foreign body once in a while in the career. So you want to write, you think is very novel. Let's say copper T, which has been eroded, and displaced found in intraperitoneal. If you do a laparoscopic removal of an intraperitoneal foreign body, it's a very, a lot of case reports keep coming. And if you Google it or do a PubMed search, you will find hundreds of articles, more than 1,000 articles, 400 articles. You just put foreign body in laparoscopic. So it is obviously not rare, and you may think it's rare and you want to report it, but then it won't really get published. So for a case report, anytime you come across an interesting case, do a quick PubMed search. Maybe ask your colleague who's standing, outside, not scrubbed up in the case. Just do a quick search. Okay. Be sure about its novelty. Find a journal which accepts case report. Next step is, there are a few journals which accept case reports, which includes our own Journal of Minimal Access Surgery. But again, for a case report to be published, I think you should have all the imaging, the specimen pictures, the histopathology pictures. Make an effort to take it's a nice high resolution specimen photographs when you take out that specimen. Preserve the CT, maybe take a photograph right then, because ultimately films may get lost. Or histopathology pictures if applicable. There's no point in reporting an hemangioperiscytoma of the renal pelvis if you don't have a histopathology picture. So when you're writing a case report, have everything together in one folder right there, otherwise they get misplaced. First is, so once you have the material, you have the case details, you have the outcome, do a thorough review of literature, because again, if there are rare case report, there will be not more than 10 to 15 or let's say 20 articles on that particular aspect. Go through them verbatim, word by word, from beginning to end. See what are they stressing. Make a table of it, because once you make a table, you're not only reporting your own case, you're telling, okay, this is how other cases have been reported. And you must discuss the novelty of your case in the discussion. I've seen few case reports, let's say presence of a gist in a duplication cyst somewhere, and the discussion just borders on duplication cyst, which is fairly common, but doesn't even touch the topic of the content. So that should be discussed. The novelty of the case report is what it makes it publishable. So this is what somebody said, that a measure of greatness in a scientific idea is the extent to which stimulates thought and opens up new lines of research. That your things should stimulate somebody to read more and develop an inquisitiveness to read more and know about it more. So as I said, literature review is a must do, a thorough literature set. And why? Why? Because it tells you what is already available, that what is already known in the literature. What you may be thinking novel is already well published. I remember we had this place, Copper T, some years back, and we thought it was very novel, but then we reviewed it, it was a whole lot of cases. Then it tells you what is lacking or what is the gap in evidence which you want to fill. And what are the limitations of previous studies, okay? So these are the things which a thorough literature review will tell you, and it will guide you towards your what to do the next step. So a systematic literature search. For example, look at this article now. So what does it tell you? What is known? So once you know that, yes, patients of obesity have increased incidence of reflux, and a sleeve gastrectomy is a good operation for that. And the knowledge gap is that the impact on sleeve on GERD is not well known when you study it as a primary endpoint. A lot of articles have reported weight loss outcomes, and on the side they have reported GERD. But if you have studies looking at GERD as a primary outcome, that at that point in time there were very few studies. And why do we care? Because we know that sleeve is a good operation, but GERD is an important problem, but we do not want to discard sleeve. We need to study it. And how do we want to fill the gap? Is by studying it through these methodologies, a symptom questionnaire, whatever, endoscopy or whatever. So this is just an example of how a literature search helps you. Again, this is a very nice protocol which I came across as a member of the ethics committee. I'm just sharing So this said, this study compared two interventions for a bladder cancer. And when they did the literature, they found a last trial which showed good results, but look at the limitation. The comparator arm was a saline irrigation, not another drug. So obviously there was a big, this is a big limitation of that study, and hence there is a big knowledge gap that the proper comparative arm has not been used. So that's why literature search is important, because it shows you, yes, or when you're designing a study also, you know what is lacking and what is to be done. And I won't talk much about literature review. There are various ways, like searching PubMed, like you can go to the YouTube using medical subject heading terms, or there are other ways. But And you can always get access to these articles. You can write to the corresponding authors if you find a good article and don't have a full text. And there are a lot of ways through ResearchGate and other things. So there are a lot of resources. There's no excuse for not doing a good literature search in the present era. So as I said, there are no shortcuts. It's the most important component of the whole process. So first, what I do is I take out at least 5 important articles related to your idea or proposed research. But don't limit yourself to just review articles. That's one of the commonest mistakes I see. You take out 2 review articles because it gives you everything, but don't take out the big series, which are original research, and they tell you much more than what is there in the review article. Take it from me. Review article depends on who wrote it, how much depth is gone into. But if you take out those original articles, which have done actually that they've done the research, they will tell you what difficulties they faced, what exact methodology they followed, what is the limitations of the study, which review article will not be able to tell you. So please don't limit yourselves to review articles. Take out original articles. Read word by word. Okay. Maybe you read an article a day, next 1 week you say, okay, this is my timeline. I'll read all these 5 articles. Make notes, highlight them. Read the discussion section most carefully. This is the section which gives you what is, the strengths of the study, what are the limitations of the study. You don't want to make the same mistakes. Look at cross references, take out another 5 articles and make a folder right at the beginning. So this is the way I go about. This is my folder of, let's say, article on marginal ulcers. So I take out like 5 articles and 5 more, and then I read each article, highlight the points I would want to stress on when I write a manuscript draft or when I write my own article. But obviously, you do not copy anything. You just read it, close these, and then start writing it. Because that is, if you start copying it, that's obviously is not the done thing. Apply for ethical clearance early. Any study, retrospective or prospective, can start only after an ethical clearance. In fact, if you look at ethical clearance forms, they ask you to give an undertaking that the study has not started. So ideally, this should be the approach. Then comes to choosing a journal. In fact, when you are writing an article, you should choose the journal before you write, because you have to format your article according to that. That means the word count, the number of figures, the number of tables should be according to the journal. So it's best to look at the journal before you start writing the article. So how do you choose a journal? Now, supposing you're a postgraduate who has just finished a thesis, you want to have a quick publication, and because for a job, for senior residency or a job, you would want a quick processing time. The impact factor may be a bit lower, but you want a quick publication. And so you may choose a journal with a quick processing time. Somebody like at a senior level may want a good impact journal, and they may not mind a long processing time. So you must look at these factors: processing time, type of articles, impact factor, whether it's open access or not, or hybrid, because some of these open access journals are chargeable. Does it involve a blind review or not? Read the About Us section for the scope of journal and instruction to the author very, very carefully. They give you a lot of information how to go about writing the article. Read some of the articles of the journal, which tells you the style of the journal, which accepts the referencing style, overall table styles and all that. And there are certain tools which you may find useful for finding a journal. For example, I'm being a bariatric surgeon. Now, this is a journal which just takes surgical articles. So it takes factor surgically induced weight loss. So SWOT, which is a top journal for obesity articles, obesity surgical articles, really emphasizes on surgically induced weight loss articles. And in contrast, clinical obesity takes articles which looks at drug treatment, looks at psychological approaches, other things. So whole gamut of obesity is covered. So if you send an article which is medicine based to a surgical journal, obviously it'll get rejected. This is our own journal on minimal access surgery. So if you look at open it, so we have so many types of articles: leading articles, reviews, original articles, case reports, how I did differently technique, troubleshooting, and so many others. So you get a good idea of where to put your article. You maybe just put it as a letter to the editor, or if it's very interesting, you can put it as a case report. So you must look at the journal you are sending to in detail. Again, this is again example of obesity, which clearly shows the impact factor, the number of days for first decision. So it has both the advantages of a high impact factor and a very rapid processing time, and that's why a whole lot of bariatric surgeons send their articles to this journal. But I must tell you that beware of predatory journals. These are exploitative, open access academic publishing business models which invite you to write. You will be getting a lot of mails every day. Please submit. You are a great researcher. Please submit your article. And then they'll charge you, and they publish it without any peer review, or they may not publish it at all. And they charge exorbitant publication fee. They do not provide any editorial or publishing services. And they use false impact factors. And I can tell you, if you are looking for an academic job, this is publication in a predatory journal is considered a big minus in your CV. So don't get lured by these journals that just in order to have a publication. Spend time and send it to a good journal. Decide on the authorship when you are doing manuscript writing. I'm sure Anil will talk about it, and I will just skip it because I'm sure he will talk about it. In general, the change in authorship order is not considered a good thing after the manuscript is accepted. And so be sure what is the authorship. And there are various criteria for defining the authorship for that, for writing an article. This is what I think the next talk will be about, but I'll just give you an overview of how to write an article. And this is divided by MRAT format. But to me, format is one thing to organize, but ultimately, when you read an article or write an article, is creating a story. There should be a fluidity, there should be a continuity, there should be a flow from one idea to the next, from a logical flow. You can't be discussing leak first, then the bleeding first, and then come back to leak again. It demands clarity and precision. It demands repeated, reading of your own what you've written. At each reading, we try to reduce the number of words, because sometimes when you write free, and we actually add a lot of colloquial words as if we are speaking to some colleague. Be concise, avoid long sentences, because when you read long sentences, you get confused. You don't know what it means. Any impressions and guesswork should be avoided. It's a scientific article. We're talking about evidence-based science. And any important statement that is not the direct result of the study should have a reference. Okay, so if you say something which is different from your studies, should have a reference from the literature. Follow the instructions of the author strictly, but at the end of the most underlying thing is to be honest with what you are writing. Your results will matter to the world. If it gets published, some of the treatments may be based on your paper, your evidence, and people quote that. So remember, science is what you write, and the honesty is absolutely strictly to be followed. Don't be scared of writing about a complication or mortality. That's the natural thing. If you don't have a mortality in 2000 cases of something very Whipples, people may think of it to be a fraudulent publication. So I think I've conveyed most of the ideas. Happy writing, and thank you very much. I'm open to questions. Thank you.
Thank you, Sandeep. I think we'll take the questions a little later after the second talk, if that's okay with you.
Yeah, sure.
Yeah. So that was a fairly exhaustive lecture, and you covered most of the ideas for such a difficult topic in a short time that was assigned to you. May I now invite Dr. Anil Sharma for his talk on how to write a medical paper. And he'll be taking us through the various steps which are required. He'll be giving us some background into the format of a paper. And over to you, Dr. Anil.
Yeah, thank you, Deepraj. I'm just trying to get things organized here. I have suddenly lost what I was seeing so far. So,
are you are sharing the screen? Because we can't see anything here at the moment.
Yeah, just trying to get to that share screen.
Sure.
In the meantime, Anil is trying to do welcome Deepraj Bhandadkar, Anil, and Sandeep Agrawal. Greetings from Jharkhand, ASI.
Thank you. Thank you, Sunil. So Anil, as you are trying to get
Thank you, Sunil.
your presentations, maybe I'll just ask a couple of questions to Sandeep so that we can save some time
can I
towards
ask
the end.
Anand to help Dr. Anil out if there is an issue with him? Anand, can you please help him out?
Yes, madam. Yes, madam.
Yeah. Okay.
Anil
Yes,
sir, can you just try to share the screen?
Yeah, I was trying to do that, but I've suddenly lost that screen for some reason.
Down there is a green color button.
No,
Is
it's
there
not
at the
coming
bottom?
now, unfortunately. So let me leave and I'll come back.
You want to
Yeah, yeah.
log out and log back in?
Yeah, I'll do that.
Okay. So Sandeep, can I ask you a question in the meantime while we're waiting for Anil to start his presentation? This is a question I've been asked often, and I cannot say that I have a accurate answer for this. So we always say that when you're working on a research protocol or any study, the permission from the institutional review board or the ethics committee is a must, and that no journal worth its salt would accept a paper which has not gone through that step. The question is, how does somebody who is outside, say, an academic institution or even a large hospital, for him, what is the way of getting an ethical committee approval? Because in our institutions, our hospital, we have an ethics committee in place. But say somebody from a smaller town, he has a research idea, or he has a series of cases that he would like to put in the form of paper. How does he go about seeking permission from the ethics committee?
So again, I must admit that I don't have any practical, knowledge of that thing. But I presume there are state government ethics committee, state government, the Department of Health or the Department of Health Research of that particular state, which anyway, so they must be having their ethics committee, or there are some societies which they have their ethics committee. Obviously, maybe a member. Through those, they can get those approvals. And so, though considered mandatory, some of the retrospective studies, if you write that patient anonymity has been maintained and certain data privacy issues have been followed, some of the journals would accept a retrospective article or a case report where a proper ethical clearance has not been obtained. But in general, as a principle, ethical clearance is required, and I'm sure there are forums where one can obtain it, because people do publish. It's not that only academic people are publishing. So I'm sure there are forums, and I think it's through the governmental, health departments.
Okay. The second part is, could you also throw some light on getting a trial that you want to conduct, particularly a prospective study or a randomized trial, registered with some of the authorities, with which, again, you have to make an application either online with an international repository or in your country? That how does one go about registering a trial when you're conducting it?
Yeah, I think that's a very good question. So for any randomized study, in fact, where there's an intervention involved, one must register with CTRI, the Central Trial Registry. That's online available. You can create your login. In fact, for an ethics committee approval, you need to have shown a proof that you have submitted it for the CTRI. They won't approve it unless you have shown an evidence that has been submitted. So once you get a submitted show of proof to the ethics committee approves it. You have to send the ethical committee approval to CTRI, and then it gets registered. And then only actually you can start recruiting your data. So for randomized trials or probably any interventional trials involving a major intervention, a CTRI registration is required. And similarly for other things, there are various other things like you have to register in various other, if you are doing a meta-analysis, there are different areas you have to register.
Anil, are you getting through? Is your presentation up and running?
Yeah. Well, hopefully. So I'm trying to share my screen now. And okay, there we go. So
yes, we have you on. We can see your screen now.
Okay. Okay, so can I be seen and heard?
Yes, very well. Thank you.
Right. Thank you, Deepraj. And sorry, everybody, my system seems to, play up. The more that I get scared of it, the more it plays games with me. So I'm sorry for that little loss of time. I would first of all like to thank our friends, Dr. Arunima, Dr. Sunil Kumar, our so many other friends at the Jharkhand chapter of the ASI. Thank you for the opportunity to be presenting the JMAS Basic Medical Writing course to you. So, okay. So we now live in times that tell us, like we know, publish or perish, or some people would say publish and flourish. And now with social media coming into the picture, there are some people that, that believe that if you don't yell, you won't sell. But the role of a surgeon has changed with time now, with the decades. So from a doer, the role of a surgeon has now been transformed into that of a thinker, of a teacher. And but that is where, in fact, writing and publishing plays a great part. And we all know, to further our academic prospects, our professional careers, the role of writing and publishing is so important now. So when you talk about scientific medical writing, it is these things that are possible. Starting from the most simple on top to the most difficult below, starting from the easy to the relatively more difficult, and starting from low levels of evidence to progressively higher levels of evidence as you go down. This is what is possible. So a letter to the editor, a case report, surgical technique, which is also how I do it, a case series, a case control study, a cohort study, randomized control trial, and then reviews in the form of narrative reviews, systematic and Cochrane reviews, meta-analysis, and finally editorials. This is the complete list. And the case series, the case control study, and the cohort study, these of course are known as non-randomized observational studies. And this is what forms the bulk of what is published today in most medical and surgical journals. So the case series, the case control study, the cohort study, and the randomized control trials, these are known as original articles. And this is what, in fact, lends credence to a journal. This is what contributes quality to a journal. Then we have review articles, like we had mentioned, which would constitute normally between 20 and 30% of the contents of a surgical journal. So what do you do first of all? Like I think Sandeep was speaking some time ago, when you have first decided you want to do a study, you will first of all fill up what is known as a study protocol or what is known as a research protocol. Now, this should be standard now in, most teaching hospitals in the country. This is a standard format that should be readily available in all teaching hospitals. So you fill up that standard protocol that has to be submitted to your local institutional review board, obtain a written consent from them for the study, and then register your clinical trial somewhere. Out here in India, you can register your trial at www.ctri.in. So we talked about this standard protocol, this protocol template that should be now a standard in all teaching hospitals in the country. So what does it contain? these are the things that need to be filled up in a standard protocol template. The study objectives. Why are you doing the study? What sort of a study design is it? You know, retrospective, prospective, retro pro. How will you select participants for the study? What sort of an intervention will you do on these participants? What will you monitor? What will you study? What will you sort of record? Your safety assessments for the participants. These should be shown to be in place before you start the study. And then, of course, statistics and participant rights and committees. These are all standard format in a standard study protocol. So you don't write because you want to say something, you write because you have something to say. And then once you have something to say, the shorter, the better. Now, please remember that that most publication space comes at a premium. But then more importantly, the attention span right now, you know, of the readers that there are is very, very limited, particularly with social media coming in as well. So that is why the shorter, the better. And this is a slide that shows you these standard Oxford 2011 levels of evidence. So you can see the highest level of evidence that there is comes from meta-analysis, systematic reviews, and good randomized controlled trials. The level 2 comes from cohort studies or low quality RCTs. The level 3 from case controlled studies, 4 from case series, and 5 is the expert opinion. So when you're starting off, you know, and most people have to start off at some stage in their careers, what to do first of all. Now, these are the most practical and they were relatively easier things to do when you start off. So the good old case report, the case series, and the surgical technique session, or some journals call it How I Do It. These 3 publications would I believe constitute the relatively easier publications, you know, for a scientific surgical or medical journal. But then if you can't explain it simply, which means in simple words, which means in an uncomplicated fashion, you do not understand it well enough yourself. So like Sandeep had mentioned, this is the standard structure that we know stays in place for most scientific publications today, the IMRAD structure. And this is the introduction, methods, results, and discussion. This is what in fact constitutes the IMRAD structure. And for an original scientific article, this is what holds good most of the time. So you have 2 paragraphs of the introduction, you have 5 paragraphs of the method section, you have 7 paragraphs in results, and 6 paragraphs by and large in discussion. So you see, you have 20 units of thought to prepare. Now, please note this term, 20 units of thought, which means that you in fact need to take 1 unit separately at a time. That is how you can cover the entire article by going one unit of thought at a time. Okay, and that is what we will try and do in the next few slides. So the first two paragraphs, the first two paragraphs form the first two units, which is the introduction, which asks you, why did we start? So the first paragraph, like Dr. Sandeep said some time ago, you should know what the current knowledge on the subject is, which means you should have gone through the relevant surgical literature to see where things stand at the moment. So the first paragraph talks about what is the current knowledge. Now, you can in fact draw from the first paragraph, pick up one small lacuna, pick up something that is perhaps not very clearly described, perhaps something that is not that well known, and then come to why you had done your particular study. So the second paragraph derives from a small lacuna in the first paragraph, and then you try and make that the purpose of your study. So the next 5 units of thought, okay, the method section, what did we do? So like Dr. Sandeep again said, this has to be like a story. So you have to in fact write a story of what you did. And that story should come in a logical framework of time. So you first completed a study protocol, you sought a clearance from the local institutional ethics committee, you then selected participants, you then performed the surgical intervention, you then made certain observations at certain periods of time. There was a statistical framework that was used. So this is the logical framework of time that we talk about. And of course, you should be very clear about the primary endpoint of your study and the secondary endpoints. Now, the primary endpoint of the study normally should be only one. Okay, which means there is one big thing that you are looking at in your study. The secondary endpoints can be several, 3, 4, maybe even more, but by and large, primary endpoint is only one. Okay, and these are those five paragraphs, the 5 units of thought for the method section, okay? And when you, in fact, put them down like this, you know you can take one unit at a time. So one unit, one paragraph talks about study design. Then you will talk about patient selection, what patients were included, what were excluded, and why. You then talk about your surgical intervention, what was done. Okay, sufficient details so that your readers know what sort of a surgical intervention was performed in these patients. The 4th unit of thought in the method section is the outcome assessment. So what did you study? What did you record? What were your time intervals when you made certain measurements? And finally, what statistical methods were used in this study? So you have 5 paragraphs of the method section. Then moving on to the results section, which is what did we find? Okay. Now, when we talk about results section, please note the last point. Do not interpret your results over here in this section. Just state your results. So the story of the main findings talk about results should be a blend of text and numbers. Okay, a blend of what comes in text form, and then when we talk about numbers, could be in the form of a table, in the form of a chart, in the form of a graph. So there should be an interesting blend of text with numbers, and do not repeat the same information in your numbers and your text. It's a waste of publication space and a waste of an effort. Okay, and be concise, like we always say. So then finally, now 6 paragraphs or 6 units of thought on the discussion segment. Now, the first paragraph normally talks about what you did and what you found. So it is like a few lines of précis writing for the entire article. Okay. Now, you don't talk about strengths that soon. I think this slide needs to be altered, and I've been telling myself that, but failed to do it. You talk about your strengths much lower down, if at all. Be in fact liberal when you talk about limitations of your study, because when you talk about limitations of your study yourself, then the editor, the reviewers would then sit back and breathe a sigh of relief, because they know that you have done part of their job by yourself. So it does put things into perspective. It does put you, in the right frame as an author when you mention limitations that are there in your study upfront. Then you talk about similar publications that are there, in surgical literature already. So you can talk about how your study fits in with the other studies. And then please remember, in this segment, when we talk about discussion, we don't just state what we found. We need to, in fact, discuss why we found what we found. Okay, so you in fact need to be talking about reasons why you got, a certain result in a given scenario. And then finally, you are now reporting it, but then what are the implications of your study? What do you suggest that needs to be done? Should there be a slight change in terms of the way that we treat patients? Should there be a slight change in clinical protocols? Should we be a little more aware about certain scenarios? So what is it that you want to, finally put through now that you have found something in your study? So finally, a few lines about conclusion. And the most important thing about conclusion is that you must conclude what you found in your study. Okay, do not make conclusion of things that you have not studied at all when you are reporting your article. And then finally, just go back to the second paragraph of your introduction, where you have talked about the aims of your study, okay? And then make sure that both things, your conclusions and your aims sort of correlate. The Vancouver system of referencing is standard now, and this can be obtained very easily online. Now, the role of a biostatistician, this is something that I have some strong feelings about. What we in fact normally do is we go through our study, we in fact complete our study, we make our tables, and then we say we will refer this to a statistician and see what we find. Now, that is not the way that things need to be done. You in fact need to involve the biostatistician right at the start of the study, because these are the things that they can help you with protocol development, with management of your data, which the way that you in fact go about your study and collecting material for your study. They can in fact keep monitoring that to make sure that that things are proceeding in the right manner. And of course, data analysis, and finally the manuscript writing also. Part of it is falls within purview of a biostatistician. But then if you ask me in one single sentence, what is the role of a biostatistician? I will tell you the role of a biostatistician is to sex things up, to make your study look more presentable, to make your study look more glamorous, so to speak. So how do you get started? Find a clear message for your article. Okay, like we said, only one primary endpoint per article. So you should have only one message per article. And that message can be expressed, okay, as a simple sentence of 10 to 14 words, which you can write up and then pin up, somewhere on a board where you actually sit and write, where you can keep looking at it when you are writing the article. So Dr. Sandeep spoke about this. The good research question and the format for a research question is the PICO format. And the PICO, as you know, is patients, intervention, comparison, and finally outcomes. So what this is, one good example of a good message, of a good research question, of a good question that confirms to the PICO format. Okay, gallbladder removal from the umbilical port leads to a greater incidence of port site hernia. So here the patients are those patients who undergo cholecystectomy. The intervention is the gallbladder removal from the umbilical port. Oops. The comparison here is when you in fact remove gallbladder from the epigastric port versus from the umbilical port. And finally, the outcomes, which is port site hernia. So you can see that this is one good example of a good research question. Okay, similarly, one more good example of a good research question: transabdominal sutures to fix meshes in an laparoscopic incisional hernia repair leads to more postoperative pain. So be familiar with target journals. Dr. Sandeep spoke about this, so I will not take your time on this. Now, these are more or less standard. Okay, in most standard surgical journals, you will have similar sort of an information in the instructions to authors. Now, these are things that should figure in your article to make it, appear high value and safe. You must mention about the approval from the ethics committee. You can talk about registration of your study as a clinical trial wherever you have done it. And of course, follow appropriate guidelines. Just a few thoughts about data management. You have to be careful about the way that you collect data, which is going to be relevant and useful to you in time to come. When you finally, in fact, look back at your data, you will find that the most often, what in fact researchers do is to have this sort of an information in the form of a Microsoft Excel worksheet where you have one line for one patient, and then you have the entire relevant sort of information for that patient on the same line. There are numerous softwares available locally. The advantage of putting data into these softwares is that you can in fact get these sort of results out in the form of a graph or a table or a figure that makes your study look attractive, like I said in the beginning. Now, we do have reporting guidelines available, which are in fact relatively simple to obtain online. And these are like a how I do it, manual for a researcher who wants to write an article. So for a systematic review, you have the PRISMA guidelines. For randomized controlled trials, you can use the CONSORT guidelines or the CLEAR guidelines. And similarly, for the observational studies, the stroke guidelines are available, and so on and so forth. So the great leap of faith has to be taken. One takes one step at a time to go far. But the main mental blocks, would be in your own mind. But unless you will make your mind up, sit yourself down and decide you are going to travel the path, things will not move. Thank you very much for your attention.
Thank you. Thank you very much, Anil, for that very lucid presentation. And I think that last slide is very important, the great leap of faith. And I would just add one more thing here is sometimes when you sit down to write a paper, it's easy to get bogged down by how much effort is required into writing that paper. And my suggestion to our juniors or to anybody who wants to start writing is not get overwhelmed by the enormity of the task that is the writing of the whole paper, but just break it down into multiple sections and just focus on that one section or even one paragraph of that section at a time. And that's the only way to not get bogged down by the task of writing and completing a paper. There is one question, and Sandeep, are you there? Or I could probably pose it to Anil, Sandeep, either of you can take this. So question from the audience is there a necessity of ethical clearance even if a surgical audit is to be carried out by a surgeon from his cases following an established treatment protocol? And can this not be published as a study? So any thoughts on that, Anil?
Yeah, why don't you take this, Deepraj? We have been speaking for a while. You have been silent, and you are the one with the most experience. So let them have benefit of your experience. Please tell us.
Right. So I mean, my take on this is I would circle around to the basics of whether this would in fact form a good study for publication. If it is an audit of one's own cases based on an established protocol, that means it's a standard treatment. It's something that's already been written about a lot in the surgical literature. So for strictly an audit, personal audit, ethical clearance may not be required. If this is a retrospective study, as Dr. Agarwal said initially, you may not require ethical clearance. But the question is, will this then get published as a study? Will this get accepted as a paper in any of the journals? If it's just something that you have an experience with, but there is nothing new to add or nothing new to share, this may not in fact form a compelling paper for any journal to accept. That would be my take on this.
Can I just add to this? I'll just qualify by a statement saying that ethical clearance in most of the peer-reviewed index journals is required for retrospective studies. I mean, what I'm trying to say is some of them do, I mean, if you don't mention it, they do not insist on it, as long as you have given an undertaking that patient anonymity and data privacy issues have been tackled. I think, but it's still a good idea to obtain an ethical clearance even for your own audit of your own records, because ultimately there are certain privacy issues in the data. So once a committee is approved and you have given an undertaking to a committee, it just makes it more authentic that you have gone by the principles of research ethics, and it does not. It might involve somebody else's data. For example, you may have taken data from endoscopy, something which belongs to somebody else. I'm just saying that. So these are the issues which gives you a sort of a legitimacy once you have an ethical committee clearance about a lot of issues, especially the data privacy issues in a retrospective issue or a audit. But yes, some of the journals do not insist. They do mention in the instruction to the author, but if you do not mention it in the retrospective, they do sort of carry your article forward.
Right. Anil, one more question to you now is, how does a surgeon, say from a rural setting, how does he go about writing something up? How does he make his foray into the world of publications? Any tips from somebody who is in a small place? I'm sure there are people all over the country, even in the smallest of towns, smallest of places, doing some fabulous work. So how do they get their message across? How do they start publishing?
Yeah, so like I said, thank you, Deepraj, for the question. Like I said, when you start writing, it's going one step at a time. You in fact cannot be expected to do a randomized control trial as your first publication. That is not going to be practical at all. So like I had shown in my slide, the three sorts of publications that are relatively easier to do are the case report, the case series, and the surgical technique section. Okay, when you in fact talk about surgical technique section, it is the same as the
how I do it. Yeah.
Now for that also, it is not the entire surgical procedure that needs to be described. If you can just talk about one part of the operation that you do slightly differently and why it is done differently, what is the advantage? Does it make the surgery simpler? Does it make it safer? Does it make it quicker? There has to be some advantage, obviously. So you can just talk about one particular step of surgery that you believe, makes that surgery better in some manner. And that, in fact, that does not involve, too much of background information, too much of writing. It's a relatively straightforward publication. You have to write much less. You have to show more pictures, obviously. You have to talk about surgical technique. So that makes it, I think, relatively simpler to write. And then similarly, the good old case report, but like Dr. Sandeep said, there are fewer journals now that like to accept case reports because they don't see it, as very good value for the journal. But then, the case reports are relatively simple to write. And then taking it one step further, the case series. Now, the case series is one group of patients that has had the same operation, perhaps. So you can talk about one group of patients that has had the same operation. You have followed up these patients for a certain period of time. This is what you find, and this is what you can in fact report. Now in a case series, you can't in fact compare anything with anything, because in a case series,
Anil, are you with us? Is your connection unstable, or have we lost you?
I think so, Deep. You can continue talking, Deep. You
Yeah.
just.
No, so I think Anil has made very, very valid points that I think for somebody who's wanting to start writing, start getting introduced to it, the first thing to target is a case report, or perhaps a small case series, or a technical paper, like, how I do it, or how I do it differently. I think that's the place to start. Dr. Sandeep Agarwal has alluded to this. The most important thing is, if you feel that there is something unusual, even before you actually perform that surgery or you manage the case, it's important to start looking at the literature and figuring out whether something that you are about to do may make an interesting case report at a later date, and then start collecting all the materials in terms of the scans, in terms of the specimen photographs, in terms of the intraoperative photographs, either open or laparoscopic, and have it ready. The one mistake we often see being performed or done is to write up any case report in a rush. I mean, you can't really be writing a case report of any kind within a week or 10 days of the patient's treatment being over. It's fair to have at least a reasonable follow-up of that patient, depending on what you're writing up. And you may start writing it up, but do not submit it to a journal in a hurry. You have to have at least say 6 months to a year follow-up on any condition, that any treatment that you've done, before you can put it forward in the form of a paper. So I think that's all that we have to say. Anything else, or are we now beyond our allotted time?
Sir, we have come to the end of the session, but I would just like to thank you very much for joining this session. And this was a very close session to me, because from Jharkhand State Chapter, we launched the website 2 years back. And since then, we have been trying to have a e-journal portal, which has not become active. And this special session was basically to give everybody an overview so that we can start. And as Dr. Sandeep and Dr. Anil said, that to start with, you should start with a case report. So what we think that we can start with a newsletter and then move ahead to the next level. Thank you very much for giving us this wonderful symposium. Yes, Sumekha, please take over.
Yes, thank you, sir. And here's the e-certificate for you.
Thank you.
And we definitely learned a lot from the symposium, especially the PG students, we young surgeons. We learned a lot from the symposium, how to write a paper, starting from the case report, then case series, then definitely we should go further. Thank you, Dr. Sandeep. Here's the e-certificate for him also, and for Dr. Anil also.
Thank you so
Thank
much.
you.
Before
Now
we let you go off,
we go on to the next.
Sumekha, your screen is not moving. Okay, that's
from you. Final comments from you. How about the conference, and final comments from Deepraj. How the
No, I would just like to thank once again both you, Dr. Sunil, as well as Dr. Arunima, for the pleasure of having us here. And thank you to both the speakers, Dr. Sandeep Agarwal and Anil Sharma, for spending their Sunday afternoon. What Sandeep and Anil both are doing a tremendous job of managing the Journal of Minimal Access Surgery. Both are very passionate about it, and all three of us agree on one principle, that we would keep doing these kind of programs, take up every opportunity to connect with those who start writing, because I think this way that we can, ignite a spark amongst the youngsters to take up the business of medical writing and take this forward. So thank you very much.
Yeah, so my final point from the state of Jharkhand, with Arunima leading and we supporting and all of the team supporting, we'll try and move forward in the medical writing from the Jharkhand ASI. And you all of you have to support us so that we move forward. Thank you.
Thank you.
Thank you.
And now we move on to our next session, and Dr. Satvir will be session in charge. Over to you, Satvir.
A very good evening to all of you. We move on to our next series of guest lectures, in which we will be talking about documentation in surgery by Dr. Sanjay Jain and chronic limb ischemia by Dr. Ganesh Sareen from UK. So to start our first guest lecture, a documentation in surgery by Dr. Sanjay Jain, I would like to invite our esteemed chairpersons, Dr. Vinay Pratap and Dr. Om Prakash. You're welcome, sir. Dr. Vinay Pratap is professor in Department of General Surgery and a graduate and postgraduate from DMCH Lakhisarai. And sir has students. Dr. Om Prakash, sir, is a consultant general and laparoscopic surgeon from Hazaribagh, and sir is the past chairman of Jharkhand ASI chapter in 2019 and organizing secretary of Jasicon 2010 at Hazaribagh. And our speaker, Dr. Sanjay Jain, is professor at Department of Surgery at Gandhi Medical College, Bhopal. Sir is MS, FAIS, FIAC, and FAIGS. Sir is an honorary secretary of ASI, honorary treasurer of APSI, and executive council member of ASI. We welcome Dr. Jain, sir.
Welcome, sir.
Welcome, Sanjay Jain, sir.
Hello.
Thank you for joining this session.
Yeah, am I audible?
Yes, I am audible, Sanjay. Welcome, Sanjay.
Yes,
And
yes.
before we start, let me welcome Dr. Sudhir, who is an eminent vascular surgeon from India, and he joined Tata Main Hospital as a general manager and the boss of Jamshedpur. Welcome, sir, for gracing the occasion and for chairing the next session because he's a vascular surgeon. I hope Dr. Sudhir has logged in. So welcome, sir.
Yeah, I've logged in. This is Air Vice Marshal Dr. Sudhir Rai here. I think you can see me. Although I could not use my computer, I'm using my wife's computer, Vinitha Rai, and it's showing her name over there. I don't know how.
Because we share one thing in common, that we share the wife's name together.
Yes, I know that. So anyway, and it's such a pleasure indeed, Dr. Sunil, and for you, thank you for having invited me to chair the next session. Okay,
thanks, sir.
Back to you.
Hello.
We just ask our chairpersons to say a few words and then Sanjay Jain sir can start.
Please.
Yeah. Chairpersons Vinay Pratap sir and Dr. Malwa sir, please.
Dr. Om Prakash.
Hello.
Yes, sir, we can hear you. Please go ahead.
Hello. Am I audible?
Yes, sir, you are audible.
Yeah.
Welcome, Sanjay.
Documentation in I welcome Dr. Sanjay Jain, and I request Hello.
Hello, can I begin?
Yes, sir, please start.
Thank you. Very good evening to all respected chairpersons.
Yeah,
and
please begin presentation.
Yeah, respected chairpersons and dear fellow colleagues. At the very outset, I would like to thank and congratulate also the Jharkhand ASI for organizing such a beautiful conference. I will be failing in my duty if I do not extend my sincere thanks to Dr. R.P. Srivastava sir, Dr. Sunil Kumar, Dr. Arunima Verma, and the entire organizing team of this Jasicon. Friends, the topic which has been given to me by Dr. Arunima is something very close to her heart, and she is kind enough and gracious enough to give me a chance to speak on this topic, and I hope I will try to do justice with that. Friends, you know, documentation is something which we are doing every day. There's nothing new, nothing out of the box which I am going to present. But if it is something like that, why I am presenting it? When the various audits were made to see that what is the quality of documentation, it has been found that there's a compliance level of varying from 30 to 80%. That means at few points, only 30% people did the justice, and at others, 80% were correct. So that means there is still a big gap. Now, what is the importance of this documentation? We know in present era, it is not only the medical legal aspects, the various litigations, and apart from that, what is very, very important nowadays, that our community, like the Western community, is also moving towards either in some form of insurance, including the poorest of the poor who are being covered now by some form of the government schemes. So until and unless things are documented properly, the bills of the hospitals are not going to be reimbursed. Even in our government setup, lot of things are happening, or rather the backbone is running by Ayushman Bharat Yojana. So if you do not document properly, if you do not document in time, the money doesn't come. So I will try to be very brief. Medical documentation is a very vast topic, and it is practically impossible to cover. So what I will be focusing and trying to be precise and short, what are the most important things from the point of view of a surgeon, or a surgeon has to record as an individual. So to just have an overview, the points which are important documentations are demographics, the consent, the operating notes, and the post-operative instructions. And to tell in one sentence, it's a complete package from the first visit of the patient, from the last follow-up of that patient. Everything, whatever we do, should be documented. The documentation and record keeping is an important aspect of the healthcare practice, and perioperative practice is no exception to this rule. Recording every activity or interventions that a patient receives is very, very important. By definition of the Collins English dictionaries, the documentation is document supplied as a proof of evidence of something, and record has been defined as document or other thing that preserves the information. Record keeping has been stated as a part of our professional duty. We cannot be relying on our memory. See, we may be remembering well our case, what we have operated today, and after a month or so, when patients revisits us, we forget, because we have so many similar cases in our life. So it is good to say something which is not written did not happen. So it should be documented properly. This is something which I have felt personally, because there are few cases which occasionally requires re-exploration. And I will give a very simple example what our young surgeon faces. Suppose you have made a stoma. Now, if you remember, or if you just go in retrospect and see how many stomas you have created in your life, and each and every stoma is not alike. You do not remember what kind of anatomy you were finding at the time of operation, what were the situation, what kind of stoma you have made, how much distal limb is there, were there any lesion. So if you make a small note of it, if you make a small diagram of it, when a patient comes after 3 months or 4 months for a closure, your memories become as fresh as you have just come out of the operation theater. So the clarity of information in records is essential. Care should be taken not only to record appropriate information, but also to ensure that appropriate and meaningful language is used. The admission note and the perioperative note should be recorded. Operating room record usually includes patient's identity, procedure performed, persons involved, the complications, and the operative notes. The post-operative notes can be organized in a SOAP format. And what this SOAP format is? So first thing is, see, again, we are doing the same thing, but we do not record it. So why it is important? So S stands for subjective. What are the patient symptoms? What patient is telling? How patient is feeling? So that is subjective thing you have to record. Then the objective. Once we examine, we find, we make our observations. These are the objective informations. Then we assess, no, this thing has happened. And then we have a plan. Okay, we can do this. So suppose a patient, we have operated, we have find that we have done a laparotomy, the abdomen is soft, the bowel sounds are present, and our assessment is that he is doing fine. And this is probably our plan is to start per oral to that patient. So this is how, when you record, this is known as the SOAP format. The discharge record includes the admitting and definitive diagnosis. So you make a diagnosis when patient is admitted. By the time patient is discharged, sometimes this may get a bit changed. Summary of the patient and course in the hospital is very important to record. Instructions about further management as outpatient, including any medications, the length of admission, and planned follow-up should be done. There are certain errors which we make without fail, I will say, like all the doctors are being said that our writing only we can read, or sometime the chemist can read. So illegible handwriting is one. Delay in completing the patient record. And records have been completed up to 24 hours or more after an event. So that means it should be completed immediately, or if there is some delay, it should be recorded why the delay has happened. It is possible that we have a long list. We cannot make the operation notes in between. So but by the time we finish up our OT, we should try to complete. Completed by someone who has not delivered the care has documented. Now, someone who was not a part of our operating team, he exactly doesn't know. He has never concentrated on the case. So if he is writing operation notes, we can understand what will be the real outcome. The lack of signature. We write everything, forget to sign, and sometimes purposely the people try to avoid putting their signatures. And this is a more common tendency amongst the young surgeons or the resident. They try to just make what we call in our local language, just put a chidiya. So they make a small initial. So you never know who has done this, who has recorded it. Inaccuracies in date and timings. The very common thing, we write the date and month for certain time, that holds good. But when the years passes, 10-12 or 10-8 will not mean anything until unless the complete date is not there. Inaccuracies in patient's identification information, such as wrong date of birth, misspelling of names can be there. Inappropriate language used. Again, the young people, they are very fond of using the abbreviations, and sometimes you will find the abbreviation has formed a sentence. So it is very difficult even for us to understand what they want to say. And there are certain things which are commonly used to denote more than even one one element. Like you see TOF, when a pediatric surgeon writes, it is the tracheoesophageal fistula. When a cardiologist writes, it's the tetralogy of Fallot. So you have to write the complete thing. It is very, very important. Ambiguous abbreviations, opinion mixed with facts. So it should be fact, not the opinion. Opinion you can write separately, and subjective, not the objective observation. What patient is saying may be important to hear to come to the conclusion, but what you interpret is the most important as far as the treatment plan is concerned. The demographics is very, very important. Patient demographics from the core of the data from any is the core of the data for any medical institution. They allow for the identification of the patient and his categorization into categories for the purpose of statistical analysis. A good patient demographic form the key to obtain accurate information which is required for claim submission. Also, patient demographics have been classified into 5 major headings: the patient information, patient's employer information, patient guarantor information, physician information, and the insurance information. The patient information consists of the account number, his name, sex, date of birth, marital status, his address with PIN number. Abroad it may be zip number, but in our country we use PIN number, and the patient's phone number. Nowadays, most of the people, they have got their phone, so you should use their phone number and a copy of the ID proof, preferably the Aadhaar card. The next thing which comes is the consent. Consent is very, very important. Again, a vast topic. I will be just giving an overview. So mainly there are many types of consent. Mainly we can focus, there are 2 types of the consent. One are the implied consent. When a patient comes to you for certain things, he said, doctor, there is a problem in my eye. You will see into his or her eye. So the patient has come to show his or her eye. You can see that the consent is implied in his complaint only. But there are certain problems that patient has come with a bleeding PR. You cannot do his perrectal examination or a proctoscopic examination without explaining him what you are going to do and getting a proper consent, if not written, even verbal, but everything should be explained. So before performing a procedure, it is important to receive consent from the patient. Ask the permission to make an examination, explain what you intend to do before doing it. Ask the patient if he or she has got any questions and answer them. Check the patient has understood what you have said. It is not only what you have said, he or she. The most important part of the informed consent is that patient should understand what you have said. Obtain the permission to proceed and be mindful of comfort and privacy of the patient and others. The informed consent is again to establish a valid consent to treatment. Patient need to be given appropriate and accurate information which should include the condition and the reason why it needs a surgery, the type of surgery proposed and how it might correct the condition, the anticipated prognosis and expected side effect of the proposed surgery, the unexpected hazards of the proposed surgery, any alternative and potentially successful treatment alternatives are available, they should be explained. And the last but not the least, consequences of not doing anything is very, very important. That because patient sometime will ask, if nothing is done, what will happen, doctor? Then you should be ready or prepared to answer that what will happen. Where possible, a quiet venue for discussion should be found. It is not good to discuss things when you are hurrying from your round and you just speaks over the shoulder and patient cannot understand anything. Written material in the patient preferred language should be provided. Supplemental verbal communication together with diagrams where appropriate. So you need to explain what is being done. Patient should be given time and help to come to his own decision. So it is very again important. The person obtaining the consent should ideally be the surgeon who will carry out the treatment, or it should not be a junior member of the staff, because patient will not have same amount of confidence in your resident what he has in you, whether or not the patient has understood what has been stated. Avoid using overly technical language in description and explanation. Provision of translators for patients who do not understand your language. Ask patient if they have got any other further question. Surgeons have a legal as well as moral obligation to obtain consent from treatment based on appropriate disclosure. Informed consent means the patient and patient family understand what is going to take place, including the potential risks, complications of both proceeding and not proceeding, and have given the permission of a course of action. It should be by choice and not by coercion or external pressure. If a person is too ill to give consent, we many times find the situation, the patient is unconscious, and in those cases it is better you need not get any consent. And in cases of a minor or someone who is not capable of giving consent, like he doesn't understand, is incompetent or unconscious, then the parent or guardian may generally give the they can provide the consent. Now coming to the operating notes. This is very important document, and operation notes is essential to ensure continuity of care between the operating team and the colleagues who provide a medical further care. It's a medical legal record in patient's care, and all surgical trainees should know what need to be detailed in an operation notes. Notes must be completed immediately after an operation by a member of the operating team. They can be handwritten or preferably typed in line with the current guidelines from Royal College of Surgeons of England. I think Dr. Sunil Kumar will agree. There are good practice guidelines from the Royal College of Surgeons which details how the operation notes should be written. There has been a move towards template-based operation notes to standardize the layout and post-operative instruction, making them easier to understand. Operation notes should accompany the patient into the recovery room and into the ward, should give enough details and enable continuity of the care by another doctor. It should include patient's name, date of birth, hospital or NHS number, the date and time of the operation, and the names of the operating surgeon, assistant, anesthetic. It should also include the specific operation performed with mention of the site, location, if appropriate, the method of anesthesia. The details of pre-operative preparation should follow, including the position of the patient, any additional procedure like catheterization and any antibiotic or thromboprophylaxis has been given. The remainder of the operation notes can be broken down into the following 5 main parts: the incision and the approach, which should indicate the type of the incision and the ports used, for example, midline, paramedian, posterior, and approach. And particularly helpful should revision surgery be needed. Findings, all operating findings should be documented here, including the pathology encountered specifically if it was an unexpected or there was some anatomical variation. The procedure, it should include a step-by-step account of the operation from incision to closure, starting with any major anatomical structure encountered, then the technique used, tissue excise, prosthesis implanted, assisting device used like image intensifier, gamma probe, tourniquet time, and finally any unexpected complications of the procedure such as significant blood loss or iatrogenic nerve injury. The closure should cover the structures and layers close in order like fascia, fat, skin, and the methods of closure including the material and the technique used. So this is a short list, or this is a list what should be included in the operation note. I will not read because it will be a repetition. We have already included. So this starts from the date and time and ends with the signature. Do not forget the two ends. The middle will be good. Coming to the post-operative instructions, here any specific instruction to ensure good post-operative care should be documented. It's a good practice to include things such as venous thromboprophylaxis, sample they have been sent for pathology or microbiological examination, further antibiotics if required, any instructions to multidisciplinary team members like the physiotherapist or anyone else, the specific and clear follow-up instructions and dressing change, suture removal if relevant section. It is also commonly used to specify conditions for discharge or in a daycare procedure. The post-operative instructions, it is important to ensure that the intraoperative images taken are attached to the note, saved to picture archiving or communication system together with a record of serial number of the prosthesis or which have been implanted. The document should then be signed with the signing doctor also documenting his name, grade, and medical council registration number. The post-operative instructions should include the observation and frequency. Many times I have seen if a patient is, because if you do not give instructions, sometimes these protocols may be so tight that a patient who has been operated for a minor ailment, if the nurse comes every hourly to check pulse and BP in the middle of the night where it is not required, it is going to make the patient uncomfortable rather doing any good. So how frequently you want the observation, you should write. Possible complications and required action, specific treatment and IV fluids, timeline of normal recovery, when you wish your patient to be mobilized, when to resume oral intake, what kind of physiotherapy is needed, when you would prefer to change the dressing, and discharge and follow-up details like instructions for suture, cast, or stent removals. We have, everyone must have seen the patients coming after 6 years or 5 years with concretions over their stents, which they have forget to remove, and we have forget to mention in our discharge ticket, and to tell them. Thank you very much for patience listening. And once again, I thank all the members of this Jasicon team for inviting me. Thank you.
Thank you very much, sir, for this illustrative documentation thing, which we really miss out, especially when you are in Apex Center, you are made to write it. But when you are in a private practice, you really miss that out. And I think that is very, very important.
Very true. It was really a wonderful talk. And the day Dr. Jain said that he wants to speak on this, I thought that that is a very important topic, and I did not discuss any other topic with him. I would want our chairpersons to make their comments, and then we can go ahead. Chairpersons Dr. Malwa and Dr. Vinay Pratap.
Can I?
Yes, sir. Please go ahead.
Sanjay, you have done great justice to the topic, which is very close to my heart. And times without number, we get trapped into the situation just because we don't document. I have only one small narration to make, which I came across. First time when I was visiting Cleveland Clinic Foundation. Is it okay? Is it echoing? Is it okay to talk?
Yes, sir.
Sheetal, can I?
Yes, go on. Someone
When I was visiting Cleveland Clinic Foundation in 1997, and the way I found that the surgeons were completing their task in the OR, and immediately they were going to go to the audio recording of recording everything, what they had done, what they had seen, what they had found. It was mesmerizing. And then you all are aware that the transcription came into being, and for which India was benefited. I mean, Asian countries were benefited because of the time lag we have. But transcription came into being only for documentation. So see, it took everything by revolution, medical writing, documentation. And we still are in the very naive phase of documentation. So rightly, it has been taken up by the secretary of the ASI, and I'm 100% sure that he is the future leader. He will ensure that all the state chapters, they have one or two deliberations on the documentation, and they fall in line for every member to be protected on the front of the documentation. Thank you. Thank you very much.
Thank you, Dr. Srivastava.
Thank you, sir.
So, Arunima, I am chairperson for next session. Am I audible to you?
Yes, sir. You are chairperson for the next session, sir.
Okay.
Sheetal, you are chairperson forever.
Yes, sir. I am there.
Yes, I make you chairperson forever.
Okay. Are you well?
Good. I'm good.
Fine.
I missed your party last night.
Okay. Just come to Ranchi. We'll have the party.
I'm in Ranchi. You didn't invite me.
Okay. You can join our validatory function also at Rukka Dam.
Hey, RP,
Good one. Sunil, देखो तुमको tease हो रहा है.
Okay, sir. Congratulations, Sunil and Arunima. You have done excellent job and your whole team.
Thank you.
Thank you, sir. Thank you very much. And Satvir, please present the certificates. And Sanjay Jain, sir, once again, thank you very much. I just want to mention that Sanjay Jain, sir, is not just a speaker in this conference, but he has been helping me out and motivating from the time I have started organizing conferences for Jharkhand State Chapter. Sir, thank you very much.
Thank you, Dr. Jain, sir. Please accept this e-certificate as a token. And Dr. Vinay Pratap, sir, for chairing this session. Thank you very much. And Dr. Om Prakash, sir, for chairing this session. To move upon next to our last session on chronic limb ischemia by Dr. Ganesh Sarin from UK. I would like to welcome our esteemed chairpersons, Dr. Sudhir Rai and Dr. Sheetal Malwa. Air Vice Marshal Dr. Sudhir Rai is General Manager at Medical Services, Tata Steel Limited. A graduate from Armed Force Medical College, Pune in 1980, and Air Vice Marshal Dr. Sudhir Rai did MS from Bombay University and fellowship in vascular surgery from NIMS Hyderabad with advanced training at Japan, Germany, and UK. He is a professor and postgraduate teacher and an examiner in surgery and vascular surgery for National Board, New Delhi, and other universities. He served the armed forces for 39 years, both in Army as well as in Air Force, in various professional teachings and administrative appointments, including Head of Department Vascular Surgery at Army Hospital Referral and Research, New Delhi, and leadership positions at Director General Armed Forces, Medical Force, New Delhi, and Air Headquarters, New Delhi. He commanded the prestigious 600-bedded Army-based hospital at Srinagar during the peak counter-insurgency and counter-terrorism operational scenario. He served as a principal medical officer of both Eastern Air Command Shillong and Training Command Bangalore in the Indian Air Force. On superannuation from Armed Forces, Air Vice Marshal Dr. Sudhir Rai joined Tata Steel on 2nd March 2020 and took over as General Manager Medical Services, Tata Steel Jamshedpur on 1st September 2020. We welcome you, sir. Our next esteemed chairperson is Dr. Sheetal Malwa, Professor, Department of General Surgery at RIMS. Sir is MS, DA, FICS, FAIGS, and ex-secretary ASI Jharkhand chapter, organizing secretary Jasicon 19, PG Examiner, and various publications in national and international journals. I request our chairpersons to welcome our speaker, Dr. Ganesh Sarin, who is a surgeon at UK. Sir has an MS and FRCS, working in UK since 1990 with special interest in vascular diseases and spent more than 25 years in this specialty. I request our moderators to welcome our speaker.
I think I'll take it on. First of all, well, thank you, Dr. Sadbhi, for such a nice introduction. And of course, my co-chairperson, Dr. Sheetal Malua. It's a pleasure. It's a pleasure interacting with you. And now, of course, Dr. Ganesh Sarin, a vascular surgeon from UK, more than, since 1990 almost. That makes it 30 years of experience in the field, 25 as a vascular surgeon. Now, I think without much ado, maybe request you, Dr. Ganesh Sarin, to take on the stage. So, all yours.
Thank you very much, Dr. Roy. I will just get my presentation if I can.
Ganesh, you can.
Oh, Rakesh bhai, namaskar.
खूब खुश रहिए.
Just going to get this. Has it gone?
Go ahead, you are audible.
Yeah, I'm available. I'm just getting my presentation onto that the screen.
Dr. Ganesh, where exactly in UK are you?
I'm in Manchester.
Manchester. Okay, great. Yeah, great, sir.
Sorry,
I keep telling Ganesh is a friend, and England is my next home. Whenever I go to England,
Ganesh, you need to just have that green icon, share the screen. Please share your screen. Have you opened your presentation? Yeah.
Open your PPT, sir. Minimize this and open your PPT, PowerPoint presentation.
On the desktop.
Yeah. Just minimize this.
You can minimize this.
Minimize. Yeah.
Yeah.
Excellent.
Oh, thank you.
Done.
Thank you, Anand. Am I there?
Just maximize
Yes,
your screens. Just maximize your screen. Yes.
Yes, sir. Yes, sir. Go
Am
ahead.
I there?
Yes,
Yes,
sir.
you are.
It's the presentation there. Well, let me first of all thank Arunima Sunil for giving this opportunity in Jasicon and all the team members for organizing such a wonderful event, especially in this difficult scenario. I thoroughly enjoyed today's session. Very, very informative. So coming to the topic of chronic lower limb ischemia, peripheral vascular disease, has been one of my specialty, and I try to look at the Indian perspective, where we are, how the future is going to be. I'm glad such eminent persons like Dr. Roy, he's already there. Probably there will be a good future for the vascular specialty in due course. So there are two ways to present: intermittent claudication and chronic limb-threatening ischemia, what we used to call CLI, and now it has been nomenclatured to CLTI. Intermittent claudication is over, I would say, 95% presentation of the patient with chronic ischemia, and 2 to 5% of them will present with CLTI, which I will be showing in the later part of my presentation. So this is very interesting to look at the epidemiology. In the population age group between 50 to 75, 70 plus, 5% will have intermittent claudication. And what we see as a symptomatic patient, nearly equal amount or slightly more are under the tip of the iceberg. They are asymptomatic. So 8% of this age group are asymptomatic patients. The interesting thing to be looked at, a few of the data, is that 5% of the claudicants, they will progress to critical ischemia every year if they are not, dealt with. 75% will remain stable, which is good news. Overall, 3/4 of them will remain stable if they are, provided with sort of advice and medications. And peripheral vascular disease, is the single most important independent factor for risk factor for cardiovascular disease. This is another thing to be looked at, that 5-year follow-up, 10% of the claudicants and nearly half of the patient with CLI will have a major amputation. And similarly, 20% of the claudicants and 50% with CLI will usually die of cardiovascular event. Now, if you look at these are the risk factors: the age, male sex, hypertension, hypercholesteremia, diabetes, and smoking. And if I look at the Indian perspective, as per data, it shows that by 2050, there will be about 20% of the population above the age group of 60. Around 120 million people are a smoker. Hypertension is prevalent in about 54 million, and diabetes in urban population is about 15%. So if you look at all those things, probably this is a thing which need to be looked at very carefully in future perspective, how we are going to look after our population. And this is because of the atheromatous disease, the same philosophy, same etiology, same pathology. If you look at coronary artery disease, peripheral vascular disease, and cerebrovascular disease, which is like a TIA or stroke, there's a significant overlap because the disease etiology, pathology is exactly the same. It is atheromatous process. So interesting to see that this process of atherosclerosis starts very early in the life. Fatty streak, progress to fibrous plaque, deposition and of collagen, proliferation of smooth muscles, and then complicated lesions. And this is a nice slide which shows that deposition of the fat as a foam cell starts almost around first decade of life. And if you look at the sedentary lifestyle, fast food, childhood obesity, we can correlate how the things are probably going to be frightening in the future to come. Similarly, intermediate lesion, then atheroma starts forming. We can see that there is a deposition of plaque, and then finally this ulcerate, breaking the endothelium, and then deposition of the thrombosis, causing gradual cycle of occlusion, and then thromboembolic episodes. So as I was talking before, there are two ways to present: intermittent claudication, which is pain, ache, fatigue in buttock, thigh, or calf, or foot, exacerbated by exercise, relieved by rest, and sight correlates with the lesion. Rest pain is pain paresthesia, exacerbated by supine position or leg elevation, relieved by dependency, persistent pain with ischemia. And this rest pain, if it persists for more than 2 weeks, requiring narcotic analgesics, not being relieved, that again is classed as significant progress towards CLI. This slide basically presents us that if person has got aortoiliac disease, they will present with buttock and thigh claudication. With femoral and superficial femoral artery disease or profunda, they will present with thigh and calf claudication, and with popliteal, they will present with calf and foot claudication. So a good medical clinical history, which will be guiding us through that, where exactly we are suspecting the lesion, and I will be coming to that in the later part of my presentation. So when we ask the patient, is 3 things which matters: when did the symptoms of claudication start, how long it has been going for, what is their claudication distance, and what do they do to get it relieved. If you look at the chronic limb ischemia, CLI or CLTI, which we're talking about, all these risk factors are there: claudication, diabetes, smoker. But these are the 4 hallmarks. Either one is present or all 4 could be there, like rest pain, a non-healing ulcer, dry gangrene with absent of palpable pulses, with reduced ABPI, which I will, show it in next next few slides. So coming to the gold standard, still in this day and age, a history and clinical examination. And I always tell my juniors, detailed clinical history and clinical examination, head to toe, will give you enough information what's happening. Simple example of pain of claudication coming from a spinal claudication or osteoarthritic pain. Patient will tell when the pain starts, what is the exacerbating factor, what are the relieving factor. We do come across, sometimes patient will say that, I've been started on this medication and suddenly I have found that, I'm getting these pains, and they have been started on statins. Handheld Doppler, which is a bread and butter of the vascular surgeons, is a very handy tool, and this gives you good significant information as an initial management of these patients. Berger test, I mean, that is for basically for academic reasons and for your exam purposes. I don't do it at the bedside, but it's an interesting test which shows the the level of circulation. Hello. So these are the. So this is the patient in his late 80s. He was having sort of features of chronic ischemia. You can look at the skin, brittle nail, and then he presented with ischemic toe. Diabetic with almost nasty foot ulcer, almost lost few toes. They have got neuropathy, so it was completely, painless. Dry ischemic gangrene. Here is a diabetic guy with a ulcer of the dorsum of the foot, and this was the guy who had, looks like an embolic ischemic episode affecting his little toe, and the fourth toe is not far behind. So when we have seen the patient, what investigative tools have we got in our hand? One is arterial duplex, which is a non-invasive investigation, and it gives you almost over 95-97% of the information what you require. But this is operator dependent. And then we have got the tool what we call angiogram, which are MR, CT, digital subtraction angiography, and CO2 angiography. MR is currently the investigation of choice because there's no radiation involved to the patient. And DSA we normally do, if we are planning to do any intervention, then we do single leg DSA and then proceed with the intervention. CO2 angiography is basically, CO2 is a contrast which is non-ionizing. Baseline investigation, full blood count, lipid profile, ECG and echocardiogram are very, very informative. That will give you more information what's going on. Now there are a few slides which I have shown here. This is the MR angiogram, which is showing common femoral artery is patent. Superficial femoral is occluded in whole of its length on both sides. And look at the profunda, which is very well collateralized, almost taken over the circulation. And collateralization is the mainstay in the long-term management in the patient with peripheral vascular disease. These are the DSA, which is showing the same picture here, long segment SFA occlusion, and here there is a right common iliac artery is occluded. Duplex, as I was talking about, it gives very good information. If you look at the wall here, we can see there are some calcifications. We can see a good flow, a stenotic segment. We can see a post-stenotic dilatation with a lot of eddy current. And I think some of the centers, especially in Northeast, they even operate on the finding of this non-invasive investigation, which is duplex, which is so appropriate and accurate, provided it is done by the right person with the right training. So coming to the management, I mean, intermittent claudication, medical or conservative management is the treatment of choice, which includes aspirin, clopidogrel, which are a group of antiplatelets, statin, modification of lifestyle, a supervised exercise program, and we provide naftidofuryl and silestazole. I mean, basically in the medical management, these are the medication which are there at hand, which is aspirin, clopidogrel, statin, and these ones, naftidofuryl and silestazole. We don't exhaust all these in one go. We start with aspirin and clopidogrel, aspirin or clopidogrel and statin, and naftidofuryl if their claudication distance hasn't improved. Chronic critical limb ischemia, very rarely for short distance claudicants if their symptoms are not improving or they're interfering with their lifestyle. But usually for CLI, there are two modalities of treatment available. One is endovascular intervention, which includes angioplasties and stents, and vascular reconstruction, which includes anatomical or extra anatomical bypass graft. Thrombolysis, embolectomy are still needed at times, especially in acute episodes, and non-salvageable limbs land up with amputations. The graft material, just briefly go about the three types of graft material which are in common use. Autologous is patient's vein graft, synthetic is PTFE and Dacron, and biological graft is still they are very, very costly, very limited use, and we normally use if their synthetic graft has been infected and then we have to do something to salvage their limb, then we use the biological graft. So just going to the anatomical, like aorto bifemoral graft or femoropopliteal graft, or from femur to crural vessel, which is femorodistal graft. These are in the anatomical distribution of the vascular system. Extra anatomical, if the patient is not suitable to undergo major vascular reconstruction, then either we use an axillobifemoral or unifemoral or a fem-fem crossover bypass graft. These are extra anatomical grafts. They don't last so long. So my friends, to conclude, I'll just give you a small flow chart. Management of intermittent claudication. Basically non-invasive assessment, which includes like handheld Doppler or maybe a duplex, then modification of risk factor, and patient coming to non-intervention justified, exercise program, stable, improved, discharge. If their symptom worse, then they come to this group who will need some intervention, get either duplex or angiography, and then proceed to bypass or angioplasty. For patient with critical ischemia, look at whether the limb is salvageable or limb is non-salvageable. If salvageable, investigations, angiogram, either they need angioplasty or a bypass. If it heals, fair enough. If it doesn't heal, then they'll land up in this group. And non-salvageable, if patient is moribund, then just keep them comfortable with analgesia. If patient is fit, then amputation is required. Thank you very much. Thanks. Any questions?
Thank you, sir. This is Dr. Rai here. Yes, we can, with your permission, Dr. Sareen, could we have some questions?
Definitely, yes. Thank
you. Could we request some questions from
Thank you, sir. Thank you.
Yeah, please.
Ganesh, one question. How does, what is the role of salestazole? In which kind of chronic limb ischemia you people have been using salestazole, and what dose, and what is the outcome?
Solestazole is like a 5-alpha reductase inhibitor. I mean, there's a lot of different, pharmacology they act. We use it in patients with claudication when we have tried them with antiplatelets, anistatin, and their symptoms haven't improved. I think they have got three roles. They lower the cholesterol. They also do a bit of vasodilation, and that is used as a second line of treatment before patient goes for any vascular reconstruction. So we normally use in a dose of 100 milligram 3 times a day.
One more question, with the permission of chair. When I was with you almost 20 years back, we used to do a lot of femorodistal bypasses. With 8 hour surgery,
Yeah.
graft failure, all those. What is the incidence of this femorodistal graft now with the advent of interventional radiology now?
It is, I must say, Sunil, I mean, I will just go back to one of the answer to a query that when we were medical graduates, we were told that big surgeons make big incisions. Now big surgeons make a small incision. So there are endovascular intervention which are done even approaching through the dorsalis pedis artery. So they do the railroad technique and do even crural vessel angioplasty. So femdistal bypass is, I would say, probably is gone.
So can I have a minute?
Yes.
Dr. Srivastava here.
Yes, Rakesh bhai.
So Ganesh, you owe something to be paid to your Bihar and now Jharkhand. And since you have already given a very thought-provoking discussion of the topic, and Dr. Rai is here as GM of Tata, so can I give a philosophy to two of you and a responsibility?
Yes.
Can you just tailor make a program for Jharkhand, at least in 3 or 4 big cities, how to approach vascular disease, peripheral vascular disease, and what are the resources with us? We will come out, we will spell out, and you please, you guide from there, and Dr. I is here, locally available, and we will leave no stone unturned, so that we make a program and we advance on that.
Yeah, that will be very nice, Rakesh bhai. I think, with the support of Dr. Roy and, all the team in there, that's not a big issue.
He is Dr. Rai. He's not Dr. Roy.
Dr. Rai, yes.
He is Dr. Rai.
RAI, yes.
RAI, yes.
Yes.
Let's hear from what Dr. Sudhir Rai has his view, sir.
No, thank you all of you. I think it is very, very valid because vascular surgery, peripheral vascular surgery, or rather, let me go ahead and say endovascular and vascular surgery, because it is now so intertwined and it's so important. And unfortunately, we do not have a dedicated vascular unit in Jharkhand. When I was heading the vascular department at Command Hospital in Calcutta.
Sorry for interruption, Dr. Sareen.
Oh, you're mute, Dr. Mola. Dr. Mola is mute.
Dr. Mola, you cannot be heard. Could we request you to unmute your mic?
Okay. So I'm Dr. Malwa from RIMS Ranchi. So we have a dedicated team at RIMS and Ranchi. If you get times to do, please visit our RIMS and you can have a talk with us. We are there to solve the problems of our Jharkhand. It's very problematic conditions, really very problematic, lower limb ischemia.
Well, I don't think this is problematic, Dr. Mola, because if I look back, I was in Ranchi, in Rajendra Medical College in 1985-86, when I was doing my diploma anesthesia there.
I see.
Yes, and then I did my post-graduation from Patna. What it was, that it was vascular was not heard of. So a patient will come and they will be usually diagnosed either with Burgers
or Burgers or Reynolds. That's the only thing.
Yeah, because we didn't have any tools, and it is not very costly tools. Tools are handheld Doppler, which cost about 10,000 rupees or 20,000 or something like that. I don't know exactly. And a duplex scan with people can do. And
that was in our time, and I am aware that RIMS has a vascular unit. But let's
Yes,
very
we
good,
have.
very good to know, Sunil. I must say, you know, looking at the population, and it is very good to know
sure.
that things are.
What I'm trying to say, we have a leadership position with in terms of Dr. Sudhir Rai, who is here in Jamshedpur. Let's hear his vision. He is very keen to establish and promote vascular activity, which also I have. So let's hear from the leader, Dr. Sudhir Rai. Sir, please, your vision.
Okay.
Dr. Sunil, yes, we must go ahead, and I'm so glad to know that we do have a vascular unit, a dedicated vascular unit at Ranchi. Wow! I mean, I would interact with the team over there. Let's see what and how could we go ahead. And I think this suggestion as to how to go and approach a case of peripheral arterial occlusive disease. How
That's what
if we
exactly
can
I said.
have a few sessions nowadays online and maybe some workshops, I think it would be a big step forward. Thank you.
Thank you.
We organize
Thank
that.
you.
We organize that.
Thank you, Dr. Farid, for excellent coverage. Thank you.
Thank you very much.
Onima, you
Thank
take
you.
over.
Yeah. Yes, Satvir, please present the certificates.
Thank you very much, sir. Thank you, Dr. Ganesh Sarin, for giving such a illustrative on vascular things and chronic limb ischemia. We are very well enriched with it. Please accept this e-token from our side, from Jasicon.
Thank you very much. Thank you.
And I am very glad that I met Dr. Sudhir. I had a very good chat with him. I am so blessed to be here with us. Thank you, Dr. Sudhir Rai.
Thank you, Dr. Satvir.
Okay. Billu tum theek ho na?
Thank you, Dr. Sheetal Malwa. I always call him as Malwa uncle, and now I am calling him as a sir. But I have the same bonding with him as since childhood. Thank you, Dr. Malwa.
Thank you, and thank you, Dr. Sain, once again for such a lovely talk.
Thank you very much, sir. Thank you.
I would request Dr. Sudhir Rai to please stay on for the valedictory function, because we would be happy to hear a few more words from you, sir. And yes, sir. Are you saying something, Dr. Sunil?
No, I want everybody should stay behind, but including Ganesh Shareen and Dr. Sudhir Rai, of course, you have requested, and rest of us, of course, we are staying behind.
Yes, I think Dr. Sudhir Rai is there. Dr. Sanjay Kumar has also joined in. Dr. Bakhla should be there. I think these are premier institutes. So together, I think we should be on this platform so that at the end we can have a few discussions. Thank you, everybody, for being a part of this conference. And now that we come to the end of this almost 2.5 days conference, we go on to our valedictory function. And to start the valedictory function, many of the participants are waiting to hear the results of the award sessions. So I would hand over to the session in charges, because this has been a very impartial judgment from judges from all across. And the results have been made by the session in charges. So I would let the session in charges declare the results. So to start with, I think Satvir, you can start with declaring the results of your session.
Yes, to start with, I will be declaring the results of winners for the best poster session, which are: third prize goes to Dr. Syed Sharik.
Is Dr. Syed Sharik there?
Dr. Syed Sharik?
If you are there, you can just say yes so that we can have your visual.
I was unable to connect with him.
Okay, anyways, go ahead.
Second prize goes to Dr. Chandan Kumar.
Yeah. Thank you, sir.
Excellent.
Thank you, sir.
And Dr. Chandan Kumar is Dr. Arunyama's madam's dear student.
That's very
And
nice.
the third and the first prize goes to Dr. Avinash Kumar Sinha.
Yeah.
Thank you, sir.
Avinash Kumar Sinha from which institute? RIMS.
Yes, Satvir, please tell the institute also.
Sir, Bokaro General Hospital, sir. Bokaro General Hospital, sir.
Okay, Bokaro General Hospital. Great.
Bokaro. Very nice.
Okay.
It's Bokaro General Hospital.
Okay, great.
Now I
Yes,
will be
Sumekha.
I will be announcing the result of best PG paper. The third prize goes to Dr. M. Mahesh.
Please announce the institute as well, Sumekha.
He is DNB student from CMH.
Okay.
Congratulations, Dr. Mahesh, if you are there.
Dr. Mahesh, are you there? Okay.
Okay, now second prize goes to Dr. Apurv Kumar Nayak.
Apurv Nayak, Vinay sir ka Puji.
Which institute?
He is from RIMS. Congratulations, Dr. Apurv. This is your prize. You will be getting an original outfit. And the third prize, first prize goes to Dr. Shubham. He is from, I think, BGH. He is also a DNB student.
Okay.
Dr. Shubham, are you there?
Okay, fine. We can go ahead, Sumekha.
So I have announced my part.
Yeah, please. We asked Dr. Sushil had to go for his surgeon on call duty, so Satvir will do his part.
Yes, ma'am. So, winners for the best paper session are Dr. Tanmay Prasad, third prize.
Is Dr. Tanmay there?
I don't have the details of it because Dr. Sushil was in charge of it. Dr.
Okay.
Tanmay Prasad, Dr. Sumit, second prize.
Sumit, are you there?
Yes, Sumit is from Sahebganj. He is a MCH urology. Yeah.
And Dr. Sanjay Kumar Yadav, first prize.
Yes. Sanjay, are you there?
Yes, ma'am. Yes, I am here.
Congratulations, Sanjay.
Thank you, ma'am, and thank you for giving this opportunity. And it was very wonderful. I attended almost 85% of the conference. It was
Thank you,
really
sir.
wonderful. Thank you.
Thank you, Sanjay. Yes, okay, Satvir. Now we again go back to Dr. Sumit. He has to announce his best video session. Dr. Sumit, are you there?
Sumit is not there.
Okay, so Satvir, please announce. It's only one prize for the best video session. So, can you announce that, or I would announce that?
You announce.
So the best video session award goes to Dr. Anshuman Dev. So Dr. Anshuman Dev presented laparoscopic lateral pancreaticojejunostomy, and the best video goes to him. Is Dr. Anshuman there? So just because we have already announced all the prizes, I would just like to say that we would deliver all these trophies to the winners, to their institutes, and from their institutes, it would be given to them. Rachi, I think I would deliver it myself in the end of this month. Bokaro, I think we'll find somebody to deliver it to Bokaro, and Jamshedpur would get it immediately. Yes, so now we move ahead. Sunil sir, I would want you to say a few words, and then we can have some vision from Dr. Sudhir Rai, Dr. Sanjay Kumar, and Dr. Bakla.
No, it's now valedictory, isn't it?
Yes, sir.
Yeah. Thank you very much for gracing the occasion. It has been a wonderful 2 days, and I must thank Dr. Arunima, under whose leadership the whole thing has gone. Because from the actual to virtual we have gone, but we are little less in that. But Arunima, thank you very much for your dynamic leadership with your team. You have got some few young like Satvir, Sumekha, and Sumit, and two of others who have really helped, and the ASI Jharkhand chapter, plus all the stalwarts who have joined from nationally recognized, from some of the people from internationally, including my friend Ganesh Shareen. And I'm thankful to Dr. Rajan Chaudhary, who joined yesterday, and Dr. Sudhir Rai sir, who has just come in a leadership position. And a general manager of Tata Main Hospital is someone who can guide and lead and throw us light and try and give some resources so that the surgical fraternity moves on. And also my dear friend Sanjay, who is heading Tata Motors, and with myself, Dr. Sanjay, Dr. Sudhir Rai, Arunima, and rest of the ASI Jharkhand chapter, we can collaborate together to take the surgical fraternity to a new height and also try and establish vascular in itself, because when I came from England from 20 years ago, I've been trying to inculcate this vascular thing into the system. I have not been very, successful. With you as a vascular input, I'm sure things will be better. So again, thank you very much, everybody, and then back to Arunima.
Yes, sir. Since this is valedictory, I would want Dr. Sudhir Rai to express his views.
Thank you, Dr. Arunima. Actually, a valedictory is always the last function of the whole event. And all the same, thank you very much. I mean, it's been such a honor and a privilege, rather, I would say, to have been invited to chair a session and to in a virtual mode to meet up with at least a few people and dignitaries over here. I mean, it's been a privilege, no doubt about it. And looking forward to more of an interaction in future, maybe less in the virtual mode and more in a face-to-face mode. And definitely, I'll take all the occasions and opportunities to come and meet up with people. And we look forward to moving ahead together, as Dr. Sunil has said. And my heartiest congratulations to Dr. Sunil, to yourself, Dr. Arunima, to your whole team for having done such a great show. The first time, I think you've had a virtual Jasicon. Yeah. Thank you.
Thank you so much, sir. Can I ask Dr. Bakla to say a few words?
Oh, yes, Arunima.
Yes,
I must congratulate you and Dr. Sunil for having such an excellent virtual conference in this Corona regime, in this Corona time. And you have excelled in your time. You have arranged all the speakers, very wonderfully speakers in this session. So I must congratulate you. Once more, I congratulations to and also the participants of your team. Thank you.
Thank you so much. Dr. Sanjay, sir, are you there?
Yeah, yes, Arunima.
Yes, sir. Please, a few words from you.
Yeah, Arunima, first, I congratulate and compliment you and Dr. Sunil, sir, for a wonderful show, and your entire team. And the way this virtual conference is was organized and addressed in this difficult time speaks volume of the effort all of you have made. And I also congratulate the new team who is going to take over, and you being the chairman for the next year. We expect lots of activities throughout the year. Also, I congratulate all the winners, because I have seen these academic sessions and the presentations by our postgraduate residents. It was par excellence. So again, congratulations to all the winners, including Chandan from Tata Motors Hospital, because the way they have presented and the content of their presentation was extremely good. And overall, the learning what we had throughout the session, because the wonderful speakers, Dr. Chintamani, Dr. Ganesh Sarin, and many others, Dr. Makhanla Saha. So a big congratulations once again for the wonderful show. Thank you very much.
Thank you so much, sir. And I think since all the three of you are here from the premier institutes of Jharkhand, I think I would need all your support to take the academic activities of Jharkhand ahead throughout the year. I'm looking forward to all of you to support me. Thank you very much. Now I request Dr. Uday Srivastava to say a few words.
Oh, but Arunima, you have taken over as a chairperson for the ASI Jharkhand chapter. You are the first surgeon of the whole Jharkhand, so we all support you, but you have to take us quite far. Yes, Uday, of course.
Yes, sir. Uday, sir. Please say a few words, Dr. Uday.
Is Uday there? I don't see him logged in.
Dr. Uday, are you there? Dr. Azad?
Okay. So,
is Dr. Azad there?
No, it's not there. You can ask Pankaj Bodra.
Okay, Dr. R.P. Srivastava, sir. can we have a few words from you?
No. Don't ask RP. He's the last word. So ask Pankaj Bodra first, then Nalin Kant Chaudhary.
Yes. Yes, sir. Please, now I think, sir, Sunil, sir, you can help me out. Yes,
Yeah,
Pankaj,
Dr.
sir, please say a few words. And I think our treasurer is hiding behind Dr. Pankaj Bodra. We would want him as well to say a few things. Yes,
Let's
sir.
start with Pankaj first. Yeah.
Yes, ma'am.
Pankaj.
Okay. Hello. Yes, sir. Dr.
Yeah,
Nishit is with me. You want to speak something?
Pankaj to say a few words, then Nishit.
No, sir. We are enjoying the valedictory function, sir. We had a banquet yesterday evening, and now we are having a valedictory lunch we had. So we are enjoying the conference to the limit.
Thank you very much.
You
So
just.
we will send the bills, sir, to the organizing committee.
Thank you very much. Thank you very much. Dr. Nalini Kant Chaudhary, few words of wisdom from you.
Yeah. Thanks a lot, Dr. Arunima, Sunil sir, and RP Srivastava sir, all organizers, and all the young surgeons who have participated and organized this beautiful function. And we are enjoying here also. And
Thank you very much. We are
Arunima,
nevertheless.
well, in a new as a president, as chairman for 2020-21.
Thank you very much. Thanks very
Thank
much.
you again.
Thank you.
Thank you,
Dr. Nalini Kant, few words of wisdom.
Hello.
From you.
Yes, I'm audible.
Past ASI chairman of Jharkhand chapter and a very recognized surgeon from Bokaro and Jharkhand.
Am I audible?
Yes, sir. Go on.
First of all, congratulations, Dr. Arunima, for ascending to the post of chairman Jharkhand chapter. Hello.
Yes, go on.
कुछ लाइनें
Yes,
मैं
sir. Thank you
कहूँगा
very much. Please go ahead.
मैं कुछ लाइनें कहूँगा गुर्बतें भी दूरियां का बन गई अक्सर सबब इसलिए बेहतर है कोरोना की बेरुखी बाकी रहे और दूसरा ये दूरियां भी मंजूर है मुझे वर्चुअल मुलाकातें यूं ही चलता रहे थैंक यू सर वेरी गुड वेरी नाइसली organized virtual conference and the first ever maiden experience for us.
Very nice. Before I invite RP Srivastava, anybody else who wants to share something for us?
I think we should ask our session in charges to say a few words. They have worked very hard. I want to say a big thank you to Satvir, Sumekha, Sumit, and Dr. Sushil. Dr. Sushil might have joined in. And I want each of them to say a few words at least. Can we start with Satvir? And Satvir is sitting with his father. And sir, welcome to Jasicon. He is also a very renowned surgeon from Hazaribagh.
आपका बेटा बहुत अच्छा कर रहा है सर जी.
Thank you very much.
Huge potential.
Thank you very much.
Yes, Satvir, please say a few words.
I will start from the start. The day I came to Hazaribagh before lockdown, I was not very sure and very confident that I will be able to work here and give my best. But after that, lockdown happened, and I started slowly working in between the lockdown. And then there was an APSI conference where I had a chance to talk to Dr. Arunima ma'am. And there I presented one of the paper that was a very difficult presentation, but still madam gave me a chance and I presented. And through that, I came in contact with Dr. Arunima ma'am. She guided me well through the session. And after that, I was in touch with her continuous. And then my guru, Dr. Rakesh Srivastava sir, called me up one day and said that I am giving 5 people to Dr. Arunima ma'am for making this conference a success, and you are one of them. And I hope that you keep my name and make it to the fullest. And I think I did whatever I could, and I'm very thankful to it. And I am very, very lucky to know such great surgeons of Jharkhand. Because I never did any kind of education in Jharkhand, so I am not in touch with anyone. But I have been traveled all over India, various states. So I have connections with them in other states, but I am very happy to meet everyone in the next conferences or simultaneously in any meetings. Thank you, Sunil sir. Thank you, Arunima ma'am, and thank you, Dr. Rakesh, for giving me this opportunity. And I hope I carry on like this for the next coming years.
Yes, Satvir, you are an asset to Jharkhand ASI chapter. So ASI Jharkhand chapter, we look forward to having more from you. Sumegha, are you there?
Yes, ma'am, I'm here. I thank first of all, especially you and all the team, whole team, Sunil sir, all the senior teachers and my mentors from RIMS, Pankaj sir, Bakla sir, Malwa sir, Vinay sir, and all each and every person who are a part of this platform. And I thank everyone, and I'm really obliged and really thankful to everyone for giving me this chance to be a part of this conference. And I definitely look forward for the next Jasicon 2021 at Hazaribagh. That will definitely be a good one, and we will soon meet in person.
Thank you, Sumegha. Do we have Sumit? Is Sumit and Dr. Sushil there? I think they are not there. So,
hi, I'm there.
yeah.
Hello.
Yes, Dr. Sushil, please.
Good evening, everybody. In 2018 we had organized the Jasicon at Daltonganj. तो उस वक्त करने में जो ऑर्गेनाइजर्स को जो थोड़ी टेंशन होती है, पेट में जो बटरफ्लाईज रहते हैं ना, वो मुझे इस बार हो गया यहाँ बैठे बैठे. तो ये पहली बार हुआ कि कॉन्फ्रेंस जमशेदपुर में हो रहा है और बटरफ्लाईज इधर डाल्टनगंज और हजारीबाग और इधर उधर हो रहे हैं. सो बट इट वाज वेरी नाइस एनीवे. और ये सतवीर, सुमेघा, सुमित, ये सबसे बहुत अच्छी बॉन्डिंग हो गई बात करने के इसमें सिलसिले में. इट वाज वेरी नाइस. I thank Srivastava sir, Dr. Arunima madam, Sunil sir for giving me the opportunity. It was a very lovely. I was very skeptical, but all is well that ends well. It was very nice, very unique for me too.
Thank you. Very nice. Anybody else who wants to speak before I call R.P. Srivastava, who is the patron? And Arunima, on your behalf, you are the chairperson. We'll invite Dr. Sudhir Rai for the guest faculty in the next Jasicon in Hazaribagh. Sir, I'm sure Dr. Sudhir Rai will accept that invitation. Next year is the Hazaribagh ASI Jharkhand chapter. You'll be our esteemed guest faculty there, sir.
Thank you.
Thank you. And anybody else, if before I call, I can see one of our very good DNB who passed from here, from Calcutta, now doing his MCH in South, Swavik Chandra. Are you there? Can you unmute, speak a few words?
Yes, sir, I'm here, sir.
Can you make yourself visible?
Am I visible, sir?
Yes, yes. Swavik, nice to see you. How is Belgaum?
Nice to see you, sir. I'm doing good, sir. I must I would like to say that it's been a good, very good conference as usual, headed by you and Arunima ma'am. In the past few years, whatever I have seen, you have taken the education level in Jharkhand to such a great height, sir. It's nice to see a very good association blooming and becoming more better day by day. Thank you, sir.
Okay. So which year in Tata Main Hospital? You did DNB with us, na? With us and Arunima, na? Which year you were there in Tata Main Hospital?
From 15 to 18, sir.
Okay. Okay. Thank you, Swavik. Do well, I'm sure. So Arunima, you can invite RP to end, and then that will be the end of it. You need to unmute yourself, Arunima.
Okay, so if nobody else has to say anything, we will ask Dr. RP sir to conclude the session.
Concluding the session, which was so vibrant for 2.5 days, is a giant responsibility which you have thrown on my shoulder.
Yes.
But
yes.
I'll try to do justice, Sunil. Welcome, Dr. Sudhir Rai. My first interaction with you. Maybe that we have interacted on the platform of ASI sometime, but I don't recollect. Once we meet, then we will be able to sort it out. So welcome to the land of activity in Jharkhand and the land of paucity, but the services needed are in full galore. And I'm very happy. That's why I threw that philosophy in the lecture of Ganesh, that you and Ganesh can tailor make a program for Jharkhand, because everybody says we have the facility, but of no use. So having said that, I'm so proud at in only 1.5 months time, when at ABSI, after ABSI meeting, we threw the challenge on Sunil and Arunima that since we are not going to have a physical conference this year in Hazaribagh, it is your ardent responsibility. We didn't ask them, we didn't ask them. That's how Jharkhand chapter is. It's a family. We didn't ask them. We just said that no, you have to do the virtual conference like you have done the smaller setup ABSI. One day you have to do 2.5 days conference, 2 days conference. Then it is spread to 2.5 days conference. And you have not let the chapter, not let the members down. All your humility, Sunil otherwise will be aggressive, but I find a lot of maturity in him, and I'm proud of him that he has really risen to the challenge of leading from the front. He has been leading from the front, but he will be very aggressive. And now I find that yes, here is the time, Sunil, the leadership in you is bubbling, and I'm so happy that one day I'm seeing you in future leading ASI from being in Jharkhand. That's my wish. Arunima, I still give the notation to you that
Yes,
this
sir.
girl is just dynamic. She is a dynamite on academic front. I mean, she didn't pursue the path of academics in any of the medical college here, but she went to a service hospital where the academics was there in the form of National Board Education, and she pursued her career there. She kept herself absolutely glued to the academic achievements, academic excellence, and tried to be a good teacher. She trained herself well, and today, everywhere, I'm so proud throughout 2.5 day session. Every session will end thanks to Arunima and Dr. Sunil, and I will feel real backseat pride. Oh, that's it, that's it, that's it, that's it. And this is what has been a real moment of galore for me. I'm so happy. I'm so rich now. As usual in valedictory function, you will not find people like Uday and Ajad and Jugal, since they are from far-flung areas. So they had to drive back home, and so they left even the virtual platform early. So that was just the lighter side of it. They should have stayed here in the virtual platform, but they will always explain that, oh, हमको गिरिडीह जाना था, हमको रामगढ़ जाना था, हमको देवघर जाना था, and हमको साहेबगंज जाना था. हमारा अपना बच्चा सुमित, तो विजय जी को चूंकि उनके ऑल फैसिलिटीज यहाँ नहीं थे, तो विजय जी अपने बेटे को भी लेके चले गए. सो कोई बात नहीं, ये चलता है. बट हम इस बात से खुश हैं कि जो सपना कभी मैंने झारखंड चैप्टर के लिए देखा था कि एक दिन ऐसा आएगा जब हम सब लोग एक सूत्र से बंधे रहेंगे. भले ही ये वर्चुअल प्लेटफॉर्म आया, बट सुनील, आपने और अरुणिमा, तुमने ये दिखा दिया कि हम कैसे बांध सकते हैं सबको एक साथ, और लोगों के नहीं चाहने और नहीं बहुत ज्यादा विलिंग होने के बावजूद हम उनको एकदम से पैक रख सकते हैं, और सब लोग अपने अपने घरों में ही सही लेकिन बंधे रहे. आई एम रियली थैंकफुल टू द delegates also, and the people who presented, the people who have been awarded. I will request the new awardees to join the ASI if they have not. If they have joined already, they should, the moment they pass, they should send their certificates to the headquarters to convert their life associate membership to full life membership. That's what Siddesh was talking. Siddesh was talking what I had been practicing almost 20 years for this chapter to be brought up. Having said that, dear, mind is full, words are few. I'm feeling that what is happening tomorrow, what will I do? It was so full 2.5 days. Tomorrow, what will be my activity? So this is what is the success of the program you people have crafted, carved, and executed. Long live Jharkhand chapter ASI, long live ASI, and long live our relationship.
Thank you. Thank you. Renew a vote of thanks. If nobody is speaking, thank website team also.
Yes, sir. I would
Oh,
like
yes.
to.
Oh, yes. One second. Anand,
Yes, sir.
sitting in Mysore, you and your team has done wonders. आनंद, तुमने पूरे कॉन्फ्रेंस में जान डाल के बहुत आनंद हमें दिया और इस बात के लिए ईश्वर तुम्हारा बहुत ख्याल रखेंगे.
I think
Thank you, sir.
Anand should
Thank you.
unmute himself and say a few words. Anand, please, because you were a part of the organizing team. So, Anand,
Thank you, sir. Thank you, madam. Thank you, Sunil sir.
you can put your camera on.
Yeah.
Come on live, Anand. You always come with a DP.
You can remove the virtual background because we can't see you. Yes.
Yeah. Yes.
Yeah.
Yes.
Here you are.
Yes, and Sachin is there.
Thank
That's
you, sir.
his team.
Thank you so much for giving me
Sachin, you can
opportunity.
also join in.
Sure.
Yes.
Thank you, sir. So I thank everyone, ASI Jharkhand, because you people have given me a first website, then ABSI, then other association work also, and now this also to success with you all. And also I have learned many things with you all, working with you all. So thank you so much for giving us opportunity. So I promise that we will work more in future and we will do much things. Thank you so much, sir. Thank you all. Thank you, madam.
Thank you, Anand. Thank you, Sachin, and convey my thanks to
Sabha.
Sabha as well.
Thank you.
Yes, Arunima.
Yes, so now that we come to the end of this session, we have had a wonderful 2.5 days academic bonanza. We also had a small cultural program. Everybody enjoyed a lot. We had a lot of hard work put in by everyone, not just the organizers, but also the participants, because we made them practice their sessions. So thank you everyone, each and every delegate, for being a part of this conference, all the organizing committee. I have thanked all the session in charges already. I thank all the chairpersons, the judges. They have sat through all sessions and it was a very difficult task that they have done. And we have got the right candidate who has got the prize, who can represent Jharkhand state chapter in the main Jasicon. I thank the website team. Thank you, Sunil sir. And thank you, Rakesh sir, for guiding me throughout. Thank you, Dr. Azad and Dr. Uday, though they are not here. And we finally conclude this meeting. Excuse us for any lapses. We would try to be better next time.
Most important is that we must thank Dr. Sudhir Rai, who is the new to Jamshedpur, and he has shown that initiative to be with us, and so his inclination to try and take us through and lead the surgical and especially the vascular things. So thank you very much, Dr. Sudhir. I have not interacted much with you, but I keep a track on you, sir. So we will work much more to take you in the surgical fraternity of Jharkhand.
Thank
Yes.
you. Thank you very
Yes,
much. What a pleasure.
thanks to all the premier institutes, including RIMS, TMH, Tata Motors Hospital, and Bokaro General Hospital. Thank you to all the heads from that place, because the DNBs, almost all DNBs from these institutes presented. So thank you very much for your participation, and looking forward to your constant support in our activities. Thank you very much, everyone. And so we now finally end this session. Thank you, everyone. Bye.
Bye.
Thank you.
Thank you, Anima, for your wonderful job.
Thank you, sir.
Thank you.
Yes, Anand, you can end the conference now. Thank you.
Yes, madam.